We are live.
Good morning, all. It's a pleasure and honor for the Jharkhand Ophthalmological Society to welcome all the esteemed guest faculties across India of national and international fame. We have selected, am I audible?
Yeah. Quite credible.
We have selected an array of top 10 innovators of 2025 across India, along with the three judges. And these judges are also great innovators of India, like Dr. Jagdeep Kakaria. This is the second continued year of hosting JHOS Hackathon, which is very innovative session. And we are also hosting our perennial Dr. R.P. Tandon Extramural Oration session. We have none other than Dr. Vishali Gupta, who is Vice President of BRSI, and she is an internationally known figure for uvea and retina. In part one, midterm conference, we have case presentations also to keep the students motivated, and we have a very stimulating guest faculty session also, which is covering all the subspecialty of ophthalmology, because the guest faculties who are judges in the case presentation, they are from all the subspecialty, not from one subspecialty. JHOS is a small society, but its impact is always have been felt nationally. For the third time, our society has been awarded the best state society in the category of 100 to 500 members. And not only this, we were also awarded best overall society trophy at annual conference of AIUS in New Delhi 2025.
हमको कुछ काम करना है हाँ उधर तक जाएंगे
Public awareness campaign.
देखो छोटा फीचर भी लेना होगा ना
Please mute yourself.
एक उधर लगा तो एक इधर भी लगेगा
Mute yourself.
है वहाँ पे
Dr. Ajay, will you please mute?
Can you please mute yourself?
Okay, sorry.
Dr. Ajay, please mute yourself. In a historic moment of triumph for our society, Dr. Vibhuti Kashyap, a young JHOS member, has created a history at the prestigious American Academy of Retina Specialists 2025 annual meeting by clinching the highly coveted 2 Red Buckler trophies at a time for the best surgical videos submitted globally. So the society is small, but its impact is big. Now I request President of our society, Dr. Rajnikant Sinha, to inaugurate the 23rd midterm for online conference of Jharkhand Ophthalmological Society.
Hello, everybody. Welcome to this wonderful platform of knowledge sharing and innovation sharing. I welcome you all. Hello.
Sir, you are audible, sir. You
are audible, sir.
Yeah. So go ahead and start the session. All the best.
So, has our secretary, Dr. Sujay Samanta, joined from USA? I think he has some problem in joining from US.
Ma'am, he messaged that he has some internet problem. He's on the road. So he may be joining later. He sent a message in the group.
Okay. So now over to the coordinators in the conference hall. So the judges have requested that they will give their presentation, because I have kept their presentation also. So they have said that they will keep the presentation later. First, they want to listen to the top 10 innovators. Am I right, Dr.
Yes, ma'am.
Yes, madam.
This is the idea of Dr. Jagdeep. Welcome, John Davis Akara. Welcome. Dr. Kunal Mandlik has joined. Dr. Kunal, he's the judge.
Yeah, yes, madam.
Has he joined?
Yeah, yes,
Ma'am,
madam.
he's here.
I'm here.
Can't see. Dr. Kunal, please wave.
Yeah, I'm here, ma'am.
Okay.
He's here, ma'am. He's here.
So Dr. Kunal Mandlik is also going to present a lot of innovation they are doing in Arvinda. So Dr. Kunal, Dr. Jagdeep Pakadia had a suggestion that first we will take up the innovators, then the judges will present. Are you okay with that?
Yes, madam.
Okay. So we will take first Dr. Karupati because she's a resident. She has to go for her duties. Then we will take Arvind Krishna and then we will take Nishwant. Dr. Arvind Krishna, are you here?
Yes, ma'am, I'm here.
You are going to present for Dr. Nishwant also, right?
No. There is Dr. Ishwar is presenting for Nishwat. He's also here.
Dr. Nishwant has joined.
Instead of Dr. Nishwat, Ishwar, are you
Okay.
here?
Yes, ma'am. I am Dr. Ishwar. I will be presenting on behalf of Dr. Nishwat.
Okay. Because that is a very nice terrorism innovation. Everybody is very eager to listen and watch. So over to the coordinators, please.
Thank you, ma'am. Thank you very much. So we start. We get a green flag for our 23rd midterm conference of JOS. And the first session, of course, is the Stars Innovators session. And our first talk, without much delay, we would be inviting Dr. Karupati Vasavi, who would be telling about her innovation on an augmented reality glasses for children. I would request Dr. Vasavi to please start her presentation.
No. First, you have to give her introduction, please. Hello, coordinators. First, you have to give introduction of the individual doctors.
Ma'am, I have got her work as on my slides. I do not have a complete.
Yes. She did not make a slide of intro. Just
Yes,
please read.
So she is working on augmented reality glasses for children with amblyopia, and this is basically used instead of eye patch or using pharmacological substance such as atropine. These glasses gently adjust vision by changing contrast and focus to that the weaker eye gets more stimulation. And it will also focus on improving the binocular single vision, so it can be alternative to the virtual reality headsets, and also it will regulate the treatment because it works on a micro controller. So I asked Dr. Vasavi to please start her slides on her new innovation.
Timer set कर लीजिए. Timer is 7 minutes.
Okay, ma'am.
Please set the timer.
Yes, ma'am.
Good morning, Nanda. Can you see my slides?
Yes, your slides are visible. Can you go to full screen, please?
Yes, just a second. Am I audible and visible?
Yes, yeah, Dr. Vasavi, you are audible and visible. Kindly start your slides.
Good morning, Manandal. I thank Dr. Bharti ma'am for giving me this opportunity to present my innovation. So my talk is on augmented reality glasses for amblyopia, easy vision therapy for kids. So I am Dr. Vasavi. I have completed my MS ophthalmology. I'm currently a fellow in pediatric ophthalmology and strabismus and neuro-ophthalmology. So we know amblyopia is a leading cause of preventable childhood vision impairment, which is affecting 3 to 5% globally. So there are a lot of conventional treatments which are available for amblyopia, which are effective, but they have some limitations. So we are trying to innovate a child-friendly smart glasses for seamless, engaging vision recovery. So a lot of therapies were there for amblyopia. Why there is a need for this augmented reality glasses is most of the therapies are pertaining to the monocular therapies, monocular vision therapies. But there are certain therapies which focus on the binocular therapy like VR headsets, that is virtual reality headsets, but they have certain limitations, like they're not that child comfortable, not that compliant, and we can't integrate daily in the daily life, and they're not that portable. So the proposed augmented reality glasses will tick on all the boxes, so there is a need for these glasses. So our innovation is child friendly smart AR glasses that will deliver the binocular therapy through augmented reality, and they will most of the therapies are focusing on the BSV, but a lot of therapies are not focusing on the contrast and image control and pertaining to the therapy based on the each eye. So these will also be concentrated in this, and we will have a gamified and interactive task to improve the compliance of the child, and there'll be seamless integration into daily life because they look like a normal glass, and they are not stigmatizing, because most of the therapies like patching and all will cause a psychological trauma to the child. So they are not lightweight and non-stigmatizing, designed to the kids. So we know amblyopia, there is a brain ignores input from one eye, that is in simple terms. So what these AR glasses will do is they will detect the imbalance between the eyes in real time, and they will dynamically adjust the lens power and also contrast. So they'll weaken the stronger eye and strengthen the weak eye. So they will increase the usage of the weaker eye, that is the amblyopic eye, and promote the binocular single vision. So also they will increase the neural strength connections and strengthen them, and the vision will improve over the time. So this is the model. So what it does is like, so whenever the child, this is just an AI related video which based on our thing. So when the child sees, they will be like in the, not in a virtual reality, it will be an augmented reality. So this will be the simple, I can't reveal most of the things, so I will show the simple things like how the eye tracking will be done and how the orthoptic exercise. So when we display this thing, the child can track the ball. So we will do the orthoptic exercises, and we can also measure the amount of strabismus. So this is just a simple coding. So this is a child who is wearing the glasses. In real time, it will give how much is the deviation and also how much is the strabismus component in the eye. So the core components will be hardware, software, and the work therapy mode. Hardware consists of the microcontroller. We will have a dual micro OLED display which are transparent, and we are planning to integrate the liquid lenses. If not possible, we can actually have a clip-on normal lens and works on a battery. And the software will be augmented reality. This operating system will be having the Python and the OpenCV, and there will be contrast and blur display and image filters. So when the child wears the glasses, there'll be interactive binocular games, and there'll be live tracking and feedback, which will be given to the microcontroller. So we can integrate with the mobile app, which will be connected to parent and the clinician, so that the clinician through the mobile can actually adjust the therapies rather than the child visiting the hospital every time. So these are the model of the glasses. Rightly, it is the prototype development stage is ongoing coding and stimulation, and also we are developing a 3D modeling for that. And the hardware testing is completed. The display and therapy features are under development, and integration is in process. So this is a 3-year developing model. So our smart glasses are step towards the accessible stigma-free therapy for every child with amblyopia. With right support, we can bring the innovation from prototype to impact. So we can help millions to see a brighter and clear future. So the smart glasses will actually do the patching, stimulation burn without any medication like atropine, binocular single vision therapy, and we can also this acts like a Bargata filter. Orthoptic exercises can be done, and vision therapy games. So one solution for all this is this AR glasses. Thank you.
Thank you, Dr. Shah Yusuf. It was a very nice presentation and quite informative. So over to Dr. Pritish. He will be in giving the introduction of our second innovator, which is Dr. Arvind Krishnan BP.
Excuse me.
Can
Dr.
we-
Karupati, when it will come in the market?
Right.
It is very nice innovation.
Actually, we are developing this 3D modeling, doctor. Like we are trying to do a trial and error process like that.
So
So
in 1 year or 2
yeah,
years,
in 1 year it will come. Right
then
now.
you please inform our society.
Sure. Right now the software thing is done, doctor, but trying to integrate and making it little sleek nature is thing which we are concentrating right now. Because if it is heavy, the child can't wear it. So
Yes.
How much will be the cost to the patient?
if it is not without a liquid lens, then it will cost 9,000 to 10,000. If we integrate, yes, rupees.
It's very cheap because
Yeah.
we are at the moment giving vision therapy. The software of vision therapy is very costly.
If we integrate the liquid lenses also, it will cost little higher, like 30-40K.
So keep it little cheaper because the vision therapy is 16,000 and it works. The software is 16,000. Okay, over to Dr. Pritish for please take Dr. Arvind Krishna and then Dr. Nishwant.
Should the judges ask questions, madam?
Judges are there. Judges have to ask question, not me.
So, Dr. Vasavi,
Yes.
you were talking about liquid lenses.
Yes.
How would the liquid lenses work?
They will actually have a pocket of refractive index which will change. So it will actually, these are there in the microscope. But we were actually thinking to bring it into the glasses because it need not change the power continuously, and they can actually adjust. And since we are actually operating on a microcontroller, and this liquid lenses will have a thing which will control its voltage. So we are trying to.
So what will be the material? What will be the material which you will use for the liquid?
Liquid lenses.
Liquid lens?
There is one company which is actually doing the marketing, doctor. It is costing like 40,000. So actually, I have to work with the who are having a sound knowledge in this optics. So right now, it is mostly in this.
It's mostly in ideation, and you have drawn the the model. The model you have done using what microcontroller?
That is first. I have now in prototype. I have used Raspberry Pi.
The picture you showed was which
Pi 0.
Pi 0. Okay.
Yes.
So
But
you're planning
for
to
the
put a Pi
binocular,
0.
yes, Pi 0. But if it is using both eyes, we have to have a higher thing. So since I am doing everything on my own and funding is also self, so I am doing in a like little small things so that
Excellent,
I will.
excellent. Yeah. So good. So it's clear that Dr. Vasavi is doing the programming part also herself.
Yes.
So good work, good work. Any other judges would like to ask anything else?
Congratulations, Dr. Vasavi.
Yeah, congratulations.
This is a fantastic concept, and you must carry it on to the market without stopping even a day.
Yes.
And if you need any funds, Dr. Arsisha is right here, and he can definitely provide you.
Thank you, sir.
Whatever necessary fund. But this must be brought to the market at the cost which you have said as early as possible. Congratulations.
Thank you, sir.
Now, welcome Dr. Arvind. Dr. Arvind is a final year resident from Arvind Eye Hospital, Madurai. He is an innovator eye mount 360 dynamic eye mount. He is a winner of AEC Hackathon 2025, winner of Arvind Inspiring Innovator Award AII 2025, in Industry Special Recognition Award winner at AIOS.
Please loud. The speaker is less.
2025. Is also the IIRSI Film Festival 2020 award winner, Best Teaching Video Award, Captain Subramaniam Award nominee at TNO 2025, the Best Poster Presentation at TNO 25, Best Video Presentation at JHOSCON 2025, and Yossi IROC National Level PG Quiz winner. Kindly please present your presentation, Dr. Arvind. We welcome to the 23rd midterm conference.
Yes, sir. I hope I'm audible.
Yeah, you're audible. Please continue.
Yes, thank you, sir. Thank you, Dr. Bharati ma'am, and I thank the entire Jharkhand Ophthalmic Society for giving me the opportunity. So I'll be starting my presentation and be starting my screen. One second. Is my screen visible?
Yes, the entire screen is visible. Go ahead, open the PowerPoint.
Yeah. This is, I hope you can see the full screen right now.
Yeah. Please continue.
So good morning, everyone. I'm Dr. Aravind. I'm a final year resident at Aravind Eye Hospital, Madurai. So I'm here to present my innovation, which I have titled it to be Eye Mount 360, which is a dynamic eye mount to practice in your wet lab training. So the problem statement I came across was this image, which you can see on the left. Residents and trainees, especially in the first year PGs or anyone who was first time going into the wet lab, they start practicing their cataract surgery on either a goat's eye or a human eye, which is mounted on a fixed stand such as this. So the problem here, as you can see, is that the goat's eye is not like akin to the human eye. Each side is not symmetrical. Some sides are much steeper. For example, here you can have much better access. Here you don't even have a scleral area to practice. And hence you have to keep your hands in very awkward positions while practicing your scleral corneal tunnel and side fold. So here is a video showing a first year resident trying to practice his a small incision cataract surgery steps on a fixed immovable goat's eye. As you can see, he has to keep his hand in very awkward positions, which is not like how you do a normal surgery. And it's very cumbersome and difficult to create a tunnel or any other procedures. So we thought this must be a simple solution for this, and we came up with the innovative eye stand we titled it to be the iMount 360. So in the recently conducted hackathon at Aravind Eye Hospital, Pondicherry at 2025, we worked along with engineers and our lab team and 3D printed a prototype where we incorporated a simple ball and socket system into an eyeball stand, which would essentially make the trainee to move the eyeball in any direction he wants, which is comfortable for him. Here you can see our first initial prototype which we made, where the eyeball is mounted on our prototype and the surgeon can rotate it in any position in which he's comfortable. You can also rotate the eyeball along its axis so that you can access any part of the eyeball without having to move the entire stand. And subsequently, for the LVPI hackathon, we made a second prototype, which we call it the version 2.0. So this is what you get when you're practicing your cataract surgery initially. You have to keep your hand in a very vertical position while making a stereocoordinate tunnel. But with our stand, just a simple solution, you just shift the eyeball to a better angle, and hence you can have in a much more comfortable position of your hand, you can start your surgical practice. So this is an animated diagram drawn by my good friend, and this depicts the core problem and the solution which we propose. Even in your normal small incision cataract surgery, you don't straight away go ahead with the sclerocorneal tunnel. You first put a brittle suture, you tilt the eyeball to a front, you get a good exposure. Only then can you practice your SICS tunnel. Only then can you do your tunnel. So we are trying to integrate the similar experiences which you get in real surgery in your wet lab. This is a video showing me practicing my SICS tunnel in the new second prototype, where now, since the eyeball is a little tilted, I can comfortably create a sclerocorneal tunnel, and also I can rotate it, and I can do it in any other sides as possible also. So the syringe, you can see here, creates the vacuum to hold the eyeball. So apart from cataract surgeries, when we presented at the hackathon, various other department specialties told us that it can be used for other procedures as well. For example, in this case, where you show minimally invasive glaucoma surgery, the surgery is done with the patient tilted 30 to 35 degrees front and your scope tilted 30 to 35 degrees towards you. So normally how they practice this surgery in wet lab is they have to physically take the eyeball, tilt it front, and then they have to practice. But with our stand, you can make the eyeball move in any position, lock it, and then you can start your procedure. This is an image showing I took a photo of a glaucoma fellow trying to practice suturing through an RD implant. Here you can barely even see the RD procedure, RD implant, leave alone practice your steps. But with our stand, you can get a much better exposure and a comfortable arc to practice. So this is a video showing a glaucoma fellow passing a suture through an RD implant. Since she gets a much better exposure in area, she can comfortably practice her suturing techniques. So in the future, we also plan to integrate this iMount 360 with a pre-existing head model, as you can see on the left. So if we integrate this, we get the dynamic movement of the eyeball, we get the forehead, we get the nasal bridge, and it almost simulates the real exact surgical methods. So the syringe here, you can very well see, is what we use to hold the eyeball with the suction. So these are the other commercially available stands in the market, as you can see in the left, which is what many of the wet labs have. They cost around 5,000 rupees, but it is still fixed and it cannot be moved. And these are another other examples of a silicon-based eyeball training kits, which are very, very costly, and still it is fixed and cannot move in any direction you want. So the estimated cost of our prototype product will eventually be under 2,000 rupees. It is very cost-effective, portable, user-friendly, and it is such a simple device. So it's very, very quick to market and quickly can be adapted. And it has much more applications apart from cataract, like glaucoma, even squint surgeries, or any other procedures where you want some movement in your eyeballs. It has a wide application. It can be used for residents, fellows, consultants. It can be used in wet labs. You can keep it in direct skill transfer courses and conferences. You can keep it in any training institutes, and it is universal application, not only limited to India. It can be easily exported to any country you want. The future steps for this product will be refining the design, selecting a much suitable material. So initially we are making a 3D printed model, which is very flimsy. So better model materials like a silicon steel or aluminum can give a much more rigidity and stability to the eyeball. And then refining the design, finalize it, and get multiple user feedback and go for full scale manufacturing. So we are currently collaborating with companies like Aurolab and Aravind Center for Eye Care Innovation. We are also recently collaborated
Kindly
with
conclude, sir.
Yes. So this is the picture of us winning the hackathons. This is the picture of us winning the IRSA. And yeah, thank you for the opportunity for presenting this. Thank you.
Thank you, Arvind. Very good innovations. It will be very good help to the newcomers and all. Any questions from the judges, please?
Excellent work, Dr. Arvind. So very happy to see an innovation which is going to help the doctors, the ophthalmology trainees themselves. So you said the model is going to be first 3D printed. What material did you use for 3D printing, and until now has it broken apart, or
Sir,
are you still
Sir, sorry, sir, I am not able to catch that. Dr. Bharti ma'am, can you mute your audio?
Right. So I was just saying, it's a good innovation, very good innovation,
Yes,
especially
yes,
for the young ophthalmologists. And
yes.
I would like to know what material you use for 3D printing, and whether the models which you use till now have disintegrated or broken, or are they still working fine?
Sir, the 3D printed models are the same materials which we use for the routine, the silicon things which we use in the Aravind hackathon.
PLA
Right,
or ABS?
the first one, sir, PLA.
PLA, okay.
Yes, sir.
Polylactic acid.
Polylactic acid. Yes, sir.
Did it break, or are
No,
they
sir.
still working?
We have made 3 prototypes. It is completely the same. It is not broken at all. So I am not very experienced in 3D printing. So the engineers helped me to make multiple layers of it so that it is much more stable. And none of the 3 prototypes we made so now has broken. But it's still it doesn't have the weight to practice your thing. You need to definitely go for a metal-based product.
Right. So I would suggest, in order to keep costs low, you could use a stop and go technique in the 3D printing, where you incorporate weight into the base. So you pause the 3D printing, then you add some weight in the base, and then continue 3D printing so that it incorporates more weight. And that would be probably the easiest way to get it to the masses, rather than go for injection molding or metal, so that which will take time. So I really am amazed by the innovations which are being done in the Aravind hackathon, and I hope at least some part of it might be open source. And this adding the weight by a stop and go technique in the base while 3D printing might help take care of the weight issue.
Thank you very much, sir. I would like to collaborate with you more after this session so that I can get better tips from you. Thank you.
Yeah, sure. Any of the other judges would like to comment?
Arvind, if you use a material known as Delrin, which can be machined, the Delrin material has a weight which is very light and has a strength which is nearly the metal.
Okay, sir. Okay, sir. That's a good tip, sir. I will make note of it. Thank you.
Yeah, congratulations, Arvind. one more idea I'll suggest. So the base of the 360 mount, you can just make into design into two pieces. And the center one, you can keep it empty, where you can put a metal block cube inside afterwards, after printing. So after printing the both parts, put the metal cube inside and you can just lock it inside. So it will be easy and to assemble also later on. So that will increase the weight of the base so that the eye mount won't tilt and tip off when you're
Yeah.
using it. That is a
Yes.
simpler idea.
Yes, sir. Yes, sir. I'll make note of it. Thank you. Thanks.
Okay, now please take Dr. Nishwant.
So I welcome Dr. Nishwant Balakrishnan, who is a final year resident from Arvind Eye Hospital, Madurai. And coincidentally, Dr. Pritish was just saying that he is seeing his juniors from Arvind Eye Hospital, Madurai, presenting a lot of innovators. So it's very heartening. Dr. Balakrishnan is a final year resident from Arvind Eye Hospital, Madurai, and he has won the Arvind Inspiring Innovator Award. He was also a runner-up in AIOS I Invent Hackathon, and he was a finalist in the AIOS Teachers of Tomorrow. He has been an innovator of glaucoma meter, Terry shaver, slit lamp pro, and home-based ophthalmic surgical training kit. So lots of innovation coming from Dr. Nishwant. I would request him to start his slides.
And Nishwant is very appealing for the practitioner. It is on the pterygium surgery.
Thank you, sir. Thank you, ma'am. My name is Dr. Ishwar. I'm a postgraduate from Aravind Eye Hospital, Madurai. I'll be presenting the Terry shaver on behalf of Dr. Nishwar.
Because Dr. Nishwant is in Vietnam right now for a conference.
Yes, ma'am.
On
I'll
a
just
personal vacation.
share my screen. Is my screen visible, ma'am?
We are still not able to see the screen. You sure?
No, it is not visible.
Now, ma'am?
Not at present, please. Doctor, need to click on the video, please.
Admin, please help him. He's unable to show his slide.
Doctor, just click on the please.
Yeah, Ishwar, you can start.
Yeah, we are able to see.
Meet Mr. Ramu, who is a 55-year-old hard-working gardener from a village near Madurai. He is a daily wage worker for whom every day of work is very important to sustain his living. Irritation in his eyes is constantly bothering him, for which he visits a doctor nearby. Ramu complains of irritation in his eyes to the doctor. The doctor examines him and diagnoses him with a condition known as pterygium, for which she advises surgical excision. But Ramu is worried and anxious because he had a similar complaint 6 months back, for which he underwent surgical excision of the pterygium. Pterygium is an allostatic degeneration of the subconjunctival tissue. That is, there is a fleshy growth that arises from the white part of the eye encroaching the black part of the eye. Unfortunately, surgical excision is the only treatment available for pterygium. 6 months ago, Mr. Ramu underwent this surgery, and this is how it went. The challenge with respect to current practice of pterygium surgery is that we use either blade or crescent to scrape off remnant tissue. It has a high chance of perforation of the underlying cornea. Also, it usually leaves a remnant tissue. Therefore, the chances of pterygium recurrence is more. To overcome this problem, we have designed a safer and a more effective instrument for pterygium excision without damaging the delicate cornea. Introducing Terry Shaver, a revolutionary approach to remove pterygium remnants. The working of the Terry Shaver is similar to a shaving razor. Terry Shaver uses an ultra-precise cutting-edge blade to remove pterygium remnants. A protective guard prevents the blade from penetrating the cornea even after vigorous movements, thereby reducing the chances of perforation. The depth of cutting is calibrated in accordance to the pterygium tissue. To demonstrate the working of Terry Shaver, we have used a pterygium-like tissue over a goat's eye. We could see that by using the Terry Shaver, we were able to remove the tissue easily and achieve a clear cornea. The distance between blade and guard is known as the blade gap. Based on blade gap, we have three variants: 10, 20 and 50 microns Terry Shaver. For ultra precise removal of pterygium tissue, we can use 10 micron Terry Shaver. The clinical benefits of the Terry Shaver includes the Terry Shaver's depth calibration and protective guard minimizes the risk of corneal perforations. It improves the precision of tissue removal, thereby preventing recurrence and improved patient outcomes. It is also a very helpful tool for beginners by providing cleaner excision with reduced complications. The Terry Shaver can also be used as a valuable tool in the removal of rust ring associated with corneal foreign bodies. Just like crescent and keratome, Terry Shaver can be produced in-house. Thus, Terry Shaver is an affordable solution to produce a clear cornea after pterygium surgery.
Terry Shaver, sculpting sight.
Thank you, Dr. Ishwar. That was an excellent presentation. Something innovative coming in the pterygium surgery is always very helpful to the routine practitioners. I would ask the judges to ask about the queries about this particular presentation.
But I want to know whether it is available commercially. Ishwar.
Ma'am, it is not yet available commercially. The prototyping stage is over now. Currently, the validation stage is going on, but it is expected to be commercial within a year.
We will be getting it by Oro Lab.
Yes, ma'am. The 3D printing. Yes, ma'am. The 3D printing, everything. The collaboration is with the Oro Lab engineers.
So it is a very good news. And Arvind Krishna's innovation also we will be getting after 1 year through Oro Lab. Okay.
Yes, ma'am. With the Oro Lab and LV Prasad together, we will plan to do the iMount 360.
Okay. So please keep us informed because we have a lot of teaching institutions here and your model is also very good.
Dr. Ishwar, has this Terry Shaver been used clinically in any of the surgeries or it's just at the conceptual stage?
No, sir, we have not used it clinically. It has been used on the goat side to see whether it works. And the prototype is ready. And now we are gathering opinions from various consultants and gathering the demand in the market, whether it is viable and feasible, sir.
How can it remove the rust ring? Because it's too big and too broad to remove the rust ring. I don't think it is possible to remove the rust ring with Terry Shaver. Can you explain, please?
Sir, if the rust ring deposition is superficial, then it can be removed, sir, depending on the depth of the Terry Shaver blade.
No, but then it will remove a lot of additional tissue from around.
Yes, sir. There will probably be epithelial defects.
I think you should remove this part from your presentation. It's not possible to remove the rust ring with Terry Shaver. Unless it has been done really in clinical practice, just to present it as a concept gives the wrong impression.
Yes, sir. Okay, sir.
Right.
Dr. Ishwar, good concept, the idea. So I don't think you'll be able to test it on a goat eye also. Because where will you find a goat eye with pterygium? And a good concept, but you definitely need to work it out in the wet lab. Real life scenario, you might encounter additional difficulty. So this is not the final version. You would evolve it until it reaches a stage where it can really work. The curvature
Yes,
of the
sir.
cornea and so many other factors would affect its function.
Right,
And a
sir.
good idea, good no problem statement and working on it. Go ahead.
Thank you, sir.
Vishwa, this is Dr. Rajesh. I just had two queries. How did you determine the length of the this? You have got the depth, that is, what are the different depths for, like you have asked for 10, 20, and 50? What are the depths for? And second one is like, how did you determine the length of the shaver? It looks something like an ALTK, isn't it? So you have taken the idea from an ALTK shaver, which has an automated, but here you want to do it manual. I can understand that, but how does it, what is the length of the thing? How do you
So we did
determine?
not use any specific dimensions to determine the length, sir, only based on the convenience of 3D printing.
Okay, so basically that's what it forms, a very crude way of it. Only issue being is the depth of it, the length of the damage, as sir has already pointed out. So if the pathology is just about 2 or 3 mm, you want to increase the entire length of it. So it needs to be more targeted to the specific pathology. If it's smaller, it's even better. You can do it twice, adjacent. Once you do one shave one and then the other one. But if you have a longer one, which we're seeing on the 20 and 30, 50 micron depth, I think it becomes too very, collateral damage to the surrounding tissue also. And we also have the Bowman's membrane, which once penetrated, you know that it leaves some amount of residual opacification. The pterygium may not, but our instrumentation might, iatrogenically, it might cause such a thing.
Right, sir.
And alga brush with multiple types of burrs works very safely and much better. So just consider comparing the terry shaver against the alga brush in the clinical setting.
I think it is a good thought of innovation, and probably in future we can modify, think little better, and probably it can happen with little bit of modifications. We'll have to work on it. Well done, Dr. Ishwar. Thank you.
Right, sir. Thank you, sir. Thank you for the opportunity to present, sir.
Now the next speaker is Dr. Jagdish Rana, who will be presenting.
No. Excuse me.
Yes, ma'am.
Third, fourth one. Please take Dr. Anil Radhakrishnan. Anil Radhakrishnan, are you driving?
Yeah, that is okay, ma'am. I'll stop. I've stopped it. It's okay.
Okay. So first we will take Dr. Anil Radhakrishnan, then we will take Dr. Ramesh Shah. Dr. Jagdish Rana is here. We can take him. First take please Dr. Anil, then Dr. Jagdish Rana.
So,
both of them are very senior.
So I would welcome Dr. Anil Radhakrishnan, and sir would be speaking on non-contact corneal astheometry, which is filling in the lacunae. Now, sir has done his MBBS from Calicut. He has done his MS from RIU Bangalore, and he has completed his comprehensive fellowship with a specialty training in cornea from LVPI Hyderabad. That was in 2001 and till 2024. He has been practicing cornea and refractive surgery ever since. His area of interest includes corneal infection, anterior segment imaging. He did the first microvascular submandibular gland transfer in the country for severe dry eyes with head and neck and microvascular surgery team. He was the first surgeon in the state to perform a big bubble dissect and dissect. Has 12 peer-reviewed publication, 10 international presentation, and has more than 100 national and local presentation. So, I would with this introduction, I would like to I would like to invite Dr. Anil Radhakrishnan to speak upon his new innovation.
I'm sharing my presentation now. Yeah, is it visible?
Yes, sir, it's visible and you're audible too.
Yeah. Okay. Thank you so much, Dr. Bharti and the Jharkhand Ophthalmic Society for the opportunity again. This is a small work, nothing like Dr. Kakadia's or anything very innovative, but it's a very small innovation that we have done. So this is about the non-contact corneal aesthesiometry. So whenever you encounter corneas like this, we have to check the corneal sensation. But what we have available is a somewhat crude measurement device, which is a cotton wisp test. We take the cotton from the cubicle and do that. The other option is a more precise Cochet-Bonnet aesthesiometer, basically, which has a nylon fiber, very thin nylon fiber, the length of which can be adjusted. So that is somewhat standardized, but it has been there for more than, I think, 70, 75 years. So the purpose of a study was to look at something which does not touch the cornea. So non-contact tonometer was something, aesthesiometer was something that we had in our mind. So if you could, the NCT is a machine that we commonly use in all our OPD settings. So if you could control the air path of the NCT machine by putting a barrier in front of it, and if it has different pore sizes, you can have multiple gradations of corneal sensitivity. That was our idea. So the aim of a study was to look at a simple, portable, non-invasive way of assessing the corneal sensation, and to also to check whether it can be a qualitative or a semi-quantitative measure to do that. So we put a 3D printed this one, a adapter, which was 3D printed by CAD software, and which was put to the snout of the NCT machine. The machine that we used was the TopCon, which is available in our department. So this adapter, the 3D printed adapter, was snugly fitting onto this. The inside of it had a area where the membrane could be kept. So this membrane is basically a nano-engineered filter from the Amrita Nanosciences. They had used it for the Amrita. They developed a N96 mask, which was actually seen to be better than the N95 mask, which are widely available. And that was in the market for quite some time. So the same material was used for that. So this was the design, which was kept onto the snout of the NCT machine. The 3D printing, as usual, is done by a Ultimaker Pro. We have a 3D printing design engineer who does that in our hospital. It's not moving. Yeah. So the nano-engineered filter was made by an electrospinning technique using a polycarbonate, and this is a nanofibrous material. It's basically electrospinning, just a short video of the electrospinning procedure that is used. So there are 3 grades which we made. The grade 1 had the large pore size, close to around 700 microns. A grade 3 had about 100 microns. So this is just the filter assembly again. So there are 3 grades, and this NCT, on the NCT machine, just like we would do an NCT, we center the cornea. Then this filter assembly is kept onto the machine, which will snugly fit. And then you press the joystick, and then you get the this one, the corneal sensitivity. There are 3 grades. So we usually use the smallest one. The grade 3 one was the smallest one used, so that if it is not there, we'll go for the larger one, grade 2 or then grade 1. And we combined with the Cochet-Bonnet aesthesiometer, in which there is a nylon fiber, the length of which can be adjusted. So if it is 60 millimeters, it is the most sensitive. If it is 5, if the nylon fiber length is only this much, 5, then it is less than that, it is almost cornea insensitive. That's what you can figure out. So we made a comparative study of non-contact aesthesiometer versus Cochet-Bonnet aesthesiometer versus a cotton wisp test. It's not a big study. We did hardly on 50 patients, that is 100 eyes. And we found that in cotton wisp, all of them, they were able to appreciate the corneal sensation. In a non-contact aesthesiometer, 4 patients, that is 8 eyes, had grade 2 sensitivity. And similarly, in the Cauchy-Bonnet aesthesiometer also, four eyes had reduced corneal sensitivity, which is corresponding to that. So in this short study, we found that it fared well compared to the Cauchy-Bonnet aesthesiometer. We basically took a diabetic population from the endocrinology department. So obviously we need further studies to fine tune. We have not really tested it on other conditions like herpes aesthesiometer and all. A few patients have done after corneal neurotization surgery. That is to bring back the corneal sensation to the patient. We do the corneal neurotization surgery. In a few patients, 2 patients have tried that and it seemed to be working. Thank you so much for the opportunity. I thank my colleague. This is Dr. Yashwardhan Sin, who had done the most of the spade work. Dr. Deepthi Menon from the nanotechnology. Dr. Sarin Xavier, who helped me with the engineering part, and my HOD, Dr. Gopal Pillai, and Dr. Srinivas K. Rao of Chennai, a prominent senior corneal person who helped me with the fine-tuning of the ideation. Thank you.
Thank you, Dr. Anil. It was an excellent presentation. Now it's over to the judges for their queries.
Congratulations, Dr. Anil. And I would like to ask you, do you have the polycaprolactin mesh production in-house?
Yes, sir.
Do you have that machine and the technology?
Yeah. So they had produced that during the COVID time. They had made that N96 mask. So they have the technologies.
Oh, so you still have an access to that machine?
Yes, sir. Even though commercially, because it is
why I'm asking is that polycaprolactin mesh is an excellent anti-fibrosis device. And if you implant it under the conjunctiva at the end of the trabeculectomy, it will definitely prevent the fibrosis between the conjunctiva and the sclera.
Okay. Yeah.
So it will be something like a synthetic collagen. And I have been looking for this machine since long to produce the polycaprolactin, and I'll be in touch with you for that.
I have seen a presentation
I am
on
closest, sir. I am closest. I will be there tomorrow, sir.
Yeah, John, we must work on this.
Yes, sir. Yes, sir. He's right there in Kochi. I'll find it.
Mesh can prevent the fibrosis of glaucoma fistula. I purchased polycaprolactin from USA at a very, very high cost.
Dr. Kakadia?
Yes, sir.
I think GSFC makes this. Gujarat State Fertilizer. We have to find out from them, but I'm very sure that they make these caprolactam products.
No, but suppose if you want to make it as pharma grade or bio grade polycaprolactin.
That you have to proceed with him, but I think they make it.
Sure, definitely. Great. That's great. And another question, Dr. Anil, was you tested it on one particular pneumotonometer or various companies' pneumotonometer?
only one type, sir. What we had in one section of the OPD, TopCon 9000, that only we tested.
Okay.
Yeah.
So that means because every pneumotonometer has a different puff pressure.
Yeah, that is correct.
And the puff size. So you have to have a titration based on each machine. Am I correct?
Yeah, correct, sir. Very correct.
Fine. Thank you. But the concept is very nice, and congratulations.
And you found a new machine which you want. So, Dr. Anil, so firstly, congratulations on this innovation. You have actually made a misnomer, a non-contact aesthesiometer. So, aesthesiometry is finding out the touch sensation. So, without touching, you are finding out the touch sensation. So, that is amazing, making the impossible. And I think maybe in the future, you might need to calibrate the air pressure puff or make it separately. And once that is done, maybe you can have it as a portable device also.
Yeah.
So that would make the final product which we could use easily.
Yeah, now there is one product that is available in the market called Brill non-contact aesthesiometer. So that is, I think, quite expensive. I don't remember exactly, but around 10 to 12 lakhs or something. In US, it is available. So when we started this, it was not there. That I'm sure.
Anil, you can we can use a small handheld puff compressor.
Yeah.
And it can be made as an independent device rather than using it as an add-on device on a pneumotonometer, because every OPD may not have pneumotonometer.
Yeah. So I think I'll come to you. Sir.
Welcome to Bhavnagar.
Good morning, Dr. Anil. Just wanted, inquisitive about the thing, the size. How did you determine the sizes, sir? On what basis did you come up with the sizes for the perforations in the nano thing which you did, that membrane?
Okay. So I think, see, it depends on layering, how much you do. So initially, I think based on because they had used it for the N96, they had that experience. So they said if you do it once, this many minutes, it will come to around 700 microns. This much time, it will come to around 100 microns.
No, I'm not asking about the 700 microns thing. You created a hole through which the air should go in, no, sir?
Yes.
What made you to determine that, okay, 700 microns is good enough, or 300 microns, or whatever it is? What is that size how did you get to that size? I'm not saying production of it. Production of it is fine, you told me. But how did you, why not 300? Why not 1000? Why not 2000? Something like that. So why did you come up to the size of that?
No, we okay. So we talked to these people, nano people, and they said that if you just do it for this much time, it will be around 700 microns. So it might be, we just first tested on 700 micron Thor. So that was like most people were able to appreciate that. So like there was hardly any difference.
Okay, so did you determine how much of the air pressure which finally comes out of the filter?
No, sir. I tried to do that, but like they said, it's very complicated to do. So I was not able to do it actually. I wanted to do, but I was not able to do it.
Yeah, very nice innovation, sir. I just have one question about the output pore size. The output pore, not the this thing, membrane pore size, sir.
Okay.
You have made the adapter, and it has a nozzle. So because that will direct the air puff, and it is quite smaller than the NCT puff nozzle. So what is that pore size? And through which the air puff will go? The membrane is behind the pore nozzle.
Okay, fine. So actually, if you look at the area from where the air is coming, it was almost 5 times that.
Okay.
So it was a large hole, and that whole area was covered with the membrane.
Okay. So you can also try infrared imaging to image the air puff coming, and so that you can localize the area where the puff is hitting the cornea, and you can improve your the sensitivity of your devices.
Okay. That's a good suggestion. Thank you.
Yes, thank you, sir.
Now the next speaker is Dr. Ramesh Sisa. His presentation is on an anti-fibrosis prolymphatics collagen implant for higher and longer success of trabeculectomies. Kindly present, sir, Dr. Ramesh Sisa. Are you there, sir?
Yes, sir. Just wait. Can you give it to somebody else next? I will be presenting next to this.
Okay. Dr. Jagdish Rana is here, sir.
Yes, sir. I'm here.
Welcome, Dr. Jagdish Rana, sir. His topic is on my innovative double tooth phaco chopper. A little introduction for Dr. Jagdish Rana is he's a consultant phaco and laser surgeon in Ahmedabad since 1991. He's director at Tupath Eye Hospital, Ahmedabad, Netralaya Super Specialty Eye Hospital, Ahmedabad, and Freedom Eye Laser Center, Ahmedabad. He's the innovator and patent holder of double tooth phaco chopper. Is presented about at ACRS, APACRS, AIOS, IIRSI, IBFF, DOS, KSOS, TOS, and AGOS, etc. Is the member of Ethics Committee and Managing Committee of AIOS. Is the state representative of FBS AIOS. Is the honorary executive secretary of AGOS since 2021, and also the honorary executive secretary of AIOS 2015 since
Hello, dear friends and
2021.
colleagues. Today
Kindly
we
start your presentation, sir.
introduce to you collagen, the type 1
Dr. Jagdish
of
Rana.
there is no leak of a 12 without medical.
Dr. Ramesh, kindly mute yourself.
All presentations are 7 minutes. All presentations are 7 minutes.
Dr. Jagdish Rana, sir, please.
Yes, sir, I am starting. Yes.
હા કરી દો મારું 4 મિનિટનું તૈયાર છે હું આપી દઉં છું કોલેજિનનું નહીં મને એક મિનિટ ઉભા રહો
Sir, just uncheck the enable and then continue.
Hello.
Sir, uncheck the enable box and then continue, please.
Where to uncheck it is.
Sir, box में से टिक हटा के उसके बाद continue कर लीजिए.
इसको बॉक्स यहाँ से.
उस अनचेक करके उसको कंटिन्यू दबा दीजिए. पहले अनचेक करिएगा.
Where to uncheck, sir? Uncheck.
सर नीचे बॉक्स में से टिक हटा के उसके बाद कंटिन्यू दबा दीजिए.
Yes, sir. Yes, sir.
Or just open your PPT, so that should also do the trick.
तो इसको कहाँ से हटाएंगे? इसको this is just behind it. इसको कहाँ से हटाना है सर? I don't know.
Sir, just open your PPT. You should be able to share.
PPT is just behind this. So.
Sir, first open your PPT. अभी stop कर रहा हूँ. First open your PPT, then share.
Okay. Sure.
First open your PPT, then share, sir.
How to remove this one? It is getting in between.
Sir, if you can just read the dialog box before sharing, that would be better.
Yes, please.
So let's Dr. Ashish present, then I will present. Bye. Dr. Ashish, if you present.
Yeah, I am ready.
Yeah,
Yes,
okay,
sir, please start your presentation, Dr. Ramesh.
Yeah. Can you see
Hello,
my
dear friends
presentation?
and colleagues. Today we are very happy.
Can you see the presentation?
No, sir. The presentation. Please open your PPT before sharing, please. First open the PPT, then share, please.
Okay. Can you see now?
All good, sir.
Collagen.
Can you see?
This is a novel
Yes, sir.
glaucoma antifibrosis collagen implant. With the collagen implant, we can achieve nice, healthy, and flat, everlasting bleb every time in every case. Collagen is a type 1 fibrillar atelocollagen obtained from bovine tenons capsule tissue, which is completely acellularized and is totally de-antigenized. It is also impregnated with all 4 types of GAG, the glycosaminoglycans. Hence, it retards or suppresses fibroblast activation and maturation into fibromyocytes, so it helps to negate subconjunctival scarring. Collagen implant also induces and promotes conjunctival lymphatics regeneration, recanalization, and reanastomosis. Collagen also induces controlled and minimal angiogenesis, which restores normal capillaries of conjunctiva over the flap, and so it always prevents thin and avascular blebs. Please notice the difference between MMC only bleb and MMC plus collagen bleb. Up to this stage of scleral flap suturing, the surgery is same as in standard TREP. Scleral flap is sutured watertight with teno-orocryl in figure of 8 fashion. We never use nylon or silk here, and there is no need for releasable suture. Now we confirm that there is no leak of aqueous humor. Blood filling the incision trench is a good sign that there is no leak. We want the leakage or seepage to begin only after 20 to 30 days and not at this stage. Now ready for implantation of collagen, which essentially is a lyophilized bovine tendon tissue disc. Collagen disc is now impregnated with moxidexa eye drops, and then it is cut into 2 halves with Westcott conjunctival scissor. And both the halves are now put over the scleral flap like this, and the conjunctiva is then brought back over it. Conjunctiva is now closed with 10-0 polycryl continuous suture. Both ends of the suture are kept quite long, which is then buried under the conjunctiva so that there is no significant foreign body sensation for the patient in the immediate postoperative period. This is 6 months post-op picture, very healthy flat bleb in a pseudophakic eye, and the IOP is 12 without any medication. If we look carefully, we can notice new lymphatic channels which have now developed. Please notice the same again. Nice healthy bleb in a phakic eye, IOP 14 millimeters without any topical or oral anti-glaucoma medications. Another phakic eye with a very nice healthy bleb, which is normotensive without any eye drops. One more phakic eye, IOP 10 without medications at 12 months post-op. This case was done as early as 2015. IOP is 12 without medications, and we can beautifully see the lymphatics. Thank you very much for your kind attention.
I would request the judges not to consider for any prizes as we are quite senior. So we'd like the juniors to take whatever the benefit of this platform. And these lymphatics which are developed, we are trying to demonstrate with the help of moxifloxacillin with UV light, which I will be showing in a MoxyGlow, the next presentation. And we are able to demonstrate so many lymphatics with the help of moxifloxacillin and UV light. So I'll be showing when my next presentation, when I present it.
Yes, and I was waiting for that because suddenly I found that you are presenting something else.
So I thank Dr. Bharti and rest of our team to allow us to present this paper. But I request the judges not to consider me for any prizes as they are quite senior. We'll allow the juniors to take the advantage of this platform.
Thank you, sir. It was an excellent. This is an excellent initiative that you have taken, and congratulations on your innovations also. Now, I would like to ask the judges for any queries on the present innovative from Dr. Ramesh Shah.
As this is not for competition, we can go ahead and save some time.
Okay, ma'am.
So now he is presenting MoxyGlow. This is very important.
Okay.
May I have a question, please? A very practical questions. To what level of intraocular pressure you like to put this implant?
After this, after this implant and the success of implant, we are not finding any much problem as far as the trabeculectomy, where thin blebs and other things were there. So for me, the moment I find there are changes in the perimetry, and if you are using more than 2 drugs, we do this implant. We do the
Now,
collagen
suppose the patient has got an integral pressure which is not coming down beyond 29, or somebody has 36, or somebody has 40. So to what level you like to put this implant? What are the indications? Any high pressure, or what is the pressure indication?
If there is no pathological cause like neovascular glaucoma, or there is a malignant glaucoma, I would like to do this procedure as a primary procedure. And in those extreme cases of glaucoma, we would like to put our glaucoma implant, which is very, very effective. So for me, glaucoma more or less is a surgical disease. And if there are more than 2 drugs, and if the IOP is not controlled, and there are changes in the field, I would go for this surgery. And I will not do routine trabeculectomy now. I will always use collagen in my all the cases. In last 20 days, I did 7 of them. I am not a glaucoma specialist.
And do you use
Kashyap sir? This works so well.
This works very well.
Really, so it completely prevents the fibrosis between the conjunctiva and the sclera. It regenerates the entire tenon tissue as if it's a new tenon tissue.
It is the same membrane which people are using it. Even the peritoneal fibrosis which is taking place, they remove the fibrosis and put the similar material to avoid further fibrosis after the surgery. I think it is the same thing.
Also, RC, also in the submucous fibrosis.
Submucous fibrosis.
The ENT surgeons are using a submucous fibrosis to prevent the recurrence of the tight closure of the mouth.
Thank you. Thank you, sir.
Thank you very much.
I am ready with my presentation. Can I present now?
Yes, the MoxyGlow.
Yeah, I am Dr. Jagdish.
Then he has to, Dr. Amesa has to present MoxyGlow also.
Yeah, okay.
Because that is a very innovative thing, and there is no expenditure on MoxyGlow. Just a torch, UV torch, which is available in 1,000 rupees in Amazon.
Hello, dear friends and colleagues. We are very happy to introduce to you MoxyGlow. While doing experiments with UV lights, it was a serendipity finding for us that
Doctor, your video is not visible. Can you just pause and reshare?
Is a fluorescent molecule. And digging deep in the literature, we realized that
Doctor, can you just pause the video and then share?
This is panel 1 second.
Doctor, please share again. Doctor, please open this video, then share, please.
Yeah, that's what I'm trying to do. I think Dr. Rana, please continue with yours. I'll adjust my thing afterwards. Dr. Rana?
So, okay, sir. So I would just invite Dr. Jagdish Rana to present his innovation, and his innovation is a double tooth phaco chopper. So you can go ahead with your slides, Dr. Jagdish Rana. So are you able? Yeah, thanks.
So thank you very much, Dr. Bharati Ma'am and Jharkhand Ophthalmical Society, to give me an opportunity to present my topic on innovative double tooth phaco chopper.
Innovative 2-point fixation complete phaco chopper. We have no financial interest whatsoever. Introducing a cutting-edge mechanism that will simplify the course of phaco surgery. Here is announcing the next generation 2-point fixation, a complete phaco chopper. The success of this innovative new product is such that it has acquired the status of a design patent number 255048 on the 5th of July 2013. Thinking of an ideal chopper, what qualities do expert surgeons expect it to have? Tip should be blunt, tissue friendly, but should have property of a sharp chopper, able to stretch the pupil to see behind the iris. In case of semi-dilation 2-point fixation, a complete phaco chopper, which has all the characteristics of an ideal chopper, coupled with more features that makes it a hands-on equipment perfect for phaco surgeries. This chopper has been designed keeping ergonomics in mind. It has serrations on the handle of a stronger grip, a blunt neck to hold the eyeball supported by a blunt curve to stretch the pupil, and the USP of the next generation 2-point fixation, a complete phaco chopper that has a double tooth, unlike the regularly used single tooth choppers. A simple example can abridge all that has been said above. Take a look.
This is a small funny video about this chopper.
Funny but true, a minute miss can cause an error of a lifetime. Putting this into real-life context, in the next generation 2-point fixation, a complete phaco chopper is useful in the following ways. Cracking the nucleus. And nucleus rotation. Difficult to separate. While in double-tooth chopper, because of chopping done at 2 points, simultaneously, chopped pieces get widely separated, and there are less chances of getting it locked with each other. Removal of nucleus pieces, its rotation, stuffing and re-chopping. Epinuclear rotation. stretching the pupil. The unique feature of two-point fixation phaco chopper is that it is able to stretch the pupil, keeps it stretched and avoids the injury to the iris. And due to its unique angular design, the pupil gets entangled, ensuring safety of the iris. This is how such a surgery consumes less time, decreases tissue inflammation and zonular stress. And so successful phaco surgeries is equal to satisfied patients, which in turn means
This is what about the experts say. Dr. Ronaldo from Singapore, Dr. Suhas Aldipurkar, our own phaco surgeon from India, and Dr. Toshiko Ota from Japan, who presented about in various conferences. It's also mentioned in our ophthalmic surgical instrument book. It's available in India by Epsilon and Pasami. My friend Dr. Ota has modified it slightly and made some projection at the base of double tooth phaco. It's known as Rana Ota chopper, and it's available globally as a Rana Ota nucleus dividing hook by Duckworth and Kent Limited. Thank you. Thank you so much.
Thank you, sir, and congratulations on your innovation, sir. Now I would ask the judges for their queries, sir. Invite the judges for their queries.
After this, we will take Dr. Omar Rashid. Dr. Omar Rashid, are you here?
Any queries from the judges' side?
After this, Dr. Ramesh Sai is going to present Moxie Glow. After that, we will take Omar Rashid. And in the meantime, I would take the opportunity to introduce our great coordinators. Dr. B.P. Kashyap, he is the past president of Jharkhand Ophthalmological Society, and he is the founder of the first NABH accredited hospital of Northeast and West India. Another coordinator is Dr. Rahul Prasad. He is a Victor Retina senior consultant in largest teaching institute of our state, that is Rio Renis. Our third coordinator is Dr. Pritish Pronoy. He is from the trained in the Arvinda Eye Hospital, Madurai, and he runs the largest eye department of the largest Sadar hospital of Jharkhand, that is Ranchi Sadar Hospital. So these are our three coordinators of this hackathon session, and our judges' introduction will be given by them before their talk. In the meantime, we are any question to Dr. Jagdish Rana, and Dr. Ramesh Shah has to present Moxie Glow also. We are very much interested in Moxie Glow.
So any queries from the judges' sides, please?
Dr. Jagdish, so that is a very interesting new design for a phaco chopper, and
Yes,
so
sir.
you have definitely thought differently. Instead of going for the traditional design of a chopper, you have doubled it and made sure that you have extra advantages.
Yes, sir.
Would you say that there is a big learning curve for this chopper, sir, for a person who is used to a regular design chopper? What would be
No,
the
sir,
learning
there's
curve?
zero learning. No, there's zero learning curve because it usually pass through the side port and usually comes out through the side port. So, and there's no learning curve. Rather than it's a very easy and very useful tool because without double tooth, there is less stress over the zonules and we can easily divide the nucleus species and nucleus also.
So what is the size of the side port that you need to enter this?
1 millimeter.
So that's a regular size. So there is no need
Yeah,
to
that
enlarge
is
the side port.
Yes, yes, sir,
Nice.
definitely.
Excellent.
It's available.
Any other difficulties manipulating the dual tips, sir? Because you might be closer to the capsule, closer to the cornea because there are two tips.
No, but it's a blunt tooth, so there is no chance of damaging any tissue, not capsule or not even, because we are not going towards the cornea, no, tooth is towards the lens. And
Right,
double tooth, they never damages it. Yes, yes.
So,
Right.
Dr.
Anyway,
Jagdish, what I take is you have to make a trench first before you start dividing it. Like what we do in direct chop, you can't take your chopper to the periphery. You have to make a trench, and then probably the space made with trench is used to put the chopper there and then divide it. Is that right, sir?
Yes, sir. Yes, sir, definitely. Yes, very true.
It's fantastic. It's fantastic. Absolutely fantastic, sir.
Yes. Thank you, sir.
Yes.
Dr. Jagdish, sir, I have one question. So that globally available chopper design has, as you told, it has two projections on the side. What are those projections for?
That is to stretch the iris, because here in my chopper, the angle which is below the double tooth, with that angle we are stretching the pupil. With one projection, another projection below it, we can easily entangle between that two projection, base of the double tooth and that projection. So iris get entangled between that two, and it helps to stretch the pupil in case of a semi-dilated pupil. That's an extra feature. Yes.
Yeah. Thank you. Thank you.
Yes. Thank you, sir.
As far as the non-dialectic people is concerned, I would rather not like to touch the iris at all, because they react and then the people constrict any further. But then yes, of course, if the people is constricted from the very beginning, this will help. Very nice.
Yes. Yes. Thank you, sir. Thank you so much.
Dr. Ramesha, kindly give your on microglue, Moxiglow. Are you ready, sir?
Can you see?
Hello, dear friends and colleagues. We are very happy to introduce to you Moxie Glow.
Can you
It's
see?
not saying, no, so it's not
You
coming.
cannot see your video. You can see your screen, but not the video.
So, till Dr. Ramesh Saw gives about his presentation, let me share you one thing. Here in my double tooth phaco chopper, we are not doing vertical or horizontal chopping. We are just doing lateral separation of the lens nucleus fibers, because we are just separating the nucleus fiber. In the Dr. Ronaldo mentioned it, that when the double tooth direction double tooth chopper and phaco probe are in one line, it just separates the lens fiber. So we do not have to use any force. Phaco probe and the double tooth, where they are in a line, so it easily separates without any stress over the jonules. We don't have to do the horizontal chopping, or we have to vertical chopping. So it's called a lateral separation
Hello, dear
technique.
friends and colleagues.
Go ahead.
So please continue. Dr. Shah.
RC, can I share on your behalf from my computer?
This is one.
Okay, fine, fine.
Yeah,
Now,
this is one video. After doing the LASIK, we put the moxifloxacillin, and here you can see the flow of the blood which is put onto the lymphatics around the limbus. This is one part of the video where we will be able to demonstrate the lymphatics, as well as you see the opposition of the flap is so nicely seen with the help of Moxiglow. Now I'll share my main video. Dr. Kakade, you can share it on my behalf if you want.
no, I think now it's visible from your computer. Please go ahead. Hello, dear friends and colleagues. We are very happy to introduce to you Moxie Glow. while doing experiments with UV lights, it was a serendipity finding for us that
Can you see or no?
95 nanometer UVA purple light
Yes, sir.
is a fluorescent molecule. And digging deep in the literature, we realized that MOXIE is essentially a fluorinated derivative of quinine, and the word fluorescence is derived from fluorine. So the fluorescence of fluoroquinolone is thanks to fluorine. Based on these facts, we devised a device named MOXIGLOW, which is fitted to surgical microscope and also to slit lamp. This MOXIGLOW helped us to actually visualize the moxifloxacin in real time and also enable us to record what really happens to it in the anterior chamber. Molecular molar weight of water is 18 grams per mole. Of mercury, it is 200.5 grams per mole. Of lead, it is 207 grams per mole, whereas molar weight of moxifloxacin is 401.4 grams per mole. So at full concentration, the MOXIE is 22.3 times heavier than water and 2 times heavier than mercury and lead, and it is not readily miscible with aqueous humor. It is so heavy that even if we add it in BSS pint, it gravitates down. So when we inject undiluted 0.1 cc or 0.5% MOXIE, we can see that it remains localized, not readily miscible in the rest of the anterior chamber, and it will not be homogeneous, and some or much of it may leak from bigger side ports. So protection provided and the results will be variable. For few hours, the concentration here can be as high as 5,000 micrograms per ml, which may cause endothelitis or iris atrophy. According to ESCRS endophthalmitis study and Irwin Group study, if you don't use intracameral MOXIE, there is a 1 in 1400 chance of endo, and if you use, the chance is 1 in 5800, so there is a 4-fold risk reduction. Erratic or low dose MOXIE, 1 in 3400 chance, and erratic high dose MOXIE, TAS and iris atrophy chance. So it is a Hamletian dilemma, like a ditch or dike, to use or not. So what is the solution? The solution is to make a solution, a diluted solution, which we have learned from Dr. Steve Arshinoff. The ideal concentration of MOXIE is 1500 micrograms per ml and fill the full anterior chamber with it, to make which we add 1.5 ml MOXIE in 3.5 ml BSS, which we call MOXIE mix, which is 1500 micrograms per ml. We insert the MOXIE mix cannula from side port, always remaining in front of the iris, and inject the MOXIE mix, whirling it and swirling it till the entire chamber is full and the MOXIE starts to overflow from this and the opposite side port. And then we hydrate the side ports with the same solution. We can see MOXIE going into the corneal stroma around the side ports, and then we check the intraocular pressure to be around 20-25, and this is the last step of the surgery. Even after this dilution, it still is identifiable because it looks very faintly pale yellow. But if still there is any confusion in the minds of doctor or staff, we can just switch on the MOXIGLOW and we can instantly realize which syringe is containing diluted MOXIMIXI and which one is containing the plain BSS. This video under MOXIGLOW is taken 7 hours after the surgery, and we can still see that the moxifloxacin is present in the anterior chamber significantly. It's almost the same amount which we had injected at the end of the surgery. With acetazolamide 250 mg given immediate post-op, we can see moxifloxacin in a fairly significant amount even at the end of 10 hours post-op. Even after 15 hours, we can still see significant amount of moxifloxacin in the anterior chamber. Even after 24 hours, the tenacious MOXIE is still there. With MOXIGLOW, we can use MOXIE eye drops to stain the cornea instead of fluorescent sodium. Cataracts are also fluorescent due to beta-carbolin and tryptophan, so we can shine the MOXIGLOW to detect or demonstrate the presence of cataract. This child had congenital nasolacrimal duct block in left eye. 20 minutes after putting Moxi eye drops, when we shine the Moxi glow, we can see that the drug has passed into the nose on the patent side, while the drug is retained in the lacrimal lake on the blocked side. This is good for us for confirmation as well as good for demo to parents. There are many other uses of Moxiglow, but that we will discuss in future some other time when we have more time. You can buy this from Amazon and use as DIY Moxiglow and have glorious, glowing and evergreen carrier with Moxie and Moxiglow. Thank you very much for your kind attention.
I have used this for trabeculectomy also, where I could demonstrate the flow of aqueous into the trabecular meshwork, as well as if there is any leakage in the conjunctival suturing, I can take the suture so that we maintain the chamber even in the next day. So moxifloxacillin is very useful as an antibiotic, as well as lot of other properties are there, which can be used in other branches also, like in case of radiology, in case of cancer surgery, where we can use this moxifloxacillin and allow that thing to pass through the lymphatics and trace where the cancer cells probably might be able to trace it in which lymphatics, as well as sometimes probably in even radiology, we might be able to replace this for radioactive substances, where we might be able to demonstrate some of the lymphatics as well as the blood flow while doing the angiography. We are working with them, and probably we might be able to get something better for all of us.
Thank you, sir.
So very nice. Yeah. Very nice innovation, sir. I just have one question. Whether our normal moxifloxacin drops can be used, or we have to dilute in that particular
No,
concentration?
now the syringes are available, no? Pre-filled syringe by
Okay.
we can
Yes,
use this
yes.
safely. You need not prepare them now.
Okay. No,
In
no,
the
that is
past,
fine, sir. Yeah.
so
Okay,
we
the
can use
same
that.
drops which are available, that only can be used. And can you show the torch slide, sir, which you have shown in the video? That is easily available on Amazon.
Yes, it is
The
easily
UV
available. I
torch.
think it is easily available. It is approximately 600 rupees. Only thing you have to use a good batteries.
So you go on Amazon and just type the currency detection UV torch.
Yes.
This is basically to detect the currency, whether the currency is fake or true. And the 500 rupees currency or 2000 rupees currency can be detected. So with the same torch, just shine it on the cornea and the moxifloxacin glows so beautifully.
Is it different from the blue filter light of the slit lamp or a
No,
microscope?
It doesn't work like blue filter.
So, see, the blue filter wavelength is, cobalt blue filter wavelength is 420 nanometers. So moxifloxacin does not glow at the blue filter.
Yes.
We even tried the dental blue light, which they use for curing the dental glue. That also doesn't work. We need the currency detection torch.
Okay. Thank you, sir.
I think it is UVA.
Yeah, it's UVA in the range of around 390 nanometers or 395 nanometers.
It is around 600 rupees. Only thing is the illumination is little less in this particular light. So you have to use a proper battery so that you get a proper illuminations.
So you replace the cells every week or every 10 days?
Every week, yeah. You have to replace it weekly.
Sir, I have one question.
Yes,
can we glow the normal moxifloxacin or
normal moxifloxacin? Any brand moxifloxacin will glow.
In fact, if you ask me, I have tried to find out the amount of moxifloxacin actually they are giving in the drops or not. Because there are some local people who are making these drops. And if you glow over the drop, some of them don't have moxifloxacin.
what about ciprofloxacin? Will it glow?
No. Ciprofloxacin does not. Gatifloxacin glows and moxifloxacin glows. But not fluoxacin, ciprofloxacin, they don't have the fluorescence.
So which one better glow, Cipro or Moxie?
Moxie.
No, Cipro does not have any glow.
Gatti or Moxie?
No, Moxie has the best glow, sir.
Yes. Thank you, sir. Thank you. Excellent. Thank you.
Thank you, sir. Thank you very much. Now, with the
excuse me. Some of the innovators are abroad. Like Nishibant was in Vietnam, and Dr. Rushad is in ESCRS in Europe, Copenhagen, attending the conference. So he has just joined. Dr. Rushad, are you here?
Yes, ma'am, I'm here.
So are you ready to present?
Yes, ma'am, I can present.
So you can present. So
Sure,
over to coordinators. First, please introduce Dr. Rusha Shroff. He is son of Dr. Shroff.
Morning, Dr. Rushad. Welcome to the midterm conference. Dr. Rushad is currently working as a consultant and medical director of Shroff Eye Center, New Delhi. He completed his postgraduate training in ophthalmology from the Regional Institute of Ophthalmology, Trivandrum, and his fellowship in cataract, refractive cornea and optics from Narayana Nethralaya, Bangalore in 2017. He has 23 publications in peer-reviewed international journals. He has won numerous free paper and video awards at national and international conferences, including the Best Video Award in Cataract Surgery at ACRS and ECRS. He has also won the Best Paper of Session at the ACRS and APACRS meetings for his works on ocular surface disease and lenticulate extraction procedure. Kindly continue your talk, Dr. Rushad, please.
Thank you, sir. Thank you for that kind introduction. Is the slide visible to everyone?
Visible.
अमितेश जी नमस्ते. आपको तो सबसे पहले तो
I'm going to be talking about.
कि आप लोग मेरा इतना अच्छा किया अपने
Ma'am, please mute yourself. Bharti ma'am,
इतना सुंदर करा दिए तो.
Yeah, Dr. Rushad, please continue.
Yeah, I'm going to be talking on the Blink app, which is a novel diagnostic and treatment modality for dry eye. At the outset, I'd like to say that there are no financial disclosures related to this. Now, why is this important? Because what we've seen is that things like computer vision syndrome, it can be as high as 95 to 97% in certain populations. So the number of people suffering from dry eye or computer vision syndrome is pretty high all around the world. And very often we get this kind of patient who has ocular pain and discomfort, but the signs of dry eye, there's a normal Schirmer's, a normal TBUT, but the symptoms are disproportionately high compared to the signs. And this study has shown that the prevalence of dry eye disease, this was a study done by Dr. Titial and group, is almost as high as 32% in the age group of 21 to 40 years in North India. So this is a very big problem that we have to address. Why does blink matter? Because these studies talk about how blink tends to improve dry eye symptoms. The dry eye symptoms may become better if we manage to ensure that the blinks are complete and the blink rate is actually better per person. So with this in mind, our question was whether we can leverage technology at the population level, because we are tackling a problem which is quite prevalent throughout the population. And the purpose was to use a novel AI-based app and imaging modality to alter symptoms and tear metrics in subjects with evaporative dry eye and computer vision syndrome. So this was approved by our ethics committee. We included subjects with symptoms of computer vision syndrome, which is defined as a complex of eye and vision problems related to near work experience during screen usage. And we also looked at evaporative dry eye patients as well as asymptomatic screen users. So we looked at 44 eyes. It was statistically significant according to the sample size calculator that we used. We excluded patients who had a history of ocular surgery, contact lens use, on topical or systemic medication with acute inflammation, or any other morbidity within the eye as such. We use the OSDI scoring to classify these patients according to the OSDI as mild, moderate, and severe dry eye disease. And then we did statistical analysis using MedCalc, and the normality of data was checked with the Shapiro-Wilk test. We subjected these patients pre and post intervention, which is 2 months of using the app that I'm going to demonstrate. We did not give these subjects any eye drops. So we looked at the normal dry eye metrics like Schirmer's, non-contact TBUT, tear meniscus height using the oculus keratograph. We looked at aberrometry with the eye trace, and we used our novel thermography device that looks at the ocular surface temperature to actually look at temperature changes in the ocular surface, which are suggestive of evaporative dry eye. This is the small thermography device that you can see, that gray box in that video with a small screen to actually analyze the blinks. This is seen in two modes. This device can actually be used in the restricted blink mode, where we ask the patient not to blink for as long as possible, and we record the changes in ocular surface temperature over 10 seconds. And also in the normal blink mode, where the subject is asked to blink as they would normally do, and we look at the ocular surface temperature changes in both of these. The color scale for the thermography device is similar to, say, a Pentacam or any of these devices. Cooler colors, blue, etc., look at cooler temperatures. Warmer temperatures are seen in red, as you can see in this color scale. Now, coming to the app, it's called ID. This is freely available on Android systems, so you can download it on your mobile phone or on a PC or on a laptop. Basically, with Microsoft and with Android, it's available. It's not available on iOS as of now. So this app has unique reminder features. You can see this blink reminder, which is either fixed or smart. Fixed means that you set a particular time in which it will keep reminding you to blink. So it has an auditory prompt as well as a visual prompt. What you can see in the top here is that icon, and that will tell the person to keep blinking correctly at the correct point in time. You can change the size, the position, the shape of this icon, and the auditory reminder, if you don't want to see something popping up in front of you, it can be done with the help of just an auditory prompt in the form of a beep. So this is a video of the app being used on a desktop. You can see you can set the app in different modes. The audio can be turned on and off, as you can see over here. And it also has the feature of reminding you about the 20-20-20 rule. As you could see that blink which came up there. So it just tends to tell you when to blink and how to blink properly. And in the smart reminder, it analyzes your blink pattern. If you're not blinking completely, it will tell you to blink. And the 20-20-20 rule, as you can see here, it's asking you to take a break and look away from the screen. So it's basically enhancing your ability to blink properly. Now, what we did was we looked at our results in terms of these various different blink parameters. This was done prior to the intervention and after the intervention. So you can see that though a lot of these did not achieve statistical significance, there was an improvement in the blink rate. The blink duration also improved. The interblink interval became less, which means that the subjects were blinking better in terms of time. Sorry. And your partial blink percentage showed a significant improvement. That means the number of partial blinks went down. The thermography severity score, which talks about evaporation of tears, also became better. So in terms of ocular surface temperature changes, it became more towards the normal. Now, the traditional parameters in terms of Schirmer's, TBUT, lipid layer thickness, etc. Schirmer's did not show significant change as we would expect because it's more evaporative dry eye rather than aqueous deficient. The TBUT significantly improved. The lipid layer showed improvement, though was not statistically significant. And the interesting thing here was that the aberrometry showed a significant improvement. So quality of vision in these patients also went up along with the tear meniscus height. Now, we did a subgroup analysis, what you can see over here as well, where we classified these subjects according to the dry eye subjects according to mild, moderate, and severe OSDI scores. And these are all pre-intervention parameters that you can see here. There was a significant difference in the OSDI scoring, the non-contact TBUT, and the Schirmer's, which after the intervention, there was no significant change in difference between the Schirmer's and the non-contact TBUT. So that actually shows that after the intervention, the dry eye parameters again got better. Even in these various different subgroups, they became closer together. This graph actually illustrates this point well. What it's actually showing, it looks like a busy slide, but if you see, the first thing is that normals pre the intervention were about 50% of the subjects, and post the intervention was 73%. The mild OSDI score, mild dry eye patients, pre the intervention were 36% and post were 18%, and moderate was 9%, which became 5%. What this actually means is that the mild and moderate symptomatology subjects are converting into normal. So you're getting a shift of these patients from symptomatic to asymptomatic just by doing proper blink hygiene without using any eye drops or medication as such. Of course, in the severe group where it's because of ocular pathology, this did not help very much. And that's why there was no change in the pre and post in the severe group. The limitations of our study were, of course, a smaller sample size. This is a pilot study and a shorter follow-up duration, although we are taking care of this by doing a larger study right now. And it's not available on iPhone or on Mac systems as of now. So what was known was that this Osaka study showed that dry eye not only affects the eye, but it has severe effects on the quality of life, like lower exercise levels, lower productivity, lower happiness rating. And just by doing this, by improving digital eye strain symptoms, you can take care of a lot of these issues which are significantly affecting the productivity of subjects. So computer vision syndrome is a growing public health concern. What our study adds is that this is a simple and inexpensive tool. The app is freely available for ensuring blink hygiene, improving objective and subjective tear metrics without any pharmacological intervention. And as the app is available on smartphones as well as desktops, it can prevent development of more severe dry eye and help reduce severity of evaporative dry eye. Thank you.
Thank you, Dr. Usad, for this excellent innovation. Judges, any queries, please?
Yeah, a very nice presentation, Dr. Rushad. I just have one question. The app is it based on the timer based, or does it sync with the camera and keeps on, means the desktop, this thing, whether you're blinking
It's
or
based
not?
on a camera, sir. It's based on the camera, both on the laptop, on a desktop. So on a desktop, we had actually done this in a lot of our call center employees. We used a webcam. We just attached that to the desktops which didn't have a camera. But if there is any camera on the phone or on a laptop, like all our laptops have cameras, so it works based on that. So it's actually analyzing your blink pattern. And like I said, there's a fixed and a variable blink option. So fixed will, regardless of how you're blinking, it will tell you every 5 or 6 seconds, or you can set it to the time that you want, that you have to blink. If it's on a variable blink or it's a smart blink mode, what happens is it analyzes whether you're blinking completely or not. So the algorithm basically is told to detect if the two lids are meeting when we blink, the upper and the lower lid. In case they don't, it will still remind you to blink. So it kind of takes care of partial blinks that way. And it won't then prompt you at exactly the same time if it's in a variable or a smart blink mode.
Okay, so it will remain open in the background in your mobile or desktop for monitoring your eyes. Yeah.
Yes, the only drawback which I have seen so far is it kind of drains battery a little faster on your mobile because it runs, but you can continue to run any app. It's not like you have to keep that on and you won't be able to do anything else. You can continue to do your normal functioning. It will keep running in the background on its own.
Okay. No, I was just searching when you're presenting on the apps, this thing, App Store. So it was mentioned that it is not running in the background and like that in the screenshot. So that's why I just asked whether, because for tracking your eyes, it will need to run in the background.
It does.
Yeah,
It runs in the background. I'll see why it doesn't say that, but yeah, it runs in the background. It has to run.
Sure, it's a really nice reminder app. Like we have water reminders to drink water. It is like a blink reminder. Really
Yeah,
nice.
it's a very
Congratulations.
simple reminder for that.
Yeah.
Thank you.
Thank you.
Yeah, so the human beings are now being controlled by the watch and the blinkers and the water drinking and all that. Oh my God, we are being controlled. Yeah.
So even the breathing reminders. In the Apple Watch, there's a breathing reminder. Very nice, Dr. Rushad. Congratulations.
Thank you, sir. Thank you.
So if there are no queries, we move on.
So, Dr. Rushad, again, congratulations on that very app innovation for this period of high technology and smartphone addiction. When the camera is on, is it uh, taking a live video or is it clicking pictures occasionally? Is there any privacy issue? What is the
So
what is the
the
method of the pictures?
excellent question. Basically, it is taking a video of your eyes. The data is encrypted so that it's not actually looking at your iris patterns and stuff like that, because we knew that that would become a question about privacy and things like that. So it's constantly monitoring every second of your blink. It's in fact monitoring in milliseconds. The amount of data that's generated is quite a lot for each particular moment of how your eye is actually blinking and for the time that it's on. But the data gets encrypted in such a way that you cannot actually use it for identification in any way.
When the data is being stored on the phone, would the phone storage also be used up along with the battery?
No, it's not the storage that's being used up. It's connected to cloud, so it doesn't specifically use up the storage of the phone. It just uses the battery. It's basically because the
So
camera
it
is
just
running continuously.
captures and then analyzes and deletes. So it
Yeah,
doesn't store it. Okay, perfect. Excellent, excellent. It's very apt for this smartphone era.
yeah. I think it's a simple thing to do, and it's been working very well in terms of just reducing the requirement of eye drops also to a fair extent.
Okay, thank you, sir. So we now move on to our next presenter. The next
Please take Dr. Omar Rashid.
Yes, ma'am.
He's
We are
waiting.
taking. We are yes, ma'am. We are taking him. I would like to call Dr. Omar Rashid. He is the medical director at the Perfect Visions Eye Hospital in Srinagar, and he will be talking about his innovation in the corneal dissector for femtoless manual corneal allogenic intrastomal ring segments. So I'd request Dr. Omar Rashid to start his presentation. Thank you.
Good morning, all of you. I hope I am audible.
Yes.
Yes, you're audible.
Yeah, at the outset, I would like to thank JHOS for making me a part of this program. So, without wasting any further time, I would straight away go on my presentation. Is my screen visible?
It's visible. It's visible.
So, I will be presenting my innovation, which is a corneal dissector for manual intrastromal allogenic ring segments. CARES, as we call it, involves just a moment. It involves creation of an intrastromal channel using femtosecond laser and a microkeratome suction head. So manual CARES described by Parker et al. Uses an intact corneal separator. However, it still requires a costly microkeratome suction head system. So my simple innovation bypasses the laser system and the microkeratome suction head to create intrastromal channels. So now if we go into the cost of making an intrastromal channel using a femtosecond laser. So average price of a femtosecond laser machine is in India is around 4 to 6 crores. Cost of a femto dock, which is disposable and has to be changed after every patient, is around 6,000 rupees. And then if we talk about the annual maintenance charges, it is roughly around 30 to 40 lakh rupees per machine. So this is clearly beyond reach of most of the ophthalmologists in India. And most often than not, the patients are not able to afford this service, even if it is available at the center. So my innovation, it creates a technique that is somewhat similar to manual cares, which was demonstrated by Parkett et al. However, I do not use a microkeratome suction system to stabilize the globe. I use a modified corneal dissector, which I call OR corneal dissector, which has sharp blades and a large diameter ring to create greater torque effortlessly. So on the left-hand side, this is made by the AJL surgical system. This is basically used for manual intacts. But you can see that the diameter of this blade is much smaller, and you need to have a microkeratome suction head device to create to pressurize the globe and to create these channels. On the right-hand side is my innovation, which does not require any laser, does not require any microkeratome suction head system. So if we compare the manual cares cost, this prototype manual cares dissector, which is a set of two, right and left, that is clockwise and anti-clockwise, costs around 10,000 rupees at present, which the cost is going to come down because the product is in R&D phase, and maybe in 5 to 6 months time, we'll be able to develop this in disposable form. So drastically bringing the cost down to around say 800 to 1,000 rupees. So this is the prototype which is ready and running. I've been using it from last 2 years. So I'll skip this video, which shows how we can make these segments. These are just simple refines. We use these simple refines to make these segments. So this is a 1.5 mm segment, which is then stained by trap and glue, divided and then dehydrated for further use. So I'll go to my main video. Here we are marking around 190-degree apart these two incisions. We use a 250 micron blade. It's a partial depth blade. We need a 250 micron depth incision. So this is the left eye of the patient, and we are planning to implant care segment in infero-temporal part of the eye. Then we use a simple crescent blade, what we call as an initiation pocket. So this helps us to judge the depth. Like if I created a 250 micron blade, this helps us to just guide us further into creating this channel. So now comes the dissector, and we gently rotate it around its axis to create a 2.5 mm wide channel. So the design of the refine is such that it is not going to perforate because it's always parallel. It has no angulation. The channel is created. So this is the next video, same patient. We are inserting a previously made stained and dehydrated segment. So these are simple instruments, just a corneal forceps and a reverse Sensky hook. Just guide it using this reverse Sensky hook. We trim the excess tissue, flatten out any irregularities. This case is totally sutureless and place a BCL later on. So now we come to the results. These are immediate post-op results. You can see some staining. This is because of the dye. And these are about 2 to 3 weeks later. In some cases, we apply a suture, which we remove after 2 to 3 weeks. And these are the topographic results. Superior, you can see pre-op, the cylinder is around 10.5, which has drastically come down to 4.85. Again, on the left-hand side, this is the pre-op picture, a cylinder of around 7.65, which comes down drastically to around 1.7. These are the refractive results. This is a case of pellucid marginal degeneration where we have placed two segments up, around 180-degree apart. And on the OCT, you can see the segment sitting very nicely in the intrastromal space. And you can see on the topographic picture also the astigmatism is getting regularized. And this is the topography of the case which I just showed you. And you can see again the cylinder has come down drastically from around 4.66 to 0.99. So in conclusion, the clinical implications are manual cares is an alternative to femto cares, uh, as it has been shown in previous studies. And manual cares using OR dissector can be safely performed by every corneal surgeon without investing in expensive and high-end equipment. Learning curve is not so steep and can be learned. With further modification and refinement in instrumentation and technique, a standard protocol can be formulated to make the procedure more consistent and predictable. Thank you very much.
Thank you, Dr. Umar, for your innovative idea. And now I'd last to ask the judges for their queries.
Dr. Omar, how does your device differ from Dr. Susan Jacobs' device?
Yeah, Dr. Susan always uses a microkeratome suction head to create, because the device that they use, that is basically a separator. It is not sharp. So they have to use a microkeratome suction device like we use in LASIK to pressurize the globe and stabilize. Because with that pressure, with that device, you can just hold the eye and use the other instrument to create a channel. So if you use that device in a non-pressurized eye, you will not be able to create this channel.
But here in your case, you have to dissect with the crescent blade, and the dissection is quite wide. So is it not going to weaken the cornea?
So it is not going to weaken because we are augmenting it with tissue. Because we have created a gap and we are augmenting it with a tissue. So it doesn't cause, because we have almost cases we have been following up now for around 2 years. And same is the principle with femtosecond laser as well, because there also you are creating an incision and you are creating a channel. So basically it is a tissue augmentation that helps in not weakening the cornea.
Another question is, why do we need microkeratome? Suppose if I have only the suction ring of the microkeratome and use a phaco machine to create 65 mm vacuum.
So basically, I have not used a manual suction creating device. My only concern is I don't know how much pressure I am creating with, maybe if I use a 60 ml syringe or something like that. I'm not sure about.
No, I'm asking about phaco machines IA mode. Put the phaco machine in an IA mode and set pressure to 65 and press the foot pedal full.
Yes.
And use any microkeratome's ring. I mean, we don't need the whole microkeratome. I'm just asking you this as a possibility.
You're right, sir. We could do that, but I think for that we need to maybe enter. We need to enter the AC. I didn't get your question.
No, no, we don't need to enter the AC.
We have to take Dr. Prithvi after this.
Okay, fine.
We have to take Dr. Prithvi after this. Dr. Prithvi.
Yes, Dr. Jagdeep.
Dr. Prithvi will be the last innovator. After that, we will take the judges' presentation.
Okay, my concern was, while starting the incision, you are making a cut by the crescent blade. The depth has to be measured, and you do not know how deep you are going with the crescent, which is not marked anywhere. Number one, and number two is, while making a tunnel with the crescent blade, so the distance from the center to the periphery, you do not know how far you have gone from the center. And number three is when you have to pull your implant from the other side. So the whole the tunnel has to be complete. So probably you'll have to go through the other end also. Could you please clarify on that?
Yeah, so normally in case of larger tunnels, so I'll come to the question number 3 first. In case of larger tunnels, which are more than 120 arc length, we usually make 2 incisions so that we can push as well as pull. Through one incision, we can push using a reverse sense key, and the other incision we can use to pull the KS channel. So coming to the question of when you're making a tunnel using a crescent blade, initially the initial incision that we make is only 250 micron depth. So we usually do not take cases less than say 350 microns. So if the minimum point is less than 350 microns, we usually don't take those cases for manual cares. So when we are making a 250 micron depth, you are surely not going to perforate. And the angulation of the instrument is such that it is never going to perforate because it always remains parallel to the iris.
Okay, thank you.
Very nice. Congratulations, Dr. Omar.
Thank you, sir.
Now our next presentation is from Dr. Prithvi. Dr. Prithvi was formerly Medical Officer, Department of Veterinary Service in Arvind Eye Hospital, Coimbatore. His key achievements are as follows. He has published more than 25 articles in prestigious PubMed index journals, delivered more than 150 scientific presentations at renowned international, national, and state conferences. He has led instruction courses as Chief Instructor at AIOS, KSOS, Co-Instructor in APOA, YOSI, TNOA, and workshops mentoring future generation of ophthalmologists. His awards and accolades are as recipients of more than 35 awards from esteemed ophthalmic society. He's a reviewer of few journals as such APO, IJO, KJO, and TJORS, SRs. Kindly, Dr. Prithvi, present your presentations, your innovations. Dr. Prithvi Chandrakant.
Yes, sir. Thank you for the introduction, sir. I hope you can see my presentation.
Yeah, you're visible and audible too. Please continue.
Thank you, JHOs, for having me here. So I'll be talking about DOTS, Documenting Trauma with Smart Scope Kit. So as we all know, that eye represents just 0.27% of the total body surface area, and 4% of that is the facial area. And the eye is a third organ to be affected due to trauma injuries. So when this happens, it is a major cause of visual morbidity, and the incidence is very high in developing countries such as India. So it becomes very important for us because the global annual incidence of the ocular trauma is around 55 million, and worldwide blindness due to this is 1.6 million. So how is it, how can we, what is the important thing that we have to do in ocular injury is medical history, one thing, the examination, which is the utmost importance, and then the management. So when all these things are very important, some few things which needs is we need documentation. And documentation because we need to plan our treatment, we need to counsel the patient about the prognosis, and you need it for teaching. And also one of the most important thing during ocular trauma case is for the medical legal aspect. And so the problems right now is that we use paper medical records, which is disorganized, illegible, confusing, and EMR, which is time consuming, inconclusive, and inaccessible and expensive. And there are multiple articles suggesting that we need to go into photo documentation. That is the most important thing that we need to do right now. But in our clinical practice, in most of the clinical practice in our country, we don't really have something for photo documentation because it is expensive, because there is no accessibility, availability is less, it is very bulky, portability is an issue, and it is not very handy. That's where we come in with the Smart Scope Kit. So this Smart Scope Kit is a must for every ophthalmologist. And this is something very innovative because it is very frugal, because you can do it yourself. You don't really require to depend on any instrument as such. You can make it yourself. So how can we do it? So one thing is for visual acuity examination, you can use the Eye Handbook application, which is free of cost in both Android and iPhone platforms, with which you can use it to test vision test. You can use Amsler Grid, you can use color vision test. Everything is there for free in this particular app. The second thing which you need is the trial frame, the pinhole, the occluder, and a +10 diopter lens, just for documenting the visual acuity. The next one are the investigations. So investigation, few small things, that is BP apparatus, torch, pulse oximeter, glucometer, dilating and anesthetic drops, syringing cannula, and these are the other things: forceps, sterile 26 gauge needles, sterile slides, wipes, fluorescent strips. So these are all the investigations that we can include in the smart scope kit. The next one is the eye everter and the universal speculum, which can be used to evert without touching the eyelid. You can use the eye everter without using the hands. And then we go to the ASPI device that I have made. So this is basically a chart paper which is being cut into 10 centimeter to 1.5 centimeter. Stick a double-sided tape, make a small hole with a paper puncher, and use a 20 or 15 diopter IOL. So once you keep this IOL in this particular hole that we have made, and then attach it to the smartphone primary camera, it becomes a macro camera, and then you can take images of anti-segment without a slit lamp and as good as a slit lamp. So these are all the images that we have been taken from the ASPI, and you can see all these kind of trauma related images that can be taken for documentation for the for any ophthalmologist. So this is ASPI. Then you have the shear tonometer to check the IOP, and then we have the ASPI gonio. So if you take a 6 or 8 diopter IOL, you can convert the ASPI into a gonioscopic device. Along with the gonio lens, you can take images of the angle. So this is a photo of angle recession which has been taken due to the trauma. So this is another IOL scope where you can use this. This is just for information that we can use IOL scope for 430 IOLs which are stuck one upon the other on top of a smartphone, and then this can be used to take images of the parasites and other microorganisms. Then you have the Scooby-Doo, where you have a cobalt filter also attached to the ASPI, which will coincide with the flashlight, and this will help us to do the fluorescent staining of the eye. So over here you can see how a seed is positive due to a corneal entry can be documented, and this is also video documentation, not just photo. So this becomes very easy for us to do without a slit lamp. So these are the anti-segment imaging devices, and then we have the posterior segment devices, that is the trash to treasure red cam, where you can use a hand sanitizer bottle, cut it according to this shape, this particular shape, and then you can put the 20 diopter lens onto it, and then the other end can be used to put the smartphone. So once you've done that, you can take images of the posterior segment, and you can take without a posterior segment imaging device, and all these are the pictures that we took of the trauma related posterior segment images that can be taken by this particular thing. So these are all the components of Smart Scope Kit which can be used. And we had a small pilot study, and you can see these were the results that we had. The cases that the photo documentation were done according to the different departments. And so this is an effective kit for documentation of trauma-related findings in places where photo documentation were not done. And it helps in counseling the trauma patient about the prognosis with evidence, and also can help any of the ophthalmologists in MLC cases, medical legal cases, where support of photo documentation is required. And this is a new age innovative do-it-yourself comprehensive kit, which can image finding ranging from anterior to posterior segment. And it is very efficacious and alternative to conventional instruments that we see in our daily clinic. Thank you.
Thank you, sir, for the presentation. Judges, any questions, please?
I think all the innovators are done. Presentation of all the innovators are done, and we have shared the mark sheets. In the meantime, they are preparing the mark sheets and they are giving the numbers. We are now going to pick up the judges' presentation. So over to the coordinators for introduction of our 4 judges, Dr. Jagdeep Kakadia, Dr. Kunal Mandalik, Dr. John Davis Akara, and Dr. Rajesh Shah. please introduce them, or you will do one by one?
Ma'am, we'll be doing one by one, ma'am.
Okay, so one by one, you take up first, start with Dr. Jagdeep Kakadia, his senior most.
Yes,
one
ma'am.
by one.
Of course, ma'am. Of course. So it's my privilege to introduce Dr. Jagdeep M. Kakadia. He is from Ashkardeep Eye Hospital, Bhavnagar, which is in Gujarat, India. His professional career and work experience involves he's in solo private practice since 1989 at Bhavnagar. He has performed more than 65,000 cataract and IOL surgeries, more than 5,000 anti-glaucoma surgeries, more than 5,000 pterygium surgeries, 500 dropless keratoplasties. He has done custom LASIK exclusive surface ablation in more than 10,000 plus sites. He specialized in dropless cataract surgeries also. Among his award, he has received Dr. Daljit Singh Innovation Award in 2023 by ISM SICS and Dr. Arun Mathur Oration Award in 2023. He has also received Newton in Ophthalmology Award. That was the Think Under the Apple Tree Award in 2019. He has got 10 State Orations Award. His innovations include Autofocus Pro IOL, which is a ringless progressive IOL, Omni Glow stereo coaxial illumination devices, which many cataract surgeons are using these days. UV Glow, we just saw that. That's UV devices for C3 or CXL. Omni Flow anti-glaucoma retrobulbar drainage devices. Omni Flow Supra, which is suprachoroidal shunt for glaucoma drainage. Terigo, a special large BCL for sutures and glue-free pterygium surgeries. Stila Flow, which is an autoclaval and reusable cassette and tubing for Boscan Long Sterilus machine. Moxiglow that we saw today, a device to really see the presence of moxifloxacin. And Lazorex, which is a laser-based toric axis marker. And last but not the least, Video Glow, which is a hardware, firmware, and a software to record, store, categorize, and retrieve and edit surgical videos. Our next judge introduction will be given by Dr. Pritesh.
Good morning, sir. I'm introducing Dr. Kunal Mandlik. He is a senior consultant, cornea and refractive surgery. He is the Deputy Director, Arvind Eye Hospital Eye Bank at Arvind Eye Hospital, Pondicherry, Joint Treasurer, Pondicherry Ophthalmic Association, Innovation Lab in charge at Arvind Eye Hospital, Pondicherry, Fellow of American College of Surgeons, FACS, International Training in Corneal Lamellar Surgeries and Eye Banking at University of Iowa, United States, University of Illinois, Chicago, United States, University of California, Los Angeles, United States. Wide surgical exposure to more than 25,000 surgeries in the specialty of cataract, corneal transplant, and refractive surgeries. Next, Dr. Kunal Mandlik.
So I have a request. I have a request. So I got the mark sheet from Dr. Kunal Mandali and from Dr. Rajesh R. I have to receive the mark sheet from Dr. John Davis Akara and Jagdeep Kakadia sir. I have received from two judges,
Yes,
Jagdeep Kakadia sir and John Davis Akara have to send. Okay, sir?
I'm sending you in 3-4 minutes.
After you finish your presentation, sir.
Okay. Thank you.
Okay.
Continuing regarding Dr. Kunal Mandlik, he has received Best Innovator Awards in AIS 2023, International Heroes of India Award at AIOC 2024, International Rising Star Award and Research Excellence Award at JHOSCON 2025. Received AAO Host on Ophthalmologist Grant for AAO 2024. He was a faculty speaker in many instruction courses, surgical instructor at national and international conferences, including American Academy of Ophthalmology, Asia Pacific Association of Ophthalmology. He is the organizing ophthalmology hackathon at Arvind Eye Hospital since 2020 to solve different ophthalmological problem statements. Many publications in peer-reviewed national and international journals in the field of cornea and refractive surgery. Next,
Thank you, Dr. Pritish, for that introduction. Now, I'll be introducing our final judge. The third judge, sorry, is Dr. John Davis Akara. Now, sir comes from a very beautiful state of Kerala. He is a glaucoma and a cataract and a refractive surgeon at West End Eye Hospital, Kochi, and also looking after the Chaitanya Eye Institute, Kochi in Kerala. His innovations include John does foldable fundus scope, which is an ultra-portable smartphone fundus camera. Now, fundus cameras are expensive and bulky equipment and not available to most ophthalmologists. Dr. John Davis Akara has designed and made a smartphone fundus camera which can be folded and fits in one's pocket. This patented innovation is currently being incubated at LVPI Startup Incubator after winning a startup challenge and aims to produce a very affordable device costing less than 20,000 that can be used by every ophthalmologist. His other important innovations include designing 3D printed glaucoma drainage devices, MIGS, and cataract surgery instruments. Using the technique of 3D printing by John Davis Akara has produced a few innovations. One is a 3D printed glaucoma drainage device, which currently is used for a wet lab practice. Another is models of MIGS devices like Kahooks, Dual Blade, and iStent. These are mainly for teaching purposes. And another is a drug-eluting lacrimal punctum plug. Yet another is a model of various surgical instruments like CTR, B-Hex, phacoprobe, and chopper. Another innovation is a large-size model of eye with cataract to demonstrate steps of phacoemulsification with the help of Dr. Rohit Rao. That was about Dr. John Davis Akara.
Now the next judge is Dr. Rajesh Rar. He has done his MBBS from RP Center and the video trained at Sankar under Dr. Mahesh P. Shanmugam. These were the introduction of the 4 judges. Now I request Dr. Kakadia sir to start his innovation, sir.
Okay, thank you so much, Jharkhand Ophthalmic Society. Is my screen visible?
Yes, it's visible. Okay. It's visible.
Right. So I'll start my presentation on laser axis. Hello, dear friends and colleagues. Today we are very happy to introduce to you laser axis, which is a selective laser for accurate capsulotomy. These two geniuses are source of our inspiration for this work. We do have financial interest in laser axis. You all know about our invention of OmniGlow. OmniGlow can convert any normal surgical microscope into a high-end stereocoaxial microscope. Laser axis is the laser avatar of OmniGlow, which can be attached to the bottom of any big, burly, heavy standard surgical microscope. Laser axis can perform round or oval capsular axis. These are our early stage experiments on grapes. Every time we get nice free cut, first we have to stain anterior capsule with brilliant blue dye of any good pharma company. Please don't worry, BBG dye is very safe for corneal endothelium and iris. In fact, it is safer than trypan blue. After staining the capsule and filling the chamber with visco, we stabilize the eye with a suction ring and focus the laser with 2 red dots on the capsule. And then with a press of the foot pedal in 1 second, the capsulotomy is performed. Capsule is cut by laser photothermolysis. Centration is manually done in reference to first Purkinje image. The free-floating disc can be picked up by forceps or be aspirated by the phaco handpiece itself, and then the phacoemulsification is performed as per routine. This is a case of small pupil mature cataract laser axis. After staining the anterior capsule, we now hold the eye stable with fine Thornton ring, and in 1 second, the axis is done. The green tone during axis is due to the automatic laser filter coming in and then going out. This is a case of pediatric cataract
the capsule of which is usually very thin and elastic, difficult to handle. After staining the anterior capsule, we can do laser axis. And after removal of nucleus and the lens material, we wash out the visco and then stain the posterior capsule. And then we can do primary posterior capsule laser axis and pick up the disc without disturbing the vitreous phase. And now we can inject the IOL of our choice. Here, this is a 3-piece IOL going in the bag. And then capturing the optic. So the anterior capsulotomy as well as primary posterior capsulotomy both can be very efficiently performed by the laser axis laser. Laser axis is also very helpful in subluxated cataracts. We can do capsular axis without any stress or stretch on remaining attached zonules. After staining, we can insert iris hooks for better exposure of the capsule. And after the laser axis is done, because rim margins are so strong, we can fearlessly insert capsular hooks also to bring the bag to the center. And of course, Sioni segments or Sioni ring has to be done in such cases. One more case of laser axis in subluxated lens with capsule retention hooks. By this laser, type 4 collagen of capsule undergoes a phase change such that the margin becomes very strong. In the scanning electron micrograph peak, the rim is seen like this. When we cut a thin plastic sheet with laser, same type of strengthening and reinforcing coagulation occurs at the cut edges of the plastic. Capsular margins are so strong that they can be stretched up to 10 millimeters without breaking. Capsular margins are so strong that even in a fully intumescent wide bulging cataract, there is never a chance of Argentinian flag sign. Pick up the disc with forceps and proceed with the nuclear emulsification as per routine. The central floating disc can even be aspirated in bimanual or coaxial eye handpiece. Thanks to biophysics of laser axis, it is impossible to get renegade axis not only in wide bulging cataracts, but even in high hyperopic eyes with shallow anterior chamber or positive vitreous pressure. This is a case of a fully mature cataract with anterior subcapsular fibrosis band. After staining, the laser axis is performed. Now we gently and delicately remove the central capsular disc. And then we can remove the fibrotic band. Capsular margins are so strong that we are never worried about the margins getting broken. Thickened, coagulated, and corrugated rim margin is distinctly visible like this. 1 year post-op pictures. These are the current specifications of laser axis. There was no epithelial or stromal burns observed, no additional corneal endothelial cell loss due to laser. no renegade rhexis in any case, no incomplete rhexis in any case, and no margin tear during phacoemulsification in any case. We are also working to include image-guided eye tracking in laserexis so we can get accurate centration in each and every case, so we can achieve a perfect overlap in all cases, monofocal, toric, or multifocal. Our hopeful desire is also to develop a tori-smart laserexis in future, which will leave tiny tags of anterior capsule inwards at the desired axis of toric IOL placement, so that we can do rhexis without any mental stress, with a smile on our face every time in every case. A point to ponder, not just for today, but forever. We all are created to create, because the Creator lives within us. Thank you, Jharkhand Ophthalmic Society in general, and Dr. Bharati Kashyap in particular, for inviting me to present this video here. And thank you all for your kind attention to laserexis, the future of anterior and primary posterior capsulotomy. Thank you.
I thought, sir, I'm going through a magical show.
Thank you, sir.
Fantastic, sir. Could you please go into little detail, because if where are you focusing your laser, to the anterior capsule surface, or in the capsule stroma, or behind the capsule, until what is the the depth of the cut? So because when you are dealing with a very hypermature cataract, the moment the capsule is cut, the capsule collapses, and the margin of these capsule, they become irregular, so they do not remain in the focus anymore. So what happens then? Very inquisitive, sir. Could you please, it will be a
hello.
very nice if you could explain these things.
Yes, sir. So the laser is focused.
Dr. Bharti, madam, please mute yourself. We are being interrupted. Sorry, but it's true. Sir, please go ahead.
So the laser is focused at the anterior capsule, and the depth of focus of the laser is plus or minus 200 microns than the anterior capsule. But it only cuts the anterior capsule, because this laser, this wavelength, will cut the collagen and not the protein. So it does not cut the lens fibers, it just cuts the anterior capsule. And the anterior capsule has to be stained with brilliant blue green dye. So BBG dye has to be used in order that the capsule absorbs the laser energy in a proper fashion, so that we can induce the thermolysis, cutting by the thermolysis. So staining is essential. And as to the hypermature cataract, once we have stained and then filled the chamber with the visco, then now the chamber is closed. There is no instrument which is going inside. In case of a rhexis, with the forceps or with the needle, when we enter through the side port or through the main port, there is a pressure gradient difference, and there is a chance for the visco to be slowly leaking. And the moment you puncture the capsule, the intralenticular pressure can try to rupture the capsule and create the Argentinian flag sign. But here it is a complete capsulotomy is done in a closed chamber. So the pressure in the anterior chamber and pressure in the intralenticular pressure does not have a chance to make the capsule to rupture. That is one thing. And the second thing is that the cut margins are coagulated as if you are cutting a plastic sheet or a thermocol sheet with a hot wire. So it becomes so strong that you take two Sinskey hooks or two Kuglen hooks and try to rupture, you cannot rupture the capsule. Manually also you cannot rupture. If you want to rupture this capsule, we have to use 4 Kuglen hooks from 4 sides,
And if we stretch this capsule from all four sides, that's the only time when we can create an intercapsular rupture. It becomes a very, very strong capsular margin.
Dr. Kakaria, the second thing is you have forgotten to mention that it does not get absorbed by the vitreous. So when you are doing a posterior capsular axis, we do not disturb the vitreous at all.
Right, that's correct. Thank you, RC, for reminding me that. So this laser does not cause any disturbance to the vitreous phase. So even if we do primary posterior capsulotomy with this laser, it will cut only the capsule without disturbing the antihyaloid phase.
And we can change the size of the posterior capsule also.
So how do you measure the diameter of the rexis, number one? And number two, how do you deliver this the laser?
Or the laser is delivered straight from under the microscope. You can imagine this as a laser avatar of the omnigloss. So the laser will come right under the objective lens of the surgical microscope.
Okay.
And initially we used to use suction ring to hold the eye stable, but if the patient is cooperative enough to hold the eye stable for a second, the rexis is already done in 1 second.
Do you have to adjust the strength of the laser? I mean, suppose if the capsule is fibrous or thick, or sometimes there are many a times you get the subcapsular fibrosis with a little bit of corrugations. Do you adjust anything anywhere for this?
No, the subcapsular fibrosis does not get cut by the laser, but the capsule gets cut by the laser because capsule is in front of the subcapsular fibrotic band. So we don't need to adjust the laser. Of course, so far we have not done any membranous cataract, pediatric membranous cataract. So I don't know about the pediatric membranous cataract, how much the laser power I'll need. But for all the other cases, the laser power we need is about 3 watts.
Sir, I have one question. So what laser are you using for that? Means like in femtorexis, we use femto laser. What frequency and...
Oh, this is a visible laser. This is a
Okay,
630. It's a visible laser.
And for as you said in posterior, to do posterior capsular axis, do we have to stain the posterior capsule again with the brilliant blue?
No, yes. You have to wash out all the visco after you have removed the cataract and all the cortical fibers. Then we go back, inject the air, stain the posterior capsule, and then only cut.
And for the anti-capsular axis, it is done under visco. The AC is filled with
Both.
visco.
No, both. Even the posterior capsular axis is also done under visco, but for staining, we have to first wash out the visco, then refill the chamber as if you are doing a second capsulotomy.
And this laser axis device, can it be placed, because we are using your OmniGlow devices also. So in Arvind, so can the both devices be used and fixed together, or
Yes. So eventually, when the laser axis will come, the OmniGlow will be taken back, and this will be OmniGlow come laser.
Okay, so at present, is it available means in the market, or it's just in R&D phase?
No, it's not. It's very expensive to make. So we just made 2 prototype devices, one for me and one for Dr. RC, for doing our pilot trials in-house. And it's a little longer road to get the CDCS approval and everything. But we are hoping that within a year or so, we will be in the market.
Thank you very much, sir.
And I'm glad to let you know that most probably it's going to be Oralab laser axis. Like Oralab OmniGlow, it's going to be Oralab laser axis.
Jagdeep sir, can you elaborate on the dye to be used? Because I think the previous doctor has spoken about trypan blue.
No, the trypan blue absorption wavelength of the trypan blue is slightly different, And for that, we have to use a laser which will be 590 nanometer. And 590 nanometer laser itself is very expensive. It costs nearly 70 lakhs rupees, the laser source itself. Whereas this 630 nanometer red fiber laser cuts the brilliant blue dye, BBG.
Yes, yes.
And BBG dye is, say, Trypan blue is costing around 100 rupees and BBG dye costs around 280 rupees. So we have to use BBG dye.
So how about including us in your project? Because I've been using the femtosecond laser cataract surgery. I'm sick of it after spending so much of money. So I want to be a part of this project.
It will be your honor, sir. It will be your honor.
And what will the marketing cost at the time when it's all produced? Approximate cost. I know it's very expensive and getting it done.
See, the cost of production is around 32 lakhs. And I think when we put it in the market, it will be something around 42 or so.
Okay. So
So
it'll be a nice thing to compare with the flax and
yeah. No, sir, here we don't need any contact lens or any, per case disposable, there is nothing. The only additional cost will be the brilliant blue dye, and the difference between Trypan blue and brilliant blue will be 150 rupees.
So, and one more thing, in flax femtorexis, we see cortical adhesions at the edge of the rexis, which is difficult to remove after after doing a femtorexis.
Right.
So, is the similar thing seen in this?
Oh. Yeah, that's very interesting question. Because in case of flax, the laser goes 300 microns down and it cuts the cortical fibers also. So you don't have the tags to easily engage it into the suction port of the irrigation aspiration handpiece. But here, this laser cuts only the capsule. So the epinucleus and the anterior cortex remains as is. So once the capsulotomy is done, the entire procedure is as good as a manual phacoemulsification and manual IE. So we have enough length of tags of the fibers to get it engaged into the aspiration port. So that difficulty is not with this. And also the femtosecond rexis is actually a can opener rexis. To be, if you go on electron microscope, it is like a postal stamp border. There are multiple holes and it takes 2 turns, and the second turn is slightly off by 1 degree or so. So it cuts the bridges, but still it is always like a postal stamp border with tiny holes. So there is a chance of a radial extension sometimes in case of the femtorexis. But here with this is a laser thermolytic cutting. So there is absolutely no chance. You take 2 Kuglen hooks and stretch it from one end of the anterior chamber to the other end of the anterior chamber, it will not break. If you want to break it, you have to use 3 or 4 Kuglen hooks. Then only you can break it.
Very true, sir. Very true, because they are basically micro
Capsulotomies.
Yeah,
Right.
capsulotomies. And they are very fragile. If you have to go behind the capsule, sometimes it many a times it gives way and it is the extension. But what you're showing, that is because of thermal, and the margin gets probably a little bit of coagulated and makes it a little stronger. This is fantastic. This is fantastic.
And plus, sir, we don't need a separate machine or a separate room for doing capsulotomy. In case of femto, if I just want to do capsulotomy with a femto, I'll need another machine and another table. Whereas here, this is integrated under the microscope. So your workflow remains exactly same as your normal cell. Only thing is, instead of using needle or forceps, we are using the laser to cut.
Magic, sir. Magic.
Thank you, sir.
Kakade sir.
Yes, sir.
Can you elaborate on the size of the rexis which you can do it with this?
Oh,
And
sir,
there is posterior.
Kashyap sir, this is very interesting question by Dr. Ramesh. So this is one of the simplest laser to build actually. I just have to tell my laser to write an O and the font size. So if I tell the laser to write a 4 mm O, it will write a 4 mm O. If I tell the laser to write 5 mm O, it will write 5 mm O. So, and that whole thing is controlled by a laptop. And if I ask the laser to write a 0, it will write an oval capsule. And if I tell that I want the 0 to be horizontal, then it will make a horizontally oval capsule. If I write that I want a vertically placed 0, then it will make a vertically oval capsule. So in fact, if I want a heart-shaped capsulotomy, that is also possible. If I want a diamond-shaped capsulotomy, that is also possible. Whatever you wish. It's just we have to tell the laser that you write. It's basically a marking laser.
Sir, I'm sure these flax people are out of the market. Out of the market, sir. Out of the market.
Thank you so much, sir.
Our next speaker is Dr. Kunal Mandalik. Please introduce our guest faculty coordinators, please.
Madam, a request. I would have to leave in another 10 minutes. Dr. John speaking. Is it possible that I present now, ma'am?
So, Dr. Kunal, can we take Dr. John Devi Sakara?
Yeah, sure. No problem. No issue.
Thank you, Dr. Kunal. Sure, madam. Thank you so much, ma'am. Is my screen visible?
Yes, sir.
Okay. So I'm Dr. John, and I'm going to be talking about my first 3D prints. So I'm in Cochin, Western Eye Hospital and Chaitanya Eye Hospital. I got into 3D printing while I was in Arvind, and it became a magic box. So I'll just show you some of the things I have made with that. This is a 3D model of an eye. So that is one of the things I was able to make. This is an article about all the things which are possible in ophthalmology with 3D printing. So let's go to the first one, which is the eye drop guide. So eye drop guide is a helping tool for patients to align their eye drops into the eye. So this was one of the 3D models which we printed. And if you see this on the right side, the 3D model is seen here. And the bottle is put into the 3D model and placed into the patient's eye. If you scan this QR code, you will get the video of the
Please
development
mute
of
yourself,
that.
please.
Next, let's go to the punctal plug which I designed. The punctal plug is a very small model. So to get that, you cannot use a regular 3D printing of the plastic-based filament deposition modeling. You have to use resin 3D printing. On the right side here, you can see the resin 3D printed on the punctal plug on the tip of a needle. And then you have the video and the 3D models here. And if you see here, the next one here is a glaucoma drainage. So that is also available. Then I am going to MIGS. So I'm a glaucoma specialist. So MIGS implants and instruments are another set of 3D models which I designed. You can see the KDB blade and the eye stand here. And these are the printed models of the KDB blade, the big model, the small model, and the large model of the eye stands. These can be used for teaching both patients and also to junior doctors. And these are also available on the National Health Institute of the US has a 3D printing website where I have uploaded them and also uploaded them onto Thingiverse. So you can download and 3D print these models yourself. This is another 3D use of 3D models. This is using an app called Object Merge 3D. So once you have this app and you print a paper cube from this, you can install all the models which you have downloaded onto the computer into this, and you can just virtually handle all these 3D models by picking them up with your hand. Yet another one is the eye surgical instrument. So that will be the cataract surgical instruments which I'm talking about. You see all these models, again, these are available there. And we have printed these models, including the BHEX ring. Another set of cataract surgical models we have used as big models. These big models can be used for teaching students the various steps of cataract surgery, including the phacoemulsification steps, and this helps to show exactly how the nucleus parts have to be moved around by using double-sided tape to stick the nuclear fragments to the phacoprobe. Mind you, all of these are 3D printed and color coded. The fundus red glow, the orange glow is from the fundus. The nucleus is yellow. The stained anterior capsule is blue. These are also available to download for free. Then, last but not least, I have designed a device called the foldable fundoscope, which is a fundus camera practically. It is you attach a smartphone to one end of this and put a 20 diopter lens in the other end, and then you can use it to take fundus photographs in a dilated pupil. So it's a smartphone fundus photography instrument. And I have patented this, and I will be coming out with this is the first model. This is the second model. I'll be coming out with a model which has inbuilt illumination and magnetic locking as well. So this is what I won an award startup challenge for in Hyderabad. And yeah, thank you for listening. I hope I have inspired some of the innovators and many others to take up 3D printing to build their innovations. Thank you.
So now the next presentation is from Dr. Kunal Mandlik. Kunal sir, kindly share your slides.
Yes, I'm sharing. Are my slides visible?
Yes, sir, you're visible and audible too.
Yes, so I'll be speaking on our journey of hackathon at Arvind Hospital, Pondicherry. So basically, we started our hackathon journey back in 2020, when during the COVID times, when we were free, we had a lot of time with us. So we were thinking what to do with it. Then our Chief Medical Officer, Dr. Venkatesh, came about solving our own issues, our own problems, what we were facing in our OPDs and OTs. So how to go about that? Then that time we thought of having an hackathons year at Arvind Pondicherry. So hackathon generally is a engineering term where they are having hackathons in the engineering institutes every year. Each engineering institute will have their own hackathons where they come out with different solutions for different problems as such. So what exactly is a hackathon? It's a sprint-like event where people from different fields come together and work for a problem statement. It normally we work for 24 to 48 hours, coming up with some prototype or with ideations. So at our hackathons, we first start collecting the problem statement like around 6 months prior to the hackathon dates, and those problem statements are shortlisted. Then each we have to have teams for the problem statement. So each team will have around 2 to 3 ophthalmologists, and as we have MOUs with different engineering institutes like IIT Hyderabad, VIT, and all, and private companies. So we have technical team experts in each team, like 2 engineering students will be there in each team. So then after that, after the teams are assigned, we assign one problem to each team, and they work for 24 to 48 hours continuously. And then they either build a prototype in those 2 days and present it on the last day, where we have the grand prizes for the top 3 winners. And either they build a prototype or they come up with an idea to go about in future. So here we have a short video about our hackathons. You can have a look at it.
Ophthalmology is more than a linear path. It's a prism of endless possibilities where one can branch out into multiple dimensions. Merging medical and surgical aspects of healthcare with the latest technological advancement and working towards enabling the same can be a very fruitful pursuit. Visionaries like Charles Kelman, the father of phacoemulsification, have brought in foreign concepts to revolutionize eye care while bringing light to millions of eyes. The first step would only be a poignant question: what if? Today, ophthalmologists are overworked and understaffed, caging their curiosity to provide quality eye care to the needy. Let's look at Dr. Akshay, an ophthalmologist fresh out of residency, curious to go beyond the routine curriculum. On the hunt for a fellowship program that suits him, he comes upon Aravind Eye Hospital, Pondicherry. He applies for a short observational stint here, eager to know firsthand about the work culture he's heard of.
Aravind, given its scale and pursuit of its purpose, continually encounters challenges. One of its founding values is to always find a way to provide care regardless of people's ability to pay. Innovation with wide participation from within and outside is one of the engines that propels Aravind. All such emerging insights and solutions are then transparently shared through Lions Aravind Institute of Community Ophthalmology to help others provide effective eye care, thus help eliminate needless blindness worldwide.
Walking onto our expansive campus, he's guided towards the Chief Medical Officer, Dr. Venkatesh's room, where he shares his viewpoints, interests, expectations, and concerns. The eagerness in him is seen, and the Chief has a knowing smile on his face when asking Akshay to take a walk around our facility, interact with the staff, and then return.
Hello Akshay, let me guide you through our facility. We have a double monitor system to reduce errors while connecting patient details. We have color-coded footprints along our halls guiding the patients to their respective clinics. In the OPD, we have the eye opener to help with lid opening and retraction. We also have the eye verter to help with easy non-contact lid eversion. Our standing slit lamp helps improve posture and spinal health amongst our doctors. Let me now take you to our operating theatre and the area for administering subtenous anesthesia. Here we have LumiZoom, where the user gets better magnification and clarity for providing easier blocks. At our wet lab, we see SAFE, spring action apparatus for fixation of eyeballs to provide proper fixation of goat eyes during training.
Where do you get all these ideas?
Hackathon. Aravind Hackathon is where innovation meets purpose. At the heart of the Aravind Eye Care system, we believe in the transformative power of collaboration and creativity. This event brings together minds from various fields and skilled eye doctors to synergize ideas and tackle challenges in advancing patient care. Our culture of innovation has been a driving force throughout our history, propelling us to the forefront of eye care excellence. This hackathon is a testament to our commitment to pushing boundaries and finding innovative solutions. Together, we build a future where innovation is not just a concept, but a way of life for us.
Akshay is enthralled by our institute's culture of innovation and lateral thinking, and has eagerly decided to enroll himself into the fellowship program. Dr. Venkatesh gladly welcomes him on board and suggests that he take part in the upcoming hackathon. Akshay chooses to take up an issue that is close to his heart since his early training days: how to enhance surgical training early in one's career. He envisions a program wherein a mentor can oversee the trainee's surgeries and hand movements, even remotely, and offer support whenever necessary. Through the hackathon, with the support of his team, Akshay came up with Golf, GoPro Operations Live on Facebook, clubbed with hand movement recordings. This was to aid surgeons with learnings in their first few surgeries. The feasibility and reproducibility take the stalwarts by surprise, and they are eager to implement the same in their systems. Akshay is overjoyed that he's provided a solution that will help improve training programs across facilities.
I'm Dr. Satya, a pediatric ophthalmologist, and this was the third hackathon I went to. So I've been working on problems related to squint evaluation, and to me it was an eye-opener on how quickly engineering students could understand squint evaluation and all that is involved in the process. This is something doctors struggle with. So they came up with solutions that was way beyond what our problem statement described. So working with like-minded doctors and engineering students has truly broadened my thinking and given me a bigger horizon on what is possible.
Here, we see a healthy culture of pursuing quality research with an inquisitive mind, looking at all available innovative opportunities. The system also helps bring ideas that cater to people in need through tech and product development support. A great example would be the saline load sensor, wherein entry segment phaco machines also have sensors to warn of saline levels, avoiding surges and intraoperative complications. Our sister concern, Orolab, has taken up the idea and has incorporated the same into their latest phaco machines to bring a higher standard of care to the deserving across the world. The XNIT method of scleral fixation of IOLs has also been developed at our center, with many iterations supported by the system and Orolab. We now have specialized XNIT kits available for commercial use, and the technique provides a secure and hassle-free way to ensure proper scleral fixation of lenses.
Hi, I'm Sandan Kotawala. I'm founder and CEO at Alpha Tech. We developed a virtual reality-based head-mount perimeter. So this is IVA, Intelligent Vision Analyzer. It's a VR-based head-mount perimeter that anyone can wear on the head and do the entire visual field test. Visual field test, which is typically done on big devices, can now be done on a VR-based perimeter. And Arvind has always been our support. Arvind has helped us throughout the journey, not just in developing a product, but in development, in clinical testing, and validation, as well as to help us to launch into the market.
Staying ahead of the tide and working with curious minds to develop solutions will further advance the field of ophthalmology while restoring sight to millions of eager eyes, waiting for that one bright ray of hope.
Thank you all. So I'll finish my presentation over here.
Yeah, thank you, sir.
It's really good to know they are doing a very great job. It's hackathon. It's very nice to start. Thank you very much for sharing with us your experience.
Most welcome. And this video was a AACRS Oscar Grand Prize winner and adding to our collection of other 8 Oscar awards previously.
But great.
Over to you, ma'am.
Yeah. So we have reached the end of the prestigious innovator session hackathon. So we really enjoyed, and now my secretary is coming with the mark sheet. The mark sheet they have sent to the coordinator room.
Ma'am, your video is paused. Will you please recheck your internet? Bharti ma'am. Okay, until Dr. Bharti will rejoin. So then our next presentation will be R.P. Tandon extramural oration. So Dr. Dolly Tandon, Dr. Vibhuti Kashyap are session coordinators. Are you there, ma'am, and Dr. Vibhuti? Dr. Vishali Gupta.
Request the coordinators.
Yeah.
Please. Dr. Anindya, please stop. What I am saying that after the extramural oration, we will announce the winner of the hackathon session so that they will get some time to calculate. Madam has joined. Madam, are you here?
Yes, Bharti, I have joined.
Vishali, madam, have you joined?
Yes, Bharti, I have joined. Yeah, I'm here.
Yes, yes. So, Dr. Dolly Tandon, first, Dr. Vibhuti Bhushan will introduce the oration. Dr. Vibhuti Bhushan, are you here? If he's not there, then Dr. Anindya, I request you to introduce Dr. late Professor R.P. Tandon.
Sure, ma'am. Just now.
हाँ हो गया.
Great honor to introduce Dr. R.P. Tandon. Though personally, I'm not, very much. I have never
Please
met him actually.
show the slide. Premlata, please show the slide.
Yeah, Premlata, will you please go to slide of Dr. Tandon?
Premlata, please.
So
please show the introduction slide. Okay, in the meantime, you can keep
I can
reading.
start. Yeah, sure, ma'am. So, Dr. Rajeshwar Prasad Tandon is no longer with us. He was one of the most prominent members of our fraternity. Those of us who had the privilege of knowing him would fondly remember him as a distinguished ophthalmologist and a wonderful human being. He was very knowledgeable and had immense wisdom. If there was one trait that defined him, it was his quest for knowledge. He was a voracious reader and he imbibed everything that he read. He could talk on any subject from ophthalmology to oceanology, from philosophy to politics, from science to economics, and from history to the latest gossip. He was a great communicator, and once he got onto a topic, you could not but be charmed by his clarity of vision and oratory skill. He had a natural gleam in his eyes and a mesmerizing smile. Dr. Tandon had his early education at the St. Michael's School, Patna. He did his MBBS from the Prince of Wales Medical College, Patna in 1954 and MS in 1957 from the same college. He then joined the Bihar Health Services and was posted at Bodh Gaya. He left for London in early 1959 and did DO, RCS and RCP, followed by FRCS in 1964. He came back to India in 1965 and joined Rajendra Medical College, Ranchi, and worked there for the next 10 years. Dr. Tandon left government service in 1975 and went into full-time private practice at Ranchi. With the liberalization of the economy, he was quick to grab the opportunity to upgrade his clinic with the latest equipment and technology. He was very popular among his colleagues. To them, he was just Tandon. He was clinician and surgeon par excellence. His clinical knowledge and wisdom was immense, and most of the who and who of Ranchi flocked to him for advice and treatment. His clientele also came from all the nearby areas of Ranchi. He was one of the founding members of the Academic Medical Forum. He was its founder secretary, wrote the constitution, and later became its president. AMF honored him in 2000 as the most outstanding ophthalmologist of Ranchi for his leadership in leading the forum to its present position, and above all for his being the fine model of a cultured human being. He was President Bihar Ophthalmological Society during 1989 to 90. Jharkhand Ophthalmological Society honored him with Lifetime Achievement Award in 2006. He commanded a versatile personality during his lifetime. He authored many books on varied subjects. For example, Successful Man, Transformation to Love, Mind, The Karmic Laws, etc. To name a few. Apart from academic forums and societies, he was also a member of Sri Satya Seva Trust and Sri Satya Organization. Dr. R.P. Tandon left for his Heavenly Award on 3rd December 2011. He leaves behind a great legacy. His wife, Mrs. Saroj Tandon, his 4 daughters, and their families are doing well. And we are proud to have one of his daughters, Dr. Dolly Tandon, as an active member of the Jharkhand Ophthalmological Society. So it's thank you very much. Now, Dr. Bharti Kashyap, would you like to proceed?
Over to Dr. Dolly Tandon. Dr. Dolly Tandon.
Yes, thank you, Dr. Bharti, Dr. Anindya. And it is my proud privilege to introduce Dr. Professor Vishali Gupta for the Dr. R.P. Tandon Oration Award. Dr. Professor Vishali Gupta is a very well-known name in our ophthalmological fraternity and presently Chief of VR at PGI Chandigarh. She is holding and also previously held many important and prestigious posts like President, International Uveitis Study Group, Vice President, Vitreoretina Society of India, Past President, Uveitis Society of India, Member Scientific and Bylaws Committee, Macular Society, Chair Program Committee, ARVO. She has to her credit many PubMed indexed publications, 416, over 16,000 citations, and 68 high index. She has presented 1,087 lectures and international lectures being 568. She has to her credit, she is to her credit one of the top 2% world scientists in Stanford ranking since the last 6 years. She has edited 6 books and book chapters 87. She has 2 US patents to her credit. She has been awarded with P. Shiva Reddy by AIOS, Colonel Rangachari by AIOS, Steph Foster Oration during ARVO, Shyamala Bhaskar by LVEP, G. Venkatswamy Endowment Lecture by Uveitis Society of India, Alumni Oration and awarded by Shankar Netralaya, Sadguru Oration by Sadguru Netra Chikitsalayah Chitrakoot. She is among the top 100 most influential ophthalmologists in the Asia Pacific from 2022 onwards. Thank you, Dr. Vishali Gupta. Eager to hear about the road less traveled.
Thank you very much, Dr. Dolly. Thank you very much, Dr. Bharti. and the Jharkhand Ophthalmological Society for giving me an opportunity and honor to remember Dr. Tandon. So the topic that I have chosen for today is the road less traveled. Let me begin my journey on this road. It was year 1995. I had just joined ophthalmology, my first year resident at PGI Chandigarh. So there is a report of about 5 cases from India where the eyes were removed because the diagnosis of TB could not be made, and a beautiful publication by Dr. Jyotirmay Biswas showing the histopathology of the eye. Now, as a resident, I thought like TB has a treatment, and why are these ophthalmologists enucleating the eye for TB? So this was something which I took up as a challenge. So that was my first time where I learned that TB is causing blindness because we won't recognize, we won't even treat ocular TB because we believed it did not exist. So this is the beginning of my journey, and the road that I took was less traveled because the more traveled road is on the left, the cataract surgery, and the less traveled is on the right, that is the uveitis. While eradicating blindness due to cataract is, I would say, easy, but it's easy, honestly. Whereas the blindness due to uveitis is a tough task and it's not very popular theme. What exactly is blindness? Blindness is not a disease. Blindness, if you go back to Picasso's work, for some of you who love art, there was a dark period in Picasso's life, and where he painted all the beggars, street urchins, old, frail, and blind. Because once you make a person, I'm not saying you make a person blind, once a person is blind due to something which you fail to treat, the blindness is not a disease. It brings about the marginalization of that person in the entire society. So how do we diagnose ocular TB? And this is the picture taken of Robert Koch, which was, almost 100 years ago, 1905 in Berlin, when he discovered treatment for TB. So this is him just coming out of after receiving the Nobel Prize in Medicine. What were we doing in ophthalmology 100 years later? Not even treating the disease, which was so very, very treatable. So I was a first-year resident, as I told you, and I had a mentor, Professor Amod Gupta, blessed to have him in my life. And this is one of my favorite pictures in medicine. This is called The Doctor. Now, if you look at this picture very carefully, this is the picture belonging to a child suffering from tuberculosis. If you look at the doctor is thinking, like, what can I do for this child? There is a light coming from the window, which means that he has been awake throughout the night looking for the treatment. The parents are there, but they are in the background. They are not the ones who are primarily concerned. The primary concern is the doctor. And even the medicines are on the side of the doctor because he's making sure that he gives it himself. So we thought, how can we diagnose ocular TB so that we don't have to enucleate the eye and prevent blindness? That was the time Professor Gupta gave me an idea that there is now PCR available. Let's start doing PCR from the intraocular fluid. Sure enough, we started doing it. I was very excited, and this is me way back in 1999. I presented my work about PCR positive for tuberculosis in some of the patients with uveitis. Well, this was the meeting, and guess what? Lot of criticism about how can we use PCR for ocular TB. And this is what I want to tell our younger colleagues out there, that whenever you say something, you will be thrown stones at. But what do? When people throw stones at you, you turn them into milestones. Let the senior people not discourage you if you find something new. For me, it was they said, oh, TB does not exist in the eye, so PCR is false positive. Somebody from a very premier institute, a big professor said, oh, we sent water for PCR testing and it was positive. Should it discourage you? No. You follow your path. Today, I can say PCR was truly not a magic, but it gave us a tool with which we could define various phenotypes, and these are granulomatous uveitis, hypopyon, snow banking, vasculitis, tuberculomas, and serpiginous-like choroiditis. Now, when we look at these phenotypes, we understand that they are TB. They need anti-TB treatment. And when we add anti-TB treatment, the recurrences rates would be reduced dramatically. Before we said that TB could cause serpiginous-like choroiditis, generally serpiginous choroiditis was being treated with steroids and immunosuppressive drugs and had 100% recurrence. So people were using almost 3 immunosuppressive drugs to control it. But with our discovery or with our introduction of this term, adding anti-TB drugs, no need for immunosuppression, and we could achieve remission in almost 90% of the cases. Multiple publications came that just addition of anti-TB helps in reducing the recurrences in more than 80% of the patients. And well, it did take us about 100 years to start treating ocular TB, but we finally reached there where we made ocular TB being recognized and the need for treatment. This is the year 2015 when my mentor, Professor Amod Gupta, kind of superannuated, and this is the picture just taken that day. What had we achieved till then? Till 2015, we all understood that TB is a very well recognized form of extrapulmonary disease. We all thought that we have done so much work, so everybody would recognize, and even the DOTS program and all should be able to give anti-TB drugs to our patients with ocular TB. However, that was not true. Ocular TB till 2015 was not even considered as a part of extrapulmonary TB by authorities. And this shocking revelation came to me. There was a roundtable conference with an effort to incorporate ocular TB as national TB control program. And we got criticized that ocular TB is not seen worldwide. There are only few centers in India which are seeing and reported, and it just does not happen. So came the policy document from the Government of India in 2007 about Index TB guidelines for extrapulmonary TB, and ocular TB was not a part of it, which means whatever we had been saying, our own government did not believe in that, because some people up there thought that ocular TB is not a problem. Well, what do? So that was the second stone which I took personally, and I said, okay, we will show that ocular TB is not a problem of PGI Chandigarh or Shankar Nethralaya Chennai. It's a problem of the entire world. We collected 4 people, and these are my collaborators: Carlos Bevezio from MUFI London, Rupesh from Singapore, and Kwan is from Stanford. We actually met for the first time at an airport lounge. We said we have to do a multicentric study. I was told, you cannot do multicentric trial without funding. So drop the idea and don't make a fool of yourself. Don't listen. If you're convinced with something, go ahead. We did start working on the pure goodwill gesture of our collaborators, 25 countries, 900 patients, and we just made a motto: together towards tomorrow. We had no funding, we had no financial backing. It was just a goodwill gesture of experts who did the data entry, our youngsters who worked very hard. And together we came with 27 publications on ocular TB, which was the first multicentric, or the rather only multicentric study of ocular TB. The next is, now how do we convince our ID specialists that they should give ATT to our patients? So we decided to have a consensus document, and we were privileged that by this time, ocular TB study group was joined by all major international society backing us up, which included IOIS, IUSG, and Foster. We did a very intense consensus meeting, which was held in Chandigarh, and suddenly there were a lot of people who were, joined the bandwagon, and I was no longer alone in my mission. And we came up with 2 publications in ophthalmology giving the guidelines to the internist as to how to and when to initiate anti-tuberculosis therapy. Fine. We did come up with this, and for me, this was the personal win, winning the mission when the standard treatment workflows of India and the ICMR guidelines included ocular TB as a part, recognized it as extrapulmonary TB. For me, that was kind of a very important step. So we did come up with the consensus, a multicentric consensus, but then the next stone came. Well, you have given good guidelines, but it's very difficult to remember those guidelines in day-to-day practice. So we came up with the next step, which is the calculator. Very simple. You just enter the age, name, gender, and country. It automatically shows you the endemicity, that it is from endemic country. You enter the phenotype, and we just took 3 tests: Monteus, interferon, and CHEST. And we tell the calculator, you calculate what is the risk. And it gives you as an app that there is very high probability amongst the experts to consider anti-TB drugs. It's as simple as that. Whenever in doubt, you can ask the calculator that what would the world experts do in my situation, and the calculator will give you an answer that whether they will give anti-TB treatment or not. The treatment CORDS calculator was available. Stones continued, criticism continued coming from the premier institutes saying that COTS recommends overtreatment. Not really. COTS does not recommend overtreatment. So we really validated our calculator based on the criticism, and we have 2 publications now. One is the in JAMA Ophthalmology about this COTS calculator being used all over the world, validating it. And second is by Dr. Jyotirmay Biswas about validating this calculator in the Indian population and showing that it works very well without overdiagnosing. This brings me to a kind of an end of my journey in ocular TB, which started in year 1999. Actually, in year 1995, when I read a publication that why the eyes were being enucleated from ocular TB, reaching a point where hopefully we will be able to recognize these eyes in time and not make anybody blind from something as simple as ocular TB, because this is our problem. We have to find an answer. And it was wonderful because in year 1999, which was the first meeting of Uveitis Society of India, I had received the criticism about floating this idea. And this is year 2022 when I got G. Venkataswamy oration on the same topic. So I think it's important that if you believe in something, just persist with it. Of course, the work is, these collaborations and all, they do require a lot of people who help you. And this is my favorite slide, that tree's beauty lies in its branches. That's fine. My branches are my students, but the strength is in roots. And you never forget the roots. You never forget the people who taught you. You never forget the people who were with you when you had an idea without the world experts backing you up, because those are the people who are really important. Once you have done something, everybody wants to know your story. But the people who listen to your story when you are nothing, they are the people you should always remember in your life. This is my lovely department. I'm very grateful to my teachers and my colleagues and my students. We run a beautiful MCH program only one in the country right now. And it's really nice to have these youngsters with us all the time. People who have been with us for years together, like the support. A big thanks to them, and a big thanks to my lovely family, my husband and my daughter, for this difficult journey that I took. All these people made sure that I was not alone in this journey, and they were always around me. With this, I would once again like to thank Jharkhand Ophthalmology Society for giving me this honor and opportunity to speak to all of you on a Sunday afternoon. Thank you very much.
Thank you, madam. Over to Dr. B.P. Kashyap, our past president, Jharkhand Ophthalmological Society.
Madam, thank you very much to have accepted our invitation. You are a living legend. I have been following you since more than 25 years, and I know that it was your and Professor Ahmed Gupta's effort that OCT is in India. And what to talk of OCT only, there are a lot of things which you have started. And what a wonderful team you had. Oh my God. Dr. Gupta, Dr. Ashali, and then on the other hand, Dr.
Manga Dogra.
Manga Dogra is ROP, and the person who became the Jagat Ram. Oh my God, he's such a simple person. All was so good, exemplary. Hats off to you, madam. Hats off. You are one of the strongest women of ophthalmology in India, madam. It's not two thoughts about it. And we are planning to have felicitation for you in our annual conference going to be in Ranchi. We'll be calling
13th,
madam.
14th,
Please
and
come
15th.
over.
13th, 14th, and 15th. The main conference will be on 14th, madam. And there will be an inauguration ceremony in the evening. And we will do a grand honor. So you have to come, ma'am. Please block the date.
Thank you.
14th February.
Thank you.
And I'm also given a task to announce the result of the JHOS hackathon. And all the numbers, they are very close to each other. I really understand that all the judges must have a very, very difficult time to judge who is the first and the second, and giving the marks must be very, very difficult. But out of those, the third prize goes to Dr. Arvind Krishna VP. And the second is Dr. Anil Radhakrishnan. And first go to Dr. Rashad Shroff. So to all the speakers, may I request them to be present in the annual conference of JHOS on 13th, 14th, and 15th of February. and we'll be facilitating you there at that time. Thank you so much. Now,
Thank you, madam. Thank you.
Thank you. Thank you.
Now, please proceed.
Okay, now we have to take the talk of guest faculty talk of Dr. Rajesh R. Dr. Seema has joined our secretary, ex-secretary Dr. Subrato Mitra is there. Welcome, Dr. Subrato. You have to say a few words before Dr. Malaya Verma's vote of thanks, because you are since morning, and I can see you.
I'm since.
Vibhuti Bhushan, they have to say a few words before vote of thanks. So Vibhuti is also there. Seema is there. Seema could not come because of the GTR fast. So please take up coordinators. Please take up Dr. Rajesh R. Dr. Rajesh, are you here?
Yes, ma'am. He is here. He is here.
Okay.
Dr. Rajesh, you can start your presentation.
No, have you done his introduction?
No.
Ma'am, we have already dealt. We have already introduced him, ma'am.
Okay, he's from RP Center, AIMS, New Delhi.
Yes, ma'am. Yes, ma'am.
And he has done his fellowship from
Shankara
Netral. And he's the right hand of the most senior faculty of retina.
Dr. Mahesh P. Sangam.
Dr. Mahesh P. Sanmugam.
Yes, ma'am.
Okay, shall I start sharing my slide, ma'am?
Yes, please. Yes, please.
So can you see my slides, sir?
Yes, it is visible and you're audible too.
Yeah. Thank you. Thank you, Dr. Bharti ma'am, for this opportunity. So I'll be presenting in one of the least told about problem. So we were confronted upon a few patients who had an accelerated diabetic retinopathy, and we were fumbled upon what would be the probable cause. So since we started searching for these lesions, what might be the reasons for aggravating such conditions, we had a few of our own patients. I'll just go through the history of some of them. So when I looked into how would I divide these patients, based upon certain systemic factors, which comorbidities which the patient had, or the ocular features which I had presented with, along with diabetic retinopathy, and some masquerades, which since we are an oncology center, we do get some masquerades which can manifest as diabetic retinopathy. So these are the three broad classification on which we see patients who had previously had a very subtle amount of diabetic retinopathy, and they suddenly had some increased accelerated outgrowth. So getting one by one, so let us look into the hematologic dysplasia. So I'll just start with one of my patients, 61-year-old gentleman who had presented with us with a diminution of vision in the right eye for 20 days. He was a known diabetic and hypertensive with fair metabolic control. Not to mention his vision acuity was also quite okay. The right eye had 612 N6 and the left eye has about 66 N6. He has dyslipidemia also. He had received some amount of anti-VEGF elsewhere because the right eye had center involving diabetic macular edema. So this is what he presented with. You can see the color photos and the OCT. OCT shows cystoid macular edema in both the eyes, a little bit left more than the right. So what we decided, since he had already received anti-VEGF, we thought let us give him the benefit of Osidex, since it was just introduced at that point of time. And we saw whether it might give some additional benefit as compared to anti-VEGF. This is about, we could see that about 10 to 20% of the reduction of CMT had occurred in the right eye, as well as in the left eye also. So looking at this within the matter of 2 to 3 weeks, we felt that the patient might respond better, and we continued monitoring him. But at 4th week, we did had some amount of laser and followed him up. But for our dismay, both the eyes at around 4 to 6 weeks post focal laser started developing the edema. The edema had regained, and now it was much more than what it was to present with. So, I mean, the patient was most probably frustrated because he had already seen multiple doctors and it had presented to us. So he was lost for follow-up. Maybe again, he went for some amount of second opinion, and then he came back after 10 months later. And 10 months, it was even more dismal. The vision acuity in the right eye had now deteriorated to 3/16 and 36. And he had some amount of cataract, maybe because of the Osidex, which we had given. And post that, in that 10 months, he had some other injections elsewhere. And the left eye was a bit more maintained. It had 612 with N8. So look at the amount of CMT in this patient. Right eye, it's completely ballooned up, as well as in the left eye also. And since the cataract had progressed in the right eye, that's why the vision was much worse. So we took a dive into the systemic examination. Systemic profile was very much within acceptable limits. What I mean by that, HbA1c and hypertension. But the one thing which was noticeable was his platelets. It was about 60,000. And then we diagnosed this patient as ITP with hypertension and moderate NPDR with status post multiple injection and laser. So ITP was the main cause of this recurrent edema, which was not readily getting cured or responding to the standard treatment, that is anti-VEGF and Osidex. So the patient came back after all these investigations and the physician opinion. Now the platelet was 30,000, and you can see it is even more ballooned up. So only thing that we need, what we noted was when we look back into the history and all his investigation and OCT, and we correlated his blood examination, it was seen that whenever the macular edema fluctuated according to the platelet, so the platelet was less, the macular edema was more, and the hemorrhages were more. And when the platelets were better, the hemorrhages were, and the edema was much better. So we started the patient to go on with systemic steroid. We can see how once the ITP was under control with the systemic steroids, with 1,75,000 of the platelets, the edema was getting better without any intravitreal injections or any other intervention, ophthalmic intervention. So that's the one thing. So whenever we have a patient who has blood dysplasias, not only this, even in patients we have CML. So these patients also present with these cystoid macular edemas and hemorrhages, which may not be correlating with this systemic control of sugars and hypertension. The second well-known association with diabetic retinopathy is nephropathy, because diabetes do cause chronic renal disease also. So this is one of the classic patients where patient presents to us, we have treated, it was stable, quite stable, sugars are unstable, but once the patient comes with the deteriorating renal parameters because of whatever the reason, we can see that the edema is progressing. So second of the causes in which there is an accelerated diabetic retinopathy changes despite the sugars being under control is if there's any worsening of the hypertension or nephropathy, we can definitely correlate with the worsening eye conditions also. Third is if a patient has undergone a cataract surgery, we know that if a patient has a center involving diabetic macular edema and the patient undergoes a cataract surgery, there's definitely progression of the involvement and further deterioration of the edema status post-cataract surgery. Even to that extent that patients who were well treated and were completely stable at the time of cataract surgery, 20% of these patients who had resolved diabetic macular edema post-cataract surgery can develop. But in this patient, you can see that the minimal amount of CME which was there post-cataract surgery is developed into what we call as the cystoid macular edema and some amount of NSD also. So these patients are usual form of treatment of IVTA or DEX implant can definitely resolve the macular edema and keep them stable. Patient who has hypertension do have retinal vein occlusions, either TRVOs or BRVOs, even to the extent of CRVOs also. So a patient who has diabetic retinopathy who suddenly develops increased macular edema or neurosensory detachment, we need to look closely because certain small tributary retinal vein occlusions can cause quite exacerbation of the macular edema, which may not be completely stable or mainly responding to the regular anti-VEGF that we give to these patients. Coexisting macroenzymes. So what we look at is the AV crossings where some of these patients do develop macroenzymes, and macroenzymes can bleed at all levels, whether it's epiretinal or preretinal or even to the extent subretinal or intraretinal. So any of these levels, the hemorrhage might proceed and cause concomitant macular edema. So a patient who is quite stable, what we trivially look at as mini or micro or mini aneurysms might enlarge to macroenzymes, and that can cause bleeding and development of macular edema. So we need to keep a close follow-up of these patients. If such a thing is noted, then we can laser, or most of them they self-involute, but if we laser, the edema also regresses for a period of time. So another concept which we came about a few years back is when most of these diabetic macular edema patients who have some microaneurysms are treated with anti-VEGF or DEX implant, they do respond beautifully. But what we looked at is some patients, despite the injection, you can see this is all the upper OCTs are pre-injection and the lower bottom OCTs are the post-injection various, whether it's anti-VEGF or DEX implant. You can see the response is very, very minimal, marginal, not even 10% of the initial CMT that we look at. So when we look very closely, what we could see is enlarge it. We had these aneurysms which are a little bit more than the microaneurysms which are typically noted in diabetic retinopathy. So this we termed at that point of a time as mini aneurysms. These time, I mean, over a period of time, they have been labeled by various groups in various terminologies, telcaps, or PREVAX and other things. Nomenclature has been given. So telcaps is what has been noted recently. So these, what we call a little bit more than microaneurysms, do not respond very, like any other usual mini-aneurysms or patient with diabetic retinopathy. These patients do respond beautifully to laser. So if at all we note these patients which are very clinically seen as well as in OCT can be picked up, and once we do laser, so they resolve very wonderfully. The edema goes down. Rather than only relying on anti-VEGFs or dexamethasone implants or tricot, we need to laser these patients. So focal laser is always added armamentarium, which we should never forget it. So some patients do have what we call as a premacular bursa. So the PVD is not there. There is an empty space between the posterior hyaloid and the macula. So these patients are known to not to respond to the regular treatment. That is, once we give anti-VEGF, the reason behind is these empty bursa spaces prevent or does not allow the pharmacological agent to reach the retinal surface and thereby causing the resistance of edema. So if such a thing is noted and the patient is not responding to, then definitely would suggest to pharmacological vitrolysis or like Jetria, or we can go ahead with the vitrectomy in such conditions. So that allows a single space of the vitreous cavity, and whatever pharmacological agents that we give can respond beautifully to these patients. So this is the premacular bursa which I have documented in the OCT over here. So this is anti-VEGF which was given, and this is 1 week post anti-VEGF. The response is
Excuse me, Dr. Rajesh, would you like to sum up, just wrap up?
Yes, ma'am, that's it. Just another 2 more cases. So whenever we give anti-VEGF, we think about the patient to respond beautifully, but you can see in some patients, it doesn't respond like that. It worsens. In fact, the macular ischemia increases post in these patients with central involving macular edema. The reasons unknown, but the basic reason behind is the increase in the macular ischemic nature. Diabetic papillopathy is another added features in some patients who develop papillopathy because of hypertensive NAI1 and other conditions might lead on to a sudden progression of the retinopathy and loss of vision, which doesn't correlate very well to the systemic control. So this is one of such conditions. Any of the radiation retinopathy. So a patient who has diabetic retinopathy, who has melanoma or anything, this is a patient who had been melanoma, who had been treated with brachytherapy, and that causes an additional radiation retinopathy, which might mimic like diabetic retinopathy and causes visual loss. So it may not be related to the systemic nature. So CML, that's what I was talking to you about. Collagenal vascular disease is another cause. You can see the amount of progression the patient had presentation, and this is a month later, he had developed a complete detachment. So this is immediately post-operative when the patient settled with under oil and the vision was retained. So in summary, background clinical information is very important, not just the status of HbA1c and hypertension. We need to access all his investigation, fundus images, FFA, whatever that is available with us. We should not miss anything. Even if we don't know anything, we need to keep it in, and check and keep looking back. What was the reason? And we may end up identifying a new finding with these pictures maybe later, but that might be enhancing knowledge for the future generation. Thank you.
Thank you, Dr. Rajesh. So because we are going too late, we'll be proceeding for the next session. It is on case presentation. It's for PG students. I'd like to just re-announce once again, it's a 6 minutes. Please stick to 6 minutes. It's a hard stop. And only one question. I will request all the judges to just ask one question to every candidate. So now the session coordinator.
No. Just one question. Aise rakho. Just one question.
Okay, ma'am. So the session coordinators are Dr. Sophia Ahmad, Dr. Reena Singh, Dr. Seema Kumari, Dr. Ashima Tigga, Dr. Pritish Pranoy. The esteemed judges with us, Dr. Sweta Walia, Dr. Firuz PN, Dr. Deves Kumawat, Dr. Piyush Bansal, The chairpersons with us, Dr. Sunil Kumar, Dr. Rahul Prasad, Dr. Abhishek Onkar, Dr. Poonam Singh, Dr. Bibhuti Kashyap, Dr. Tanisha Oza, Dr. Nidhi Gadkari Kashyap, and myself. So we are going ahead without any delay to our next PG students. Dr. Mayank Saran, are you available?
Yes, ma'am.
Sure, perfect. So, Dr. Mayank Saran, it's your time. Please start your screen share and please go ahead. Yeah, your time starts now.
Please start your slide, Mayank, Dr. Mayank.
I request everyone, please. Yeah, the next presentation. Next presentation is from Dr. Anvita Sweta Kachap. Please get ready. So, Dr. Mayank, your time starts now.
So the slide is visible to everyone.
Yeah, it is visible. You proceed ahead.
Good morning, sir, ma'am. The topic for my presentation is surgically induced endothelial cell dysfunction and corneal decompensation. So basically in this condition, there is endothelial cell loss, which might be due to pre-existing any corneal disease like dystrophy, or it can also be surgically induced, which leads to further stromal edema or epithelial edema. So normal anatomically, the corneal endothelium is a single layer of non-regenerative polygonal cells, and most of them are hexagonal in shape. But the main point is that the influx of fluid into the stromal layer is being prevented by some like barrier, which have like barrier function of endothelium, or there are some active pump mechanism like sodium, potassium, ATPase pump, bicarbonate, and chloride transporters, and some like carbonic anhydrase enzyme, which act as a pump out mechanism, which pumps the excess fluid which is present in the stromal layer back into the aqueous humor. So the pathophysiology for this condition is that whether the patient is having any corneal dystrophy or not, but during the surgery, whenever there is an endothelial injury, it leads to the break in the that endothelial barrier, as well as there is inefficient endothelial pump, due to which the aqueous humor or the fluid it moves into the corneal layers, leading to stromal edema, and later on, if it progresses further, leads to epithelial edema. And that chronic persistent cases of those epithelial edema leads to bulla formation, which is referred as bullous keratopathy. So for the risk factors, if we are like appointing any patient for cataract surgery, we need to rule out any endothelial dystrophy, mainly Fuchs endothelial dystrophy, because there is already deficient endothelial cells, or the patient is diabetic or having raised IOP. During surgery, we need to focus on if there is we are using like high mechanical energy in phacoemulsification, or there is surgical trauma by seeing some instruments, or while placing the IOL, one of the haptics might erode or damage the endothelial layer, or the direction of the irrigating solution towards the endothelial layer, or there is some detained lens fragments in the AC. Whereas in the post-op, if there is flat AC, so it leads to the contact between the iris and the endothelial layer, or there is vitreous in the AC, raised post-op IOP, or surgeon has put an ACR, again where haptic will erode the endothelial layer, or the patient has undergone into toxic anterior segment syndrome, where due to unsterilized instruments or there's preservative-based medicine or solution are being used. So clinically, patient will come with blurring of vision or glare, which is worsened at the morning because of that non-evaporative effect during the nighttime, or the patient may complain of pain, which will be due to the ruptured bulla, in which there is exposure of the nerve fibers. Whereas in sign, we'll see corneal haze due to that corneal edema. In severe cases, there will be epithelial edema leading to bullous keratopathy. And if there is improper healing of that endothelial layer, it leads to permanent decompensation. Then that patient is need to go for keratoplasty. So for the treatment part, if there is mild or moderate stromal edema is present, so we can give or advise topical hypertonic drops during the daytime and ointment At the bedtime, topical corticosteroids can be given to control the inflammation, and if there is raised post of IOP, so we need to control that also. The patient has come with ruptured bullous, so we need to like apply bandage contact lens to elevate the pain, or like we have done like anterior stromal puncture of that unruptured bullous. So again, we need to apply like simultaneous BCL application should be done. Whereas for the surgical part, if during the operation we have seen that there is descemet membrane detachment, so in that case we need to go for desmetopexy, where we just influx or we'll put air bubble or some other gases can be put, so that it creates a tamponade effect in the AC, and it puts the descemet membrane back in contact or in proper position with the posterior surface of the cornea. If like we have doing OT of a patient who has also Fuchs endothelial dystrophy, so in those cases we also need to do like endothelial keratoplasty. Along with that, there is like cataract removal and IOL is being implanted. So that's a triple procedure surgery. In endothelial
1 minute
keratoplasty,
more.
in
1 minute
endothelial
more.
yes, ma'am. In endothelial keratoplasty, we have two techniques, either DSEC or DMAC, in which DMAC has better visual outcomes due to because we are only transplanting we are only transplanting the endothelial layer as well as the descemet layer. And if there is a severe condition of the patient and there is like marked scarring or vascularization is present, then we need to go for penetrating keratoplasty. For preventive measures, it should be done like during surgery. Careful handling of the instrument should be done. Use of viscoelastic material should be done. And if the patient is having pre-existing corneal disease, so we need to manage that patient accordingly. Thank you.
Thank you, Mayank. You are on time. So, judges, would you like to ask any questions to Mayank?
Hello, Dr. Mayank.
Yes, good morning.
Good morning.
Good
So, what type of keratoplasty has the maximum rate of rejection? The penetrating one or the lamellar keratoplasty?
The penetrating one.
Why?
Because mostly, ma'am, the rejection usually starts due to that if there is endothelial rejection is most commonly is you are responsible for that penetrating rejection.
Okay. Thank you.
Any other question from judges? Okay, we will be moving to the next candidate. Dr. Anvita Sweta, are you ready? The next one, please get ready, Dr. Pragyan Chauhan. Dr. Anvita, are you ready?
Yes, ma'am, I'm ready. Am I
Your
audible?
screen. Please share your
Hello?
screen.
Yes, ma'am.
Yeah, go on.
You are audible. Please share. Your time starts now.
Dr. Anvita, please
Dr.
start.
Anvita, please start. At 5 minutes, you will get a short bell, and at 6 minutes, it will be long.
Yes, ma'am.
Your time starts now.
Start.
Good morning, everyone. I'm going to present a case. A 9-year-old boy from Garhwa, Jharkhand presented to the IOPD with chief complaints of diminution of vision in left eye since 3 weeks, whitish opacity in left eye since 2 weeks. History of presenting illness. My patient presented with diminution of vision in left eye since 3 weeks, which was gradual in onset, painless, and progressive in nature. My patient had history of blunt trauma to left eye by stone while playing with his brother 1 month back, after which his parents noticed redness in his left eye, for which they did not seek any medical attention. 2 weeks later, they noticed whitish opacity in the left eye, for which they visited RIMS OPD. Past ocular history, there was no history of any infection or ocular surgery. Past medical history, there was no history of systemic illness. Family history is not relevant, and my patient belonged to a lower socioeconomic background. General examination. My patient was alert, conscious, and well oriented to time, place, and person. He is of average build. Pallors, icterus, cyanosis, clubbing, lymphadenopathy, and edema were absent. His systemic examination was within normal limit. Ocular examination, lid and adnexa globe position and size, both eye within normal limit. Lid and adnexa, both eye within normal limit. Both the eyes were centrally fixating. Extraocular muscles movement was free and full in all case. Right eye, the uncorrected visual acuity using Snellen's chart was 6.6, whereas in the left eye, the uncorrected and best corrected visual acuity was finger counting close to face. IOP was normal for both the eyes. Conjunctiva was normal for both the eyes. Cornea was clear for both the eyes. In right eye, the anterior chamber had normal depth and was quiet, whereas in the left eye, it was shallow. The pupil in right eye was 3 mm in size, round and reactive to light, whereas in the reactive to light, traumatic mydriasis. In right eye, the iris was within normal limit. The right eye lens was within normal limit, whereas the left eye had intermittent cataract. The fundus of the right eye was within normal limit, whereas in the left eye it could not be assessed due to hazy media. So my differential diagnosis are traumatic cataract, developmental cataract, and uveitic cataract. My provisional diagnosis is left eye traumatic cataract with traumatic mydriasis. So investigations that was given were B scan. Vitreous cavity was anechoic and retina was on. RBS was 105 mg per dl. Serology was non-reactive. Serum electrolyte, CBC, LFT, RFT, PT, INR, chest X-ray, and ECG were within normal limits. Biometry was done using A scan. Management. My patient was admitted in eye ward for left eye phaco aspiration and PCIOL implantation. The pre-op advice was BP and consent were taken. Eye drop fluorbiprofen 0.03%, 1 drop 3 times was given. Eye drop tropicamide 0.8% plus phenylephrine 5%. 1 drop 3 times was given. A patient was kept NPO, 6 hours for liquid and 12 hours for solid, and IV fluid RL 1 unit was advised. Under general anesthesia, left eye phaco aspiration and PCIOL implantation was done. PNP was done after installation of antibiotic and steroid eye drops. Post-op advice, patient was kept NPO for 6 hours. IV fluid RL was advised. Injection ceftriaxone 1 gram IV, half ampule BD was given. Injection pantoprazole IV, half ampule OD was given. Injection diclofenac IM, half ampule SOS was given. Tablet prednisolone 20 mg once day was advised.
Dr. Advita, we have lost you. Are you there? Dr. Advita? Okay, so because we have lost Dr. Advita, we can go to the next presentation. Dr. Pragya Chauhan.
Dr. Pragya, are you there? You're ready with your
Yes, sir.
presentation? Please start.
Please share your screen. So at 5 minutes, we'll give a short bell.
Your time starts now.
Good afternoon, everyone. This is Dr. Pragya Chauhan, first-year resident, is going to present a case of a 22-year-old unmarried male who presented to our OPD with diminution of vision, right eye more than left eye. The DOV was gradual, painless, and progressive in nature, associated with nyctalopia. There was no history of pain, redness, photophobia, floaters, and flashes of light. There was no history of any other ocular trauma, or also there is no history of any jaundice. Past history and family history was not significant. On general examination, patient was alert, conscious, and cooperative, and rest of the findings was within normal limit. On slit lamp examination, the pupil was 3 mm in size, reacting to light, but RAPT was absent in left eye. Visual acuity of the right eye was hand movement close to face, and it was 6/36 in left eye. BCVA was not improving in right eye, but it was 6/18 in left eye. Near vision was less than n/36 in right eye and n/10 in left eye. Color vision could not be assessed in the right eye, but it was affected in left eye. Ocular movements were full, free, painless in all directions of the gaze. Position and size of the eyeball were within the normal limits. On slit lamp examination, anterior chamber, globe, and adnexa were within normal limits. On posterior segment evaluation, media was clear, size and shape of the disc was normal, but a slight temporal pallor was noted. Margins of the disc were well lineated, but bony spicules presented at macula, macula and juxtapapillary area was noted. Mild arteriolar attenuation of the arteries was also noted. Investigations we did in the patients were ultra-wide field fundus photo, OCT macula, and multifocal ERG. As we can see on this ultra-wide field fundus photo, the
Pragya, please go to screen share.
Sure, Ravana. Yeah, नीचे में एक आइकॉन है, this icon, और ऊपर में एक आइकॉन होगा slide show. On the top of your screen there's a slide show. Press that.
नीचे में आइकॉन है.
नीचे में भी है, ऊपर में लिखा हुआ.
Yeah, sure. Yes, that place.
Now, as we can see on this Optus photograph, the more of the center and juxtamacula and juxtapapillary area was involved instead of the peripheral retina, which is more commonly involved in retinitis pigmentosa. This was the fundus photograph we did in the patient. In the same also, we can see that the bony spicules were more over in the center as compared to in the periphery, because RP mainly involves the periphery first and then it comes to the center. OCT was done to check for any edema, for any central macular edema, for which vision loss could also be there. At last, we did multifocal ERG, in which we can see that in both left and right eye, the amplitude of the P wave was decreased, but more amplitude was decreased in the right eye. Also, there was blunting of the central vision. Cones, this means that mainly the rods and cones of the central area were more affected. This is the multifocal ERG of the left eye. In there also there is blunting of the hill of vision, but it is less as compared to the right eye. So my provisional diagnosis for this case would be asymmetrical inverse retinitis pigmentosa. The differential diagnosis could be vitamin A deficiency, congenital stationary night blindness, retinitis punctata albicans, and self-settled retinal detachment. This is a case of a 22 years old male presented with diminution of vision in right eye more than left eye since childhood, with illness and no similar complaints in the family. On examination, BCVA was hand movement in right eye and 6/18 in left eye. Anterior segment was within normal limit. On fundoscopy, both eyes show bony spicules involving macula, juxtamacula, and juxtapapillary area with slight temporal pallor and mild attenuation of the arteries. Treatment plan, currently there are no specific treatment modalities for this case. Only visual rehab can be given, refractive error correction can be given, and trial of low vision aids can be given. Prescription of glasses was given to our patient. Take-home messages: retinitis pigmentosa typically presents with night blindness and peripheral vision loss, but this is a case of inverse RP, which can affect central vision at a very early stage. As of now, there are no definitive treatment and only vision rehab is the key. Multiple research and advancement are underway for the treatment of the diseases. One of this is Luxturna, which is approved for RPE65 mutation, which is in trial for retinitis pigmentosa. Thank you.
Thank you, Pragya. You are on time. So, judges, please questions to Pragya.
So, Dr. Pragya, that was a very nice presentation. And I would like to ask you that did you get genetic consultation or genetic evaluation for the patient? And what
Sir,
about
we
the
asked the
family?
patient, he said that there is no other family member affected with the similar complaints in the family. He was the first one who presented with like this kind of presentation.
So it could be a sporadic presentation of
Yes,
this
it
type,
could,
or it could still be genetic, but he would have acquired the mutation in vivo maybe after the embryo would have started developing.
Yes,
So
sir.
in any case, if possible, get a genetic consultation done, because then it will have consequences, because you need to counsel the patient for because he's a middle-aged male. So
Yes, sir.
regarding the family also, you have to counsel the patient accordingly.
Yes, sir.
Thank you, Dr. Zahid. You are the next candidate. Will you please get ready? In the meantime, Dr. Anvita, are you here so that you can take up the questions? We have not asked you any questions. Dr. Anvita?
Yes, ma'am.
Yeah. So we have lost you in between. Your case was traumatic cataract. I'll request
Yes,
judges
ma'am.
to ask questions to Dr.
Ma'am,
Anvita.
should I present it again? Because
No.
I guess in mid.
No,
Yes,
that's fine. That's fine. Judges
Okay,
can
ma'am.
take up the questions.
Okay.
So, Dr. Anvita, I would like to ask, what was the cause of traumatic mydriasis in your patient?
Ma'am, there was traumatic mydriasis, ma'am, because the iris was also injured. There was posterior synecdoche from 1 o'clock to 2 o'clock position.
Could you see any sphincter tears?
Yes, ma'am, sphincter tear was present.
Yes, that was the cause for a pupillary dilatation in your patient. And my another question
Yes, ma'am.
is, how can you assess the posterior capsule preoperatively in such patients of intumescent cataract?
Ma'am, posterior capsule, ma'am, we should go for OCT changes, OCT, and through OCT maybe we can.
Yes, you
see
can
the.
go for NTA segment OCT to see
Yes, ma'am.
the status of posterior capsule, so that you can decide whether you will need to go for a PCIOL or you will have to go for an scleral fixated or an IOL, scleral fixated IOL. Okay, thank
Yes,
you.
ma'am. Thank you, ma'am.
Thank you. So, Dr. Zahid, are you ready? Dr. Zahid, are you there? Next candidate is Dr. Kunal Kumar. Please get ready. Dr. Zahid, are you here?
Dr. Zayed, are you there?
Oh, sure, Dr. Zaid. Zaid, sorry. It's Zaid. Zaid Ashraf.
He's not there.
Okay, maybe he is absent. So, Dr. Kunal Kumar.
Dr. Kunal, are you there?
Yes, ma'am. Yes, sir.
Please start your slide.
Share your screen.
Yes, ma'am.
So, who is presenting now? Zaid Ashraf?
No, ma'am,
Oh,
Dr. Kunal.
Please, Kunal. Dr. Kunal will be presenting.
Sure. Dr. Kunal will be giving a short bell after 5 minutes.
What happened, Kunal?
Yes, good afternoon.
Share your screen. Okay. Slideshow. Put it in slideshow mode. Yeah, downstairs. Yes. Okay. Start.
Good
Your
afternoon,
time
everyone.
starts.
Good afternoon, everyone. My case is a 48 years old male from Jamshedpur, Jharkhand, presented in MGMMCH IOPD on 8/9/2025 with chief complaint of redness left eye for 2 days, watering left eye for 2 days, irritation in left eye for 2 days, blurred vision for 2 days. History of presenting illness. Patient was apparently asymptomatic 2 days back. Then he developed redness in left eye in morning, which was sudden onset, not associated with pain. Then Patient self-medicated with antibiotics containing preservatives. After 2 days, symptom worsened, causing blurring of vision and ocular irritation, for which he presented in OPD, and no such complaint in other eye. Past history. Past ophthalmic history. No history of ocular trauma, glaucoma, chemical injury, or any ocular surgeries. Past systemic history. No history of hypertension, diabetes, TB, cardiac disease, and GI disorders. Family history not relevant. Personal history. Mixed diet, normal appetite. Patient does no smoking, alcohol intake, or drug abuse history, and also no non-drug allergies. General examination. My patient was conscious and all oriented to time, place, and person. He was well built and nourished, of febrile. Vitals are stable and no pallor, ictus, cyanosis, and lymphedema present. Ocular examination. Head posture normal, facial symmetry maintained. External examination. Visual acuity of right eye is 6/6 and left eye uncorrected vision 6/18 and base corrected vision is also 6/18. Extraocular movement of both eye normal in all gaze. Selmer test done. Right eye 18 mm and left eye 22 mm. IOP right eye 14 mm SG and left eye 12 mm SG. Conjunctiva of right eye are within normal limit. Left eye have diffuse congestion. Cornea right eye clear, and in left eye there is corneal sensation normal, diffuse epithelial irregularities, a striae and DM, that is decimal membrane fold, and fluorescence stain positive. AC, pupil, and lens of both eye are within normal limit. This is the image showing a decimal membrane fold and diffuse corneal staining. On fundoscopy, media of right eye is clear and left eye hazy. Optic disc of both eye are round in shape, normal in size, pink in color, healthy NRR, clear margin, CD ratio 0.3. Macula, both eye FR present. Blood vessels, both eye vessels arise from center of the optic disc, branching dichotomously into superior and inferior arcade with AV ratio of approx 2:3. Periphery within normal limit. Differential diagnosis. Toxic keratoconjunctivitis, infective keratitis, hemorrhagic conjunctivitis, neuropathic keratitis, and dry eye exudation. Case summary. A 48-year-old male presenting with complaint of redness, watering, irritation in left eye after topical use of antibiotic containing preservative for 2 days. On slit-term examination, diffuse corneal epithelial irregularities and DM fold seen. Provisional diagnosis. Left eye toxic keratoconjunctivitis due to topical drug abuse. Treatment given. First of all, discontinue preservative containing eye drop, then light patching for left eye for 24 hours. Eye drop moxifloxacin, which is preservative free, 1 drop 4 times in left eye for 5 days. Ointment azithromycin, apply locally at bedtime in left eye for 5 days. Eye drop CMC, 1 drop 4 times in left eye, which is also preservative free. Eye ointment, panthenol, twice daily in left eye for 7 days, tablet vitamin C for 15 days. And also patient educated about risk of self-medication, which is very much. And my follow-up after 3 days. Then visual acuity of left eye 6/12, IOP left eye 14 mm SG, conjunctiva, congestion significantly reduced, cornea, epithelial irregularities markedly reduced, fluorescent stain positive at center of cornea. Same treatment continued and patient was asked for follow-up after 3 days. Thank you.
Thank you for being on time. So requesting judges, please ask question.
So, did you check for the corneal sensation in this patient?
Yes, ma'am. Corneal sensation is normal, was normal.
Okay.
Dr. Kunal,
Any other question? Yeah.
Yes, sir.
I have one question for you.
Yes,
So,
sir.
what about the anterior chamber of this eye? Were there keratic precipitates or anterior chamber reaction was present?
No, sir. Enchanted chamber was quite, sir, nothing significant seen.
Okay. And secondly, why didn't you give hometropine or any cycloplegic to the patient if there is keratitis or there is epithelial irregularity of the extent to which you have shown in the fluorescein staining? So it's always a better idea that you give cycloplegic also to the patient. Okay. Thank you.
Thank you. Dr. Issad, are you there? You are the next candidate.
Yes.
After Dr. Issad, Dr. Anamika Chaudhary, please get ready.
Dr. Ishad, are you there? Dr. Ishad? You can move on to Dr. Anamika. Anamika, are you
Yes,
there?
I'm there. Yeah, Dr.
Dr.
Ishad.
Ishad is here. Dr. Ishad.
Okay, continue, Dr. Ishad.
Good afternoon, everyone. So my topic of the presentation is ocular chemical injury. Myself, Dr. Irshad Khan. I am from Kashyap Memorial Eye Hospital. So coming on to the case, my case detail is we have a 24-year-old male present with sudden diminution of vision in right eye. He has an acute history of fall of battery acid water in right eye. Diminution of vision was sudden and DOB was associated with pain, redness, and watering and burning sensation. No other part of the body was involved due to this chemical injury. Past history is not significant, no systemic illness, and family history was not significant. On general examination, patient was conscious, oriented, and cooperative, and his BP and pulse was within normal limit, and other findings were normal. On examination, his visual acuity was 6/60 in right eye, and unaffected eye, that is left eye, is normal. On examination, his pupil size, shape, and position was normal. RAPD was absent, and intraocular pressure was slightly raised, that is 23. On the ocular movement was full free. Position of the eyeball and size of the eyeball was normal. On slit arm examination, we can see the conjunctival chemosis and congestion. There was a large epidefect, that is 6 mm epidefect with limbal ischemia and loss of palisades of Voges that represent the limbal cell deficiency. Immediate treatment given was irrigation with normal saline for around 20 to 30 minutes. Now the question is when to stop the irrigation. We can measure the pH of the conjunctiva till the pH reaches 7. We have to continue our irrigation. After irrigation, we will apply the bandage contact lens, that is BCL. Second examination will be done later after the symptoms subsides. Now my provisional diagnosis, acute ocular chemical injury, grade 3. This grading is as per Roper Hall classification, which Roper Hall classification contains corneal involvement and limbus involvement. We also have a different classification, DOAS classification, that is more precise, and it contains 2-3 parameters like cornea, limbus, and conjunctiva. Initial management was done with topical steroids, antibiotic, lubricants, cycloplegics, anti-glaucoma, analgesic tablets, and vitamin C Raminant tablet. Now patient comes after 1 week for follow-up. His vision is 6/60 and epidemic was slightly reduced. This is the clinical photo of first week follow-up. Then post-segment evaluation was done and it was within normal limit. After that, patient comes after 3 weeks and his vision improved to 6/24, and now epidemic has reduced and he has mild stromal haze. And we ask the patient to continue the same medication. After this is the follow-up for third follow-up. Here we can see the haze is reduced. Now after the patient lost to follow-up and he came back after 6 months. He came back after 6 months with vision of finger count at half meter. We can see the 360-degree vascularization, deep and superficial vascularization with conjunctivation of the cornea and 360 pannus formation. His vision was finger count at half meter. And we asked the patient to start the topical steroids, antibiotic, lubricant. Now our diagnosis is chronic chemical injury, stage 2B as per Holland-Nice classification. Now our treatment plan is pannus removal with amniotic membrane grafting with simple limbus stem cell transplantation. This is a small video we have of intra-op. Here we can see the pannus is separate from the first we will do the conjunctival peritomy. Then pannus will be separate from the conjunctiva and the cornea using the forceps and Vanna scissor. Here you can see the pannus is getting separated from the cornea. Then we will see the clear cornea beneath the pannus. Then next step will be we will take amniotic membrane graft and we will place it over the cornea. This is the amniotic membrane graft. It is placed over the cornea and it is sealed with the glue. Then after that, we will take the cadaveric tissue and we will take small biopsy from the limbal stem cells, and we will cut into small pieces and will be placed on the cornea on the limbal area. And this is the intro photo of after the penis removal. Here we can see the clear cornea and glow. Then this is the photo after amniotic membrane grafting, and this is another photo of after the limbal stem cell transplantation is done. So after the post-op, a patient comes after 2 weeks, his vision significantly improved from finger count at half meter to 636. And now on finding, this is the B cell is institute limbal stem cell. This is the post-op photo. Limbal stem cell particles are visible and corneal haze is reduced. Now patient comes after 4 weeks. His visual acuity is now 618 parts. From finger count, it significantly improved till 618 parts. So chemical injuries of up two types, acid and alkali. Alkali is more dangerous than acidic. And SLED is a technique involving the transplantation of small limbal biopsy from the healthy eye or cadaveric eye, and that allows the regeneration of the corneal epithelium. And in this case, the combination of penis removal and SLED led to the reepithelialization and visual improvement. So this case highlight the AMG that the AMG provides immediate healing support, and simple limbal stem cell transplantation help in definitive visual outcomes. So early recognition and timely surgical intervention helps in crucial, and that is crucial for the optimal outcome. Thank you.
Thank you, Dr. Irshad. You are on time. Please judge this question.
So wonderful case, Dr. Irshad. Just one
Yes, ma'am.
question. How much
Yes, ma'am.
clock hours of limbal stem cell injury was there?
Ma'am, more than 3 clock hours.
More than 3 clock hours. So that's why
Yes,
you classify that as what grade of Roper Hall?
Ma'am, grade 3, Roperol grade 3. Like in Roperol, we consider like more than one third to half of the limbus was involved. And if more than half of limbus is involved, then it is grade 4.
Okay.
Very well presented case, Dr. Irshad. One question to you, that
Yes.
something could something else would have been done in the immediate presentation so that the chronic phase would have been avoided? Anything else other than the topical medication that you had used?
Yes, sir. We could have placed the amniotic membrane graft for proper healing.
Okay, so amniotic membrane as well as even your autologous serum can also help in such.
Yes, sir. Yes, sir.
Thank you, Dr. Irshad. We will be going to Dr. Anamika. Anamika, are you ready?
Yes, ma'am, I'm ready.
Sure, perfect. Next is Dr. Amar. Please get ready. So Anamika will be giving a short bell at 5 minutes. Then 6 minutes is the full bell.
Yes. Good afternoon, one and all present here. I'm Dr. Anamika Chaudhary, and I am here to present a case. A 19-year-old female from Hazaribagh presented to our OPD with the chief complaints of blurring of vision in both her eyes since the last 3 months. My patient was apparently asymptomatic 3 months back. Then she noticed gradual, progressive blurring of vision which worsened with time. There was no history of pain, redness, or photophobia, no history of recurrent attacks. She is immunocompromised due to HIV and is on ART for the last 6 years. There's no history of diabetes, TB, sarcoidosis, or rheumatological diseases. No history of trauma. Both her parents are HIV positive, and she belongs to lower socioeconomic group. General examination and systemic examination was within normal limit. Coming to ocular examination, in right eye, the uncorrected visual acuity and the best corrected visual acuity was finger counting at half meters, and in left eye it was 636. IOP by NCT was 15 millimeter of mercury and 12 millimeter of mercury respectively. Conjunctiva normal. In cornea, in both the eyes, we can see medium-sized, multiple, stellate-shaped, diffuse keratic precipitates present all over the corneal endothelium. But the corneal sensation was normal. Anterior chamber was of normal depth, but cells 1 plus and flare 1 plus was present in both the eyes. In both the eyes, there was diffuse iris atrophy with loss of iris crepes, and nodules were also seen, but there was no posterior synechia. The pupil was round, regular, and reactive to light. In right eye, mature cataract, and in the left eye, posterior subcapsular cataract. This is the corneal diagram of my patient. These are the anterior segment photos which we have taken with the help of a slit lamp and mobile phone camera. We can see the diffuse keratic precipitate distributed all over the corneal endothelium. These are the stellate KPs, as we can see from the diagram. There was diffuse iris atrophy in both the eyes, and iris nodules were also present. Right eye, mature cataract, and left eye, posterior subcapsular cataract was present. So fundoscopy was done. Right eye, there was no view due to mature cataract, and in left eye, vitreous membrane was present. Gonioscopy was done. It was open angle grade 3 in both the eyes with no hyperpigmentation, no posterior synechia, but Amsler's sign was elicited during paracentesis. Here is the Amsler's sign. On application of pressure with the 2-mirror gonial lens, we can see that the iris vessels, they started bleeding, as evident from the picture. So my differential diagnosis are Fuchs heterochromic iridocyclitis, Poschner-Schwarzman syndrome, herpetic uveitis, and chronic anterior uveitis. But my provisional diagnosis is bilateral Fuchs heterochromic iridocyclitis with right eye mature cataract and left eye posterior subcapsular cataract. So we planned for right eye phacoemulsification PCIOL followed by left eye surgery after 15 days. The investigations were done. Keratometry was done and IOL power was calculated using A-scan. So under PA, right eye phacoemulsification plus PCIOL was done with a single piece acrylic IOL. Post-operatively, she was started on eye drop moxifloxacin 0.5% plus prednisolone acetate 1%, starting from 6 times daily and tapered accordingly. Eye drop nepafenac, eye drop carboxymethylcellulose, ART was to be continued, and tablet dicyclophenac SOS. Follow-up post-op day 1, her uncorrected visual acuity was 6.9 and the IOP by NCT was 13 millimeter of mercury. Conjunctiva normal, cornea, stellate KP is present, cells 2 plus, flare 1 plus, and the IOL was well in place. Post-op day 14, her best corrected visual acuity was 6.6 with an addition of minus 0.25 diopter cylinder at 180 degrees, and for near, she was given plus 2.5 diopter sphere. IOP was normal and the IOL was in place. For left eye, this is the video which we have shown that we have done phacoaspiration plus PCIOL. And at the end of the surgery, we can see that after AC paracentesis, there's collection of blood, which is the Amsler sign, very much suggestive of Fuchs. Post-operatively, she was started on the same medications. Follow-up post-op day 1, left eye, her uncorrected visual acuity was 6.6 partial, IOP by NCT was 12 millimeter of mercury, anterior chamber cells 2 plus, flare 1 plus, air bubble was present, and IOL was well in place. Day 14, she was plano 6.6, but for near, we have added plus 2.5 diopter sphere. IOP was normal, and the IOL was in place. This is the final visual outcome of my patient. Everything was within normal limit, and the IOP was also well controlled. So she was a happy patient as her vision got restored. So as we all know that Fuchs heterochromic iridocyclitis, also known as Fuchs uveitic syndrome, is a rare and a chronic form of uveitis that primarily affects one eye. But there have been cases which have shown bilateral occurrence of this disease as well, but that is very rare. To the best of our knowledge, this is one of the first cases of bilateral Fuchs uveitis reported in an HIV positive patient. Because it is easily misdiagnosed due to non-specific signs and symptoms, it can be vision threatening, especially if effective treatment is not provided at an early stage. Thank you.
Thank you, Anamika. You are on time. So,
Thank you,
judges,
ma'am.
please ask your question.
So wonderful, Dr. Anamika. It
Thank
was
you.
good to see handmade diagrams,
Thank you, ma'am. Thank you
and
so
I
much.
really emphasize that instead of putting photographs, residents should draw hand diagrams as
Yes, ma'am.
they have to do it in their exams also.
Yes, ma'am. Yes.
So great. And Dr. Anamika, I have just one question, though
Yes,
it's
ma'am.
not pertinent to your case, but in uveitic cataract, what is the classical appearance of complicated cataract?
Ma'am, generally in complicated cataract, one see which we see is that there's a posterior synechia present, and the cataract it is generally of mature category grade only. And it starts. There can be also absorbed cataracts if uveitis has occurred because of trauma, or generally it is a secondary cataract which has occurred. And in cases of Fuchs uveitis, we mostly see it starts with posterior subcapsular cataract, and it progresses in May and can be mature forms, and total white cataract have also been seen in such patients.
So any specific finding in posterior subcapsular cataract secondary due to uveitis? Any
Ma'am, it is
specific
generally
appearance or
grade
something you can
4,
see?
grade 4, PSC grade 4 according to the locks grade 3. Locks classification, it is usually PSC grade 4 which we see. And
So we usually see a breadcrumb appearance
yes,
or a
ma'am, breadcrumb
polychromatic
appearance.
luster.
Yes, ma'am. Yes,
Yes,
ma'am.
correct. Okay.
Thank you.
I have one question to Dr. Anamika.
Yes, sir.
What was the CD count of this patient?
Yes, ma'am. So she was already on ART for the last 6 years. So her CD count was 800. It was above 500 because the titers were also well maintained as she was taking her ART dosage accordingly and following the rule.
So this association of HIV and Fuchs is a mere coincidence, I would say. And
Yes.
do you know any other causes or infective causes
Yes,
of uveitis in HIV patients?
yes. So she was also rubella. IgG was positive in her, and as we all see, the torch profile generally rubella, cytomegalovirus, or herpes simplex virus have been seen to be associated with Fuchs uveitis. Though it is not a confirmatory, but there have been incidences in most of the cases, especially in the eastern zone. It is due to rubella, and Western countries it is due to CMV virus.
Thank you.
Thank you, sir.
Thank you. Dr. Amar, are you there? Next is Dr. Gangadip. Please get ready. Gagandip.
Morning, everyone.
On slideshow. Yeah.
Dr. Amar, please start.
Good morning, everyone. Myself, Dr. Abar Kumar, PG first year from MGM College and Hospital. My patient, 44-year-old male from Mango, Jamshedpur, came to OPD with complaint of sudden painless vision loss and blurring or distortion of right eye. My patient was apparently symptomatic since 1 week. Then he developed sudden painless diminution of vision in the right eye. No history of similar episode in the past. No history of floaters. In past medical history, known case of hypertension since 1 year and currently on medication, and known case of chronic kidney disease since 1 year and patient on hemodialysis since 1 year, and no history of diabetes and cardiovascular disease. In past ocular history, there is no history of trauma or ocular surgery, and there is no family history. In personal history, appetite was normal, bowel bladder was regular, and in social history, middle class socioeconomic group. In general examination, my patient was alert, conscious, and well oriented to time, place, and person. And obese, and patient was obese, pallor icteria cyanosis was absent, and on blood pressure was on higher side, 160 upon 90. And on systemic examination, there is all are within normal limit: cardiovascular, respi, central nervous system, and GI system. And in ocular examination, visual acuity, uncorrected visual acuity in the right eye was 618, and best corrected visual acuity is there is no improvement, and near vision plus 1.5 diopter cylindrical, and vision is innate. And in ocular movement, globe position, size, lid adnexia, conjunctiva, cornea are all within normal limit, and cornea was clear. In anterior chamber, normal depth was seen, iris normal, and pupil normal, lens clear, and IOP 14. And on gonioscopy, there is no neovascularization of iris, and iridocorneal angles were open. And in left eye, there is all are within normal limit. This is my fundus picture in which media was clear and oval in shape. My disc was oval in shape and normal in color, and CD ratio 0.4. Neuroretinal rim was healthy, and margin was blurred at the superior pole. And macula apha dull, and macular edema appear as fluid pocket, and flame-shaped hemorrhages seen in superior-temporal quadrant. In blood vessels, dilated tortuous veins are proximal to the AV crossing and narrowing of the AV ratio. In periphery, there is a wedge-shaped distribution of intraretinal hemorrhages, superficial frame-shaped and deep blot hemorrhages in superior temporal quadrant. And in left eye, there is all are within normal limit. And these are the investigations which are done, and all are within normal except BP was on higher side on when patient come 11/9/2025, 160 upon 90. And in RFT, patient was dearranged. Serum urea and creatinine are on higher side, 150, and serum creatinine 6 mg per dl. My differential diagnosis was branch retinal vein occlusion, hypertensive retinopathy, and central retinal vein occlusion and macular telangiectasia. And this is my OCT findings. Vitreous and vitreoretinal interface appears to be normal, and altered foveal contour, and increased central corneal central thickness, central macular thickness, increased central macular thickness suggestive of macular edema, and hyporeflective spaces are seen. Outer retina was in normal limit, and hyporeflective spaces are also seen between neurosensory retina and RP, and RP and Bruch's complex was intact. My provisional diagnosis was right eye superiotemporal transretinal vein occlusion with cystoid macular edema in CKD patient. Management was given as patient has been planned from intravitreal injection anti-VEGF, and eye drop nepafenec 1 drop 3 times was given, and treatment of the underlying cause was also given in the medicine OPD in our college, and patient was advised for follow-up after 1 week. And patient is currently under observation and monthly follow-up. Thank you.
Thank you. You are absolutely before time, actually. So, judges, please have your questions.
So, Dr. Amar, which quadrant is most commonly affected in BRVO and why?
Most commonly present superiotemporal quadrant because of
like in your case.
Because, ma'am, numerous AV crossings are present at that site.
Like
arteriovenous crossings are present.
So why not did you say that BRVO is secondary to hypertension? Why in diagnosis it is CKD?
Ma'am, in hypertensive, ma'am, there is a diffuse and bilateral type of finding. Diffuse retinal hemorrhages are seen in this in BRVO. There is a superior only one quadrant is seen and not the.
No, I mean to say you are saying BRVO secondary to CKD.
Yes, ma'am.
Why not BRVO secondary to hypertension?
Ma'am, actually, patient is on hemodialysis, and patient reports are also mentioned that the patient was treated since 1 year for hemodialysis in our college, and that's why, ma'am, it is related to CKD.
But increased BP is the cause for BRVO, no?
Yes,
in
ma'am.
your patient, BP was raised, no?
Yes, ma'am.
So hypertension can be because of kidney disorder. It can be
Yes,
linked to that.
Maybe a cause of in chronic cases. Maybe it is a case of actually patient came on 9 this September 9th, ma'am. That's why regular follow-up was also considered. Patient was also come in near.
Okay.
We can go ahead to the next presenter.
Any other questions? Or we can move to next candidate. Dr. Gagandip.
Am I audible?
Yes, but you're not visible. Yeah, correct. Start.
Put it on slide share.
Right. Shall I? Good afternoon. I'm Dr. Gagandeep Singh Gulati, here to present on herpes zoster ophthalmicus, a case series. A 45-year-old male presented with burning and burning type of severe pain over the left side of the forehead and around the left eye since 5 days. Painful lesions on the left side of the face and forehead associated with itching since 3 days. Mucopurulent discharge from the left eye since 3 days. DOB left eye 2 days. Fever since 7 days. Had a history of chickenpox at the age of 10. Normal blood pressure and pulse rate, while the temperature was increased to 99 degrees. There's no history of immunosuppressive drugs. As we can see, there has been erythematous maculopapular skin lesion on the left side of the forehead and left upper eyebrow. The best corrected visual acuity of the left eye was 6/9. Intraocular pressure was 13. 4 millimeters after 1 minute of Sturmer's test. Ocular motility was full, free, and painless. While there was no problem, while the right eye was within normal limit, there was congestion in the conjunctiva in the left eye, mucopurulent discharge, cornea was clear, avascular, few chaotic precipitates over the endothelium, touch stain was negative, In the anterior chamber, few KPs were there, but there was no evidence of aqueous fluor or any foreign body. Equal round regular reacting normally to light pupil was present when reacting to accommodation as well. Lens was clear. On diagnostic evaluation, visual field testing was done, which showed no involvement of the optic nerve. Anterior segment OCT showed few hyperreflective deposit suggestive of keratic precipitate. Ultra wide field fundus photo was done, which is shown in the next slide. Lab test was done. CBC was WN within normal limit. ESR was increased. Viral confirmation was done with the help of Zank smear, and patient was HIV negative. The fundus for ultra-wide photograph of the fundus was within normal limit. Other case which I would like to the systemic treatment which was given were acyclovir and carbamazepine. The antiviral and the carbamazepine was given for the pain. Cold compression was advised at bedtime. Local and topical treatment, we gave moxifloxacin eye drop, prednisolone acetate, lubricating eye drop, and lactocalamine lotion. Moxifloxacin was given for the superimposed infection. On 12-day follow-up, the pain had decreased significantly, congestion and discharge had resolved, KPs had resolved, maculopapular region started resolving, BCVA improved from 6.9 to 6.6 partial. The other case I would like to present is a 65-year-old female complaining of severe burning type of pain on the right side of the forehead around the left eye since 15 days, painful lesion over the right side of the face, forehead, and the skin of the nose since 12 days, DOB right eye, double vision, drooping of the right eyelid since about 7 days, has a history of chickenpox at the age of 8, no abnormalities in the blood pressure, PR, or temperature. On ocular examination, the right eye unaided visual acuity was 1/60, left eye was 6/18. IOP was 19 in the right eye, 11 in the left eye. On external examination, there was pustular and crusted lesion on the right side of the forehead, right upper eyelid, and on the side on tip of the nose, which was a Hutchinson sign present. Ocular motility was restricted in all cases and painless. There was severe grade ptosis. There were on slit lamp examination, conjunctiva showed severe congestion. Cornea showed epidefect in the inferior quadrant, decimate membrane fold, few fine keratic precipitates on the endothelium. On F stain, large epidefect was seen. Anterior chamber showed no evidence of aqueous flare. Pupillin iris, in the pupillin iris, fixed non-reactive to light pupil was seen, and posterior synecdoche was appreciated. Lens showed immature senile cataract. This is the F stain, which showed large epidefect. Other details of the posterior segment were not visible. On diagnostic evaluation, VFA was done, which could not be assessed because of high level of cataract, and also the patient was not that much willing. Anterior segment OCT showed few hyperreflective deposit noted on the posterior corneal surface corresponding to precipitates. OCT macula was within normal limit. There was no evidence of edema. MRI brain showed no space occupying lesion. Routine tests were done in the laboratory tests. CBC showed lymphopenia. ESR was raised. Zank smear showed multinucleate giants, and HIV status was negative. The systemic treatment acyclovir, 800 milligram 5 times a day for 15 days, then 2 times to continue. Carbamazepine 200 milligram 1 time at bedtime until pain subsided. Cold compress over the left side of the forehead. Local treatment, eye ointment of ganciclovir 5 times daily to continue. Eye drop moxifloxacin 3 times daily for 30 days. Eye drop of sodium chloride because of high level of corneal edema 5 times daily 30 days. Eye drop of propicamide phenylephrine at 1 time at bedtime was given for synechialysis. Lubricating eye drop were prescribed and lactocalamine lotion was given. After 7 days, the pain had significantly decreased. Congestion was resolving, and BCVA of the right eye improved from 1/60 to 3/60. Further on, next follow-up would be done, and cataract surgery would be advised later on after the resolution of completely infection, after the complete resolution of infection. Thank you.
Thank you, Gagandeep. You are just on time. So judges, please have your questions.
So Gagandeep, wonderful case presentations to different case scenarios of herpes zoster ophthalmic and one with a Hutchinson sign and gross ocular involvement. So just one question to you. Have you heard about zoster vaccine?
Yes, ma'am. There has been a zoster vaccine which has been available since 2017. Shingrix was the name, and two doses are recommended in a immunocompetent individual below the years of below 50 years, and not affected by the virus yet. Not affected by herpes zoster ophthalmicus. Yes.
So usually we give it to elderly patients, not less than 50, but more than 50. And even those who had
Right,
an
ma'am.
attack in childhood, they can also be given to prevent the attack.
Right, ma'am.
Good.
Dr. Gulati, very nicely presented cases. Could you tell me what are the side effects of oral acyclovir that you have given to the patient in such high doses? What could be the possible side effects?
We have to check the liver function first because it is a hepatotoxic drug and nephrotoxic as well. So that has to be checked.
It has to be checked on follow-up as well, and it is
Yes, ma'am. Yes, sir.
it is nephrotoxic and not hepatotoxic.
Correct.
Thank you.
So Dr. Adarsh, next candidate, are you available? Or next is Dr. Shubham Singh. Adarsh, are you there? Dr. Adarsh? No. So we can go to Dr. Shubham Singh. Dr. Shubham, are you there?
Yes, ma'am.
Sure. So you are Dr. Shubham Singh, right?
Yes, ma'am. Yes,
Okay.
ma'am.
Perfect. Please share your screen.
Dr. Neha, be ready.
Dr. Neha Chaudhary.
Dr. Adarsh is from MGM.
No, ma'am. Neha is from MGM.
Okay, then you can take Shubham Singh.
Yeah, Shubham, your time starts now.
Good afternoon, everyone. I'm Dr. Shubham Singh, presenting a case of a 35-year-old female using glasses since 10 years, presented with acute DOV in both eyes with present glasses since 1 day. Her DOV was associated with pain and watering, and there was no history of any trauma, surgery, or any pre-existing ocular disease. Her general examination was within normal limits. Her uncorrected visual acuity was 460 in right eye, 360 parts in left eye, and with current glasses, it was 660 parts in right eye and 560 parts in left eye. Her BCA was 6.6 and 6.9 in both eyes. On slit lamp examination, lid, globe, conjunctiva were normal. Cornea was clear. There was no RAPT. Her fundus was disc healthy and it was not dilated in view of extremely shallow anterior chamber. The pressure was high in both eyes, 45 being in right eye and 46.5 in left eye. On Van Harris grade on slit lamp, both eyes were grade 0, which means angle closed. These are the video of gonioscopy, in which there was a positional closure, which was observed on primary position, which opens up on manipulation. It was a scan showing shallow AC and closed angle. The lens thickness and axial length were within normal limits, but the anterior chamber depth was low. With it, we can rule out microsphere of AKR due to normal lens thickness, and there was no high myopia because of normal axial length. So my DDs were pseudomyopia, primary acute angle closure glaucoma, uveitis, ciliary body tumor. On asking further, she told she was using topiramate for severe headaches since 10 days. So my provisional diagnosis was topiramate-induced pseudomyopia with secondary ocular hypertension. Patient was administered mannitol 300 ml IV stat and was prescribed following medications to control myopia: glycerol, ripasudil, brimonidine, timolol, travoprost, dorzolamide, and atropine. Cessation of topiramate was advised in consultation with a neurologist. On day 2, patient was symptomatically much better. Her IOP in right eye was 18 and 23 in left eye, and 40 mg Weissman OD was prescribed to reduce ciliary body inflammation and also to relieve accumulative spasm. Other medications were continued as prescribed. On day 3, there was no new complaints. Both the pressure was 10 in right eye and 11 in left eye. Brimonidine and timolol were stopped. The rest were continued as same. On day 10, her BCV was 6 in both eyes and IOP was normal. Atropine and dorzolamide were continued, and the rest of the medications were stopped. On day 17, both the BCVA and IOP was normal, and all the medications were stopped. There was a decrease in refractive error from day 1 to day 17. On day 1 being -5 spherical in right eye, and on day 17 in right eye, it was -2 spherical. And it was a -4.5 in left eye, which decreased to -1.5 on day 17. So glycerol and mannitol shrinks vitreous volume, which causes posterior displacement of iris lens diaphragm. That is how it rapidly controls IOP. For long-term control, ripastrol increases aqueous humor outflow. Brimonidine decreases aqueous humor production and increases UV scleral outflow. Timolol and dorzolamide decreases aqueous humor production, and atropine paralyzes the ciliary muscle, relieving the acute spasm. Topiramate is a sulfur-derived anticonvulsant drug often used in migraine prophylaxis. It causes choroidal effusion. Fluid accumulates in the suprachoroidal space, and it causes anterior rotation of ciliary body, which and it causes a shallow anterior chamber, secondary angle closure, myopia shift due to anterior movement of the lens. Increased IOP, and it also causes increased IOP due to angle, low angle, narrow angle. These are the other sulfur drugs which also falls within the sulfur derived drugs. Thank you.
Actually, you are before time. So, very good. So, judges, please go for your next questions.
Nicely presented case, Shubham. So what was the indication for starting topiramate in the first place?
Severe headache, sir. It was started because of severe headache, one-sided headache. It was started in consultation with a neurologist, as the patient said, and she was using it for the last 10 days.
Thank you.
Any other question from judges?
No, we can
Neha
move to
Chaudhary.
second one.
Yes, ma'am.
Yeah, you are ready. Dr. Shweta, you were asking some question?
I was just suggesting that we can move to next presentation.
So, Dr. Neha Chaudhary, please start your presentation.
Yes.
Share your screen. Dr. Payal Sarkar, please get ready for your presentation after Dr. Neha. Then after Dr. Payal, Dr. Divya.
Can I start? Hello.
Yeah, start your presentation.
Good afternoon, all. I, Dr. Neha Chaudhary, first year PG resident from MJ Medical College, going to present my case. Case scenario: a 23-year-old male from Jamshedpur came to OPD on 10 July 2025 with chief complaint of right eye upper eyelid swelling since 5 years, drooping of right eyelid since 4 years, and diminution of vision in right eye since 2 years. My patient was apparently asymptomatic 5 years back, after which he developed swelling over the right upper eyelid, which was progressive, gradual in onset, and of size 4 into 2 cm at the time of presentation, and it was not associated with pain and redness. Patient also presented with drooping of right eyelid, which was gradual in onset and progressive since 4 years with no diurnal variation and diplopia. Patient also presented with gradually progressive painless diminution of vision from right eye since 2 years, and it is associated with watering of eye on and off. Patient also gave history of macules and patches over the trunk. Past history of ocular disease. My patient had a similar history of swelling 11 years back, which was associated with drooping of eyelid in right eye, for which surgical removal was done 7 years back. There is no systemic illness present. In family history,
Patient father had a similar multiple discolored patches over trunk. In treatment history, patient is a known case of right eye upper lid plexiform neurofibromatosis for which debulking surgery was performed 7 years back and was under post-surgical medication for 2 weeks. Biopsy was done post debulking and features of plexiform neurofibroma was diagnosed. In personal history, my patient was a student. He had a mixed diet and normal appetite, and no history of smoking and alcohol consumption was present. In general examination, my patient was conscious and well oriented to time place person, and vitals were stable, pill code was normal, and on head to toe examination, 7 to 10 cafe au lait spots of size more than 1.5 centimeter was seen. On ocular examination, head posture was erect, facial symmetry was symmetrical, and on external examination in right eye, distant vision was 6 by 6, IOP was 10 mm Hg. On extraocular movement examination, superior gaze restriction present, color vision was trichromatic, and corneal sensation was reduced. In left eye, all parameters were within normal limit. On ptosis evaluation in right eye, MRD1 was minus 1 mm, MRD2 was 5 mm, interpalpebral fissure height was 4 mm, upper lid crease present, and LPS function was fair. And in left eye, all parameters were within normal limit. On slit lamp finding, in eyelid and adnexa, severe ptosis was seen. Eyelid was of S-shaped deformity. Diffuse swelling of size 4 into 2 centimeter was seen, and on palpation, it was of worm-like consistency. There was no tenderness present, well-defined margin, and having firm consistency. In conjunctiva, mild congestion was present. In cornea was clear. Anterior chamber was of normal depth. In iris, few lish nodules was seen, and pupil was sluggish reactive. Lens was clear. In left eye, all the parameters were within normal limit, but the iris has a few lish nodules. On fundoscopic examination in right eye and left eye, in both media was clear. Optic disc is of normal size. CD ratio was 0.3, and in macula, foveal reflex is present in both eye. Blood vessels were of normal caliber in both eye, and periphery was of normal. In systemic examination, in cutaneous examination, cafe au lait macules was seen, in CNS, there was no focal neural deficit was seen, and cerebral deficit was seen. My differentials were plexiform neurofibromatosis, capillary hemangioma, schwannoma, dermoid cyst, and recurrent calcium. The blood investigations were done and all the parameters were within normal limit. In CT scan, hypodense lesion measuring 18 mm into 17 mm into 16 mm size was noted in sellar region with mild thinning of right parietal and temporal bone. In MRI brain, right sphenoid wing dysplasia with empty sella and bony thinning of adjacent craniofacial bone was seen. Herniation of right anterior temporal lobe into the orbit causing optic nerve displacement and orbital involvement was seen. And ill-defined enhancing soft tissue thickening was seen in right side. Case summary. To summarize my case, a 23-year-old male presented with right upper eyelid swelling, drooping of right eyelid, and diminution of vision in right eye with history of multiple cafe au lait spots in trunk. On examination, right eye had a visual acuity of 6 by 6 with superior gaze restriction, severe mechanical ptosis, ciliary congestion, few lish nodules were seen at iris, and having sluggish reactive pupil. My final diagnosis is right eye upper eyelid recurrent plexiform neurofibromatosis involving the orbital region. Plan for management, surgical management, transcranial orbitotomy of right eye with eyelid reconstruction, a multidisciplinary team approach involving the ophthalmologist, neurosurgeon, and oculoplastic surgeon. And medical advice, symptomatic management was done, and genetic counseling was also done. Other modalities like MEK inhibitors, selumetinib and tramitinib can be given, which is indicated in symptomatic inoperable plexiform neurofibroma, and it can cause a shrinkage of 70% up to 70% of tumor, and may delay and reduce need for surgery. And debulking surgeries were indicated in a visual when there is a visual decline and progressive tumor growth involving a vital structure and progressive disfigurement or functional decline. Thank you.
Thank you, Dr. Neha. Questions, please.
Nicely presented case, Dr. Neha. Only one suggestion that always include a pedigree chart wherever possible, okay, in your case presentations. Since there is a positive family history and there is autosomal dominant inheritance pattern, do include a pedigree chart in your presentation. Thank you.
So, Dr. Neha, was gonioscopy done in your patient? So, what is the role of doing gonioscopy in cases with plexiform neurofibroma?
Actually, ma'am, leash nodules can block the trabecular meshwork and it can cause glaucoma. Maybe to see the anterior chamber there.
Now, many times there is goniosynecia and there are chances of glaucoma in such patients, and we must always take into account glaucoma in these patients. Was your patient having any sort of amblyopia?
No, ma'am.
So that also must be carefully looked into, because many times it starts in childhood and they have drooping of lid from childhood and that is missed.
Yes, ma'am.
Okay, Neha.
Thank you. So, Dr. Payal, are you ready for your case?
Yes, ma'am.
Sure, please start. Share your screen. Dr. Dibya, get ready for this is your next after Payal.
Share your slide.
Good afternoon, everyone. I am here to present a case. When the star fades, a case of neuroretinitis mimicking as optic neuritis. So the chief complaint, the 45-year-old male presented with complaint of right eye, diminution of vision in the right eye for three months back. The patient was apparently well 3 months back, following which he developed sudden onset diminution of vision in the right eye for 3 to 4 days. It was gradual in onset and progressive in nature. The diminution of vision was painless and there was no history of vomiting or headache, fever, night sweating with rigor or weight loss or any history of trauma. He visited a local ophthalmologist who diagnosed it as a case of optic neuritis and was given 3 doses of IV methyl prednisolone for 3 consecutive days. There was the medical history, no significant past history. He was a known case of hypertension, diabetes, IHD, cholelithiasis, and it was well under control and was under regular medication. He had a history of TB contact 15 years back. No significant past surgical history, no significant family history. General examination, the patient was alert, conscious, cooperative, and well oriented to time, place, and person. Average build. Other parameters were normal. Blood pressure was 128/90. Systemic examination was all within normal limits. Facial symmetry was symmetrical on both sides. External face normal, head posture normal, ocular position was normal, and ocular alignment was also central. On ocular examination, the right eye visual acuity without pinhole was FC at finger count at 2 meters. And with no improvement with pinhole, the pupillary reaction, right eye RAPT was present, extraocular movements was free and full in on direction of gaze, and no pain was associated with the movements. In left eye, visual acuity was 6/9 with improvement to 6/6 with pinhole. Pupillary reaction was normal and extraocular movements was also normal. So in the right eye, ocular adnexus was with normal, ocular motility was also normal, and color vision, we could not read any of the Ishihara charts. Left eye was, all the parameters were normal. So in the right eye eyelid, in both right and left eye eyelids was flat, conjunctiva normal, sclera normal, cornea clear, anterior chamber was deep and quiet, iris was normal in color and pattern. He was phakic and the clear lenses were clear. On
Posterior segment evaluation. In the right eye, media was clear, vitreous was clear, optic disc normal in size. The disc margins were blurred with peripheral hemorrhages. Cup was obscured. Macula was dull foveal reflex, and macular exudates was seen in the form of a star. Peripheral retina was normal, and tortuous vessels were noted. In the left eye, media and vitreous was clear, normal optic disc was normal in size, nasal margin was fuzzy, and CDR ratio was 0.4, macula was normal, peripheral retina and vessels were also normal. This is the fundus photograph showing the disc margins, which is completely blurred out in the right eye. And the exudates were seen in the macular area in the form of a star. This is the OCT of both the right eye and the left eye, and followed by the fundus FFA. So it was provisionally diagnosed as a case of fluororetinitis of the right eye. The treatment given, the patient was started on tablet prednisolone acetate 10 mg and was started on initially 6 tablets once daily for 1 week, and the doses were tapered accordingly. Tablet omeprazole for once daily for 6 weeks, and tablet calcium. On follow-up after 2 months, the visual acuity was improved from FC at 2 meters to 6/9 in the right eye, with no improvement with pinhole. Now the pupillary reaction was normal. All the extraocular movements was also normal. And posterior segment evaluation, the optic disc was normal optic disc was normal and with normal in size, with only the nasal margins was blurred. The macula was still, the foveal reflex was dull. This is the 2 months follow-up photo in which we can see that few exudates were seen, but no macula star present. This is the OCT picture. So the plan of management, we ordered the following investigation for the patient: the viral markers, HBsAg, anti-HCV, HIV 1 and 2, VDRL, TB gold interferon, MON2 test, toxoplasma antibody, and non-treponemal antibody, serum ACE, serum calcium. Discussion, neuroretinitis refers to a combination of optic neuritis with signs of retinal inflammation, usually macular. The treatment should be specific to the cause, often consist of antibiotics, and often the recurrent idiopathic cases may require treatment with steroids and or immunosuppressants. The most common etiology of neuroretinitis is found to be 60% cases with cat scratch fever, idiopathic 25% cases, and other notable causes include syphilis, mumps, measles, herpes simplex and zoster, varicella, Lyme's disease, leptospirosis, toxoplasma, toxocara, and some inflammatory causes include sarcoidosis, SLE, Behçet's, polyarthritis nodosa, Takayasu, VKH, and inflammatory bowel disease. So we also have to keep some differentials in mind, such as the hypertensive retinopathy, papilloedema, anterior ischemic optic neuropathy, diabetic papillopathy, posterior vitreous traction, disc and juxtapapillary tumors, and toxic etiologies, including base-chloroethyl, nitrosourea, and procarbazine. Thank you.
Judges, please, your questions. She has crossed a few seconds.
Okay, Dr. Payal, you have mentioned in your slide the first and the foremost cause being cat scratch, and you did not elicit any history of pet exposure or cat scratch in your presentation. So don't you think?
No, he didn't have any like pet or any.
So that was not mentioned in your presentation. That's what I mean to say. Go ahead, Dr. Shweta, you want to ask?
The same question. I was also having the same question. I think we can shift to next presentation.
I'll keep that in mind.
Okay, so presenter, please get ready. It's Dr. Divya.
Yes, ma'am.
Okay. Yeah. Dr. Shreya Kaul, you are the next presenter. Please get ready. Dr. Shonia Ghosh, are you there? Dr. Shonia? Okay. So, Dr. Dibya, please share your screen.
Okay, ma'am. My screen is visible?
No, not yet. You have to share your screen. You have not yet shared. Yeah, it's coming up. Please start.
Good afternoon, everyone. I'm presenting a case report on.
Slide share.
Hello, good
Everyone,
afternoon.
slide share. Slide share. Yeah, it's all right.
Good afternoon, everyone. I'm presenting a case report on golden hour syndrome. Case presentation: a 23-year-old male reported to the eye OPD with diminution of vision in both eye and a mass over both eyes since early childhood, as per history acquired by patient and attendant. On examination, right eye upper lid coloboma seen, epibulbar choristoma seen. Left eye epibulbar dermolipoma was seen. Preauricular skin tags were present. Micrognathia, maxillary hypoplasia, facial asymmetry, hemifacial microsomia was seen. He had cleft lip for which he had undergone surgery in childhood. This is the picture for the same. Right eye on ocular examination, right upper lid coloboma present revealed a smooth and soft mass in the right eye, posterior limit of which could not be seen. From above downward, it was extending from the superior to the inferior fornix. Left eye epibulbar dermolipoma located in the inferotemporal region of the eye, arising from the inferior fornix. It was extending from the lower fornix to the limbus. These are the pictures. On palpation, mass was found to be soft, non-tender, and its temperature was not raised. It could be moved over the underlying structure, and conjunctiva over it could also be moved. His visual acuity was: right eye visual acuity could not be assessed, left eye 6/24 and corrected to 6/9. The rest of the anterior segment was normal. Fundoscopic examination was found normal. The clinical diagnosis was dermolipoma, which was confirmed on histological examination of an excised portion. ENT examination revealed preauricular tags present in both ears, micrognathia, maxillary hypoplasia, facial asymmetry. No other abnormalities were detected. Systemic examination like cardiovascular, pulmonary, and genitourinary system was done, but no abnormalities were detected. The laboratory examination were within normal limit. ECG was normal, chest ray, no abnormality detected. X-ray of the vertebral column was normal. A diagnosis of golden hour syndrome was made, which is also known as oculo-auriculovertebral dysplasia. A few words in golden hour syndrome. It is a craniofacial syndrome, which means it causes certain abnormalities in the formation of face and head. It is a rare congenital birth defect resulting from the abnormal development of the first and the second brachial arches, with incomplete development of the ear, nose, soft palate, lip, and mandible. It is unilateral in 70 to 80% of the cases. Incident rate is 1 per 25,000 or 45,000 live birth. Male is more commonly affected than female. Risk factor: maternal intake of thalidomide, cocaine, retinoids, tamoxifen, anticoagulant result in hematoma in the region of the developing ear and jaw, which causes destruction of the differentiating tissue, leading to the brachial arc dysplasia. Maternal diabetes, bleeding in second trimester, malnutrition, exposure to tobacco during pregnancy, maternal and fetal hypoxia, and hypertension. Clinical features: facial abnormalities, hemifacial microsomia. One side of the face is smaller compared to the other. Cleft lip or cleft palate. Defect in eye, ears, and spine. Ocular anomaly occur in 50% of the cases. Epibulbar dermoid and lipodermoid are most common. Limbal dermoid and lipodermoid are mainly located in the inferotemporal region of the eye. Coloboma of the upper eyelid may be present. Ear extraocular defect are reported in 65% of the cases, and it includes preauricular tag, microtia, anosmia, conductive hearing loss. Spine: incomplete development of the vertebra, fused, missing vertebra, scoliosis, hemivertebra, fused ribs, kyphosis, and scoliosis. Intellectual disability: additional features such as cardiac, genitourinary, and pulmonary symptoms can be affected. Diagnosis is mainly clinical, based on history and examination of the eye, face, and skeletal system. Prenatally, ultrasonic diagnosis may theoretically be done at the 11th to 15th week in utero. Newer imaging modalities such as three-dimensional ultrasound may help in detection of microtia, preauricular tags, and asymmetry of the mandible even in mild form. Hearing and vision tests, ASOCT, help to look for the depth of the lesion and corneal stromal involvement in planning of surgery. Ultrasound biomicroscopy is used to look for the depth of the lesion and involvement of the angle of interior chamber. X-ray of spine, imaging of a heart and kidney. Differential diagnosis. Preacher-Collins syndrome usually shows similar features with a bilateral presentation. Downey-Brooks syndrome shows additional thumb abnormalities, anal defect, renal anomalies, which are not seen in golden hour syndrome. Linear nevus sebaceous of Jodashian shows additional features of cloudy cornea, verticutaneous lesion, infantile spasm. Chart syndrome is associated with the characteristic semilunar canal anomalies and cranial nerve dysfunctions, while mandibulofacial distortions can be differentiated by esophageal atresia and microcephaly. Treatment: complex reconstructive surgeries or glasses, oculoplastic surgery to manage oculopalpebral defect, palpebral reconstruction, lamellar keratoplasty, amniotic membrane and limbal stem cell transplantation. Hearing aids, surgery to correct heart and spine defect, refer to hearing specialist or speech therapist. Educational specialist for intellectual disabilities. This is the picture before surgery and this is the picture after surgery. Tension flap or Cutler bread, it is a surgical technique used to reconstruct large upper eyelid defect involving a two-stage procedure. Stage 1, full thickness cutaneous conjunctival flap from the lower eyelid to fill the defect of the upper eyelid to provide coverage and support. Stage 3 performed 6 to 8 weeks later after the flap has vascularized. The surgeon then divides the flap pedicle, the lower eyelid tissue is returned to its original position, and the lid margin is repaired to restore full functionality and cosmetic appearance. Thank you.
I have only one suggestion, Dr. Divya. Try to make your presentation a little presentable by reducing the content in the slides and using appropriate fonts and headings. So that makes the presentation better. Okay. Can go to the next presenter. Dr. Shweta, you want to
Hello,
ask?
hello. No, we can move to next presentation.
Dr.
Can we
Shreya, are you available? Shreya, call.
Yes, ma'am. Good afternoon, everyone.
Please share your screen.
Is my screen visible?
Yeah, put it on slideshow.
Your time starts now.
Good afternoon, everyone. My name is Dr. Shreya Kaul. I'm a PG first year doing my DNB ophthalmology at Manipal Ranchi. Courtesy for this case to Dr. Bikramjeet Pal. The title for my case presentation is Ocular Manifestation as a Primary Presentation for an Underlying Critical Systemic Disease. So for my case, this patient is a 32-year-old young male. He's a salesman by profession. His chief complaint was he presented with a bilateral, gradual, painless diminution and blurring of vision for 3 months. For the systemic history, he noted low-grade fever as what he was telling, on and off for the past few months, and mild weight loss was noticed by the patient. So this patient has taken a primary consultation elsewhere. He was initially diagnosed as a case of hypertensive retinopathy and was advised anti-VEGF injection in both eyes. For the past medical history, no significant history is being given by the patient, no significant family history has been given, and no comorbidities has been explained by the patient. For the past surgical history, intravitreal injection history has been given by the patient. He had been given those injections elsewhere, 1 dose in each eye. For the ocular examination, the visual acuity was noted for the best corrected visual acuity was noted as 612 in both eyes and N6 for the near vision, both eyes. Color vision was noted normal in both eyes, the intraocular pressure being 12 millimeter of mercury, both eyes. For the anterior segment examination, both eyes showed were unremarkable, no significant findings were noted. So now, till now, there is no significant finding noted. Then we proceed to the fundus examination, for which we did a fundus photo for both eyes. For the findings, we see scattered hemorrhages in all quadrants, multiple rod spots were noted in all quadrants, and perivascular whitish infiltrates were noted. These are the fundus photos of both the eyes for the patient. As we can see here, in these fundus photos, regarding the media is clear, the image is pretty clear. The optic disc, if we note, the margins are not really clear. We can note slight hyperemia in the nasal side of both the discs. For the arcade vessels, we can see there's tortuosity present. There is a little dilation also present. And there is a perivascular whitish infiltrate around all the blood vessels. The arrows point towards the classical appearance of the rod spots that were noted in the fundus photos. This is a montage view for this for the right eye, for the left eye, and same rod spots, extensive rod spots were noted throughout the fundus. So next step, we try to investigate. Our most relevant clue stays extensive rod spots being over the fundus here. In the investigations, the most significant finding that we could point out to was a complete blood count and a peripheral blood smear done for the patient, where we note that patient has low platelet counts and the characteristic finding of an immature blast cells present. Next step, we immediately go to an oncologist. We refer the patient to an oncologist. For the final diagnosis, the oncologist diagnoses the patient being in the blast crisis stage of the chronic myeloid leukemia. For the management, immediate treatment was started as was directed by the oncologist. These are some reference articles which mention that ophthalmic problems usually they can occur due to direct or indirect infiltration of the neoplastic cells. Although almost all structures could be affected, leukemic retinopathy is the most frequent clinical manifestation that could present to us. Another article that suggests that patients will present with bilateral subacute visual impairment. The fundal examination would reveal bilateral symmetrical leukostatic appearance with increased vascular tortuosity, diffuse retinal infiltrates up to 6 disc diameter size, retinal hemorrhage as the classic appearance of a rod spot. Another article that mentions that resolution of leukemic retinopathy, usually when the treatment, for example, imatinib therapy is started, it usually is seen in 6 months after the initial visit. The retinal hemorrhages would have resolved and remain so after 18 months, as suggested in this case. The takeaway from my case presentation would be a systemic condition could present as an ocular finding being the primary presentation to us. The eye necessarily becomes a window to an underlying case in these things. This highlights the role of us as an ophthalmologist in diagnosing the systemic diseases when ocular manifestations are the reason of the patient's first visit regarding the same. And a timely diagnosis in early to moderate cases could help initiate early treatment in such cases. Thank you.
Thank you, Dr. Shreya. You ended before time. Now the judges, you can take the questions, please. Any questions from the judges?
Dr. Kaul, what are rod spots?
Ma'am, rod spots are basically what they appear to us are like they have a white center with a periphery of hyperemic area. So in any condition where we have there's some in any condition where some glucostasis has occurred, in which some rupture of the capillary has occurred. So due to the endothelial damage, what will happen is that there is platelet coagulation cascade that gets activated. And due to that, there is a center of the infiltrate of cells. In leukemia, it will be the leukemic cells, and the periphery will be hyperemic due to the inflammation that has occurred.
Correct. Very good.
Dr. Shreya, the
Yes,
leukemic retinopathy that you have shown in this patient, is it more common to occur in acute leukemias or chronic leukemias?
So, sir, this kind of presentation more common will be in acute leukemia, but because this patient was eventually found to be in a blast crisis stage, which can mimic an acute leukemia stage of the patient.
There were certain pointers. Had the patient been evaluated previously, because the patient had fever and weight loss since 3 months. So if
Yes,
a
sir.
systemic evaluation would have been done previously only, then it would have been caught at that time as well.
Yes, sir.
Thank
Yes, sir. Thank you, sir. Thank you, everyone.
Now the next speaker is Dr. Sonia Ghosh. Are you there? Dr. Sonia? So with that, we end with this session. the paper presentation session. Now our next session is the guest lecture session. We'll announce the winner after this session. Madam Rashi Shyam will take over from here.
Doctor, I see two speaker left. Dr. Shrishti Shreya, उसका हो गया है. Dr. Sonia Ghosh.
Yeah, Sonia Ghosh is not. She is not present, madam.
Acha, all done na?
Yes, ma'am, all done.
Okay, so now we have to start the guest session, but first you have to introduce them. Each speaker you have to introduce, then the guest speaker will give their talk.
So, good afternoon, everyone. This is the session 4, which is the guest lecture. We apologize for the slight delay we are running into, and we heartily welcome and thank our guest lecturers who have been present.
Stop. First, I have to introduce the coordinator of this session. Coordinator of this session is Dr. Rashi Shyam. She is trained in Shroff Eye Hospital, and she is a prolific glaucoma and cataract surgeon. And she is the coordinator, and she runs Kamal Eye Hospital in Ranchi, director of Kamal Eye Hospital Ranchi, and she is the coordinator of this session. So welcome, Dr. Rashi Shyam.
Thank you so much for your kind words, ma'am. So Dr. Shweta Walia and sir have been with us very patiently for the last few sessions, and we welcome you once again. I would like to introduce them before we proceed with the guest lecture topics. So Dr. Shweta Walia, ma'am, she is a fellow pediatric ophthalmology and strabismus from SNC Chitrakoot. She is currently chairman scientific committee of the Madhya Pradesh State Ophthalmic Society. She has more than 50 publications in national and international journals to her credit, and the innovative technique of sutureless glueless SFIOL in 2016 as well. There are many, many awards to her name, and to name a few, these are the All India Talent Search Scholarship Award by the then Prime Minister of India, Shri H.D. Devegowda sir. Best Teacher Award, Srimati Mani Harish Chandra Memorial Award. Winner of the Clash of Titans at Indore Annual Medical Publication Award, NICA Award, and Award of Excellence letter by Indore Collector and Minister Kailash Vijay Varghese during 26 January parade ceremony for the exemplary work done by her to promote eye donations in the city of Indore.
Thank you, Dr. Rashi and Dr. Bharti, for such kind words and inviting me over here. So today I'll be presenting few tips and tricks for IL-PAR calculation. We all know that cataract surgery is our bread and butter, and we all need happy patients every time. And on post-op day one, all of us would be happy seeing our happy patient. And if the patient is gloomy and we have to prescribe glasses to him, it is a heartbreak to us. So surgery is an art, but accurate calculation is built on numbers, and we as being doctors are very bad at mathematics and numbers, but few tips and tricks can make us master of these numbers. So why IL-PAR calculation is critical? Because good biometry gives us good outcomes, and all our patients demand an unaided 6x6 vision. And a small error of 0.1 millimeter in axial length calculation can amount to 0.25 diopter of refractive error, and to extrapolate it 1 millimeter leading to 2.5 to 3 diopter of power shift. Similarly, in keratometry, a 1 diopter of error can amount to 0.9 diopter of IL error calculation. And if the effective lens position is not in the bag and is just 0.1 millimeter forward, and it will lead to 1 diopter of refractive error in the post-operative phase. So the surgery ends in OT, but the success continues in the clinic. So it was long back when IOL was started during the period of World War II. It was Harold Ridley who first implanted the first IOL. And that patient had a refractive error of minus 18 diopter with a large number of cylinder. So this is not acceptable these days, but it was at that time. And then Binkoff came up with a pre-pupillary lens, and he also had same refractive error. So this led to some improvements and some IL-PAR calculation, so that the patient doesn't have to wear such big number spectacle. And then Fyodorov came with a power calculation in which he incorporated axial length, refractive power, and anterior chamber depth. Now, when we are calculating IL power, we take into many parameters into account: the axial length, the K reading, anterior chamber depth, effective lens position, and the IOL constants. Also, few IL formulas have white-to-white corneal diameter also incorporated. So coming to the first keratometry, it measures the anterior corneal surface. We can do it manual, but it is very rarely performed. We can use autorefractometer. Optical biometer has incorporated inbuilt in it, and we can also use topography and tomography when we specifically need to have the posterior corneal astigmatism, and in patients having irregular astigmatism when we are planning incisions and to assess the spherical aberrations. Now, biometer can be either an ultrasound or an optical. Ultrasound is usually contact and immersion. Immersion gives readings which are par excellence with the optical biometer. We can go for immersion if done properly, and it gives a result typical to the optical biometer. But optical biometer is superior as it gives a telecentric keratometry and true K values as it measures the posterior corneal surface also. And there is a fixation check also because continuous B scans can confirm the foveal pit visualization for accurate axial length measurement. Now, many of us still are doing contact we are still on ultrasonic biometer, and it must be done most accurately. And in our medical colleges, the residents are doing this A scan, and for them, it can be done either in a seated or a supine position. When we are doing immersion, and the patient has to be in supine position, we have to put a topical anesthesia, give them a fixation target, and you have to touch the cornea without indentation, and you have to note down the echo spikes. The echo spikes have to be of 100% height, and they should be at 90 degree to the surface. So you can see over here that there are 5 spikes that can be seen in a contact type of ultrasound biometer, and all of them are having a high peak and are of good resolution. Now I am showing now another A scan over here. You can see that this spike is not 100%. So this scan you will delete from the 10 readings that are coming, and then you will again retake for recalculation. So all such, when we are doing biometry, you should see what type of spikes are coming. Now see this picture. Over here you can see that the first spike is having 2 spikes. So my question is it normal, or we have to delete it and take another? Rest all of the spikes are of 100% height and are of good resolution. So why this 2 spikes have come? Has anyone ever noticed this? Yes, most of us have noticed who are doing immersion ultrasound. And in ultrasound, both the cornea is giving spike for the epithelium and endothelium. And if you see these 2 spikes, it clearly indicates that this scan is immersion type. So this can be asked in their postgraduate viva also, and they must know the difference on the scans, whether it is a contact type or an immersion type of A scan. Now see the scan. Over here, you can see that axial length measurement has come 24.60, and another it has come 24.18. So this difference is because of compression, and this slight difference has led to a refractive error of minus 1.25 diopter spherical postoperatively. So you must be very careful when you are calculating the A scan powers. Now over here, you can see that the retinal spike is not perfectly straight. So that it means that the probe is not aligned properly, and this scan should be deleted and another scan should be taken. Now see, here's a case of a 65-year-old male for routine cataract, and he has undergone contact ultrasound. The axial measurement was 21.2. Retinal IOL power was 22 diopter. However, the post-op result was plus 2 diopter hyperopia. So what has amounted to this? This is because that the cornea has indented and has led to false short axial length. So compression of cornea should be avoided, and you should be very careful when you are doing to contact ultrasound. Now, most of us have now shifted to optical biometers, but we should be careful in those cases also. Now, this is a case 2, and it is a 70-year-old male, and IL master has given the readings, and the target achieved is 6/6. So what has worked, because the fixation is verified as in this optical biometer, the ocular surface is good, and we take a true K, and anterior chamber depth and lens thickness is measured accurately, and that's why the patient has achieved a target vision of 6/6. But this patient, a 62-year-old female who is a diabetic, an optical biometer was done and predicted IL power was 21.5. However, again, the post-operative result was plus 1.5 diopter hypermetropia. So what went wrong? So this is a diabetic patient, and diabetic patients usually have a dry eye, and this must be taken into consideration. The corneal surface, the ocular surface should be perfect. And in this case, because of dry eye, there was false steep case, and this overestimated the corneal power. So ocular surface optimization is very, very crucial. Now, dry eye symptoms can mimic cataract symptoms like glare, halos, and decreased vision. And surgery can worsen the dry eye, leading to patient dissatisfaction. So dry eye identification is a must before surgery. And if the patient has a moderate to severe dry eye, first we must treat the dry eye, inform the patient that he has dry eye, and post-operatively also he can continue with the symptoms. Now, this is another patient who is a myopic and has axial length of 28.5 millimeters. And an optical biometer was used, but still the patient is myopic by -2. So what went wrong? So we have to see what IL formula you are using and what is the effective lens position. Many times the effective lens position changes, and this leads to a refractive surprise. So in high patients having high axial length, either a Barrett formula or a Von-Gitch calculation must be done. So this is the case. Over here, you can see that the axial length in right eye was 24.48, while in left eye it was 25.71. So 1.25 millimeter difference is there, and this can amount to a difference in the IL power. So in right eye, the power came out to be 11.5, and in left eye, it came out to be 6. However, when we see the formula used, when you are using the Barrett, the power is coming to 7. And when you are using SRKT, it is coming to 9. So which formula to take? Now, in this case, we will see what are the K values of the patient. The K values are also not normal for this patient. In right eye, it is 46 and 48. In left eye, 47 and 49. So in such patients who are having large corneas, in those, even if the axial length is different, you must go for SRKT formula, and for this patient we'll go for 9 diopter, not for by the 7 using Barrett formula. Though Barrett is a universal formula that we can use at any time, but if the K values are abnormal, we must go for SRKT formula. So you must check with all the formulas, what formulas are coming, what values are coming, and then take a call. So there has been evolution of IL formulas from early approaches to regression formulas, to theoretical formulas, to new novel formulas, the Barrett 2, the EVO, the Kane, Olsen, and the Pearl formula. And for normal axial length, most of the formulas work well, while for short axial length, Barrett, Hills, and Hagues and Olsen formula works well. While if the axial length is long, we usually go for Barrett, Hill, Hagues, Olsen, SRKT, and also for an Von-Gitch adjustment. What is Von-Gitch adjustment? If the axial length, for increasing axial length, we have to subtract some amount, and this is done for long axial length patients. You can use various online calculators. The ASRCS formula, the site gives us various tools to calculate, and this is a wonderful site, and you can check your whatever formula power is coming with your A scan, put those readings over here and use new formulas. Now, when you are planning for toric IOL, you can use the online calculators and plan your incisions. Now, if there is an anisometropia, recheck everything. The formula should be matched for axial length, match the power with the spectacles, and select IL power based on agreement across multiple methods. Effective lens position is a very important thing. many times you have done everything correctly, but still the patient comes up with a refractive surprise. And this can be because of effective lens position change. Many times there is rent and you have to plan the lens into the sulcus. And at that time, this back sulcus algorithm comes to our help, and we can recalculate our power and place the lens into the sulcus. Now, what about the cases who have undergone some refractive surgery or a RK surgery? Now, this is a case of a post-RK patient with 20 marks. So in these, the care readings are unreliable, and biometry suggests widely different ions. Also, the K readings changes with dian variation. You have to select the flattest K, and target refraction has to be myopic. And you can use ASRCS post-RK calculator, and with the Barrett true K vac, you can get the IL power. Similarly for the post LASIK patients, you can use the online calculators and use them. Now in pediatric patients, for more than 6 years, we can use IL master. For patients between 3 to 6 years, we can attend for an IL master and confirm on A scan. For children less than 3 years who are uncooperative to sit on the machine, we can use immersion A scan under anesthesia. And since the pediatric eyes are smaller, we can use Barrett formula with Dahan's corrections. If the child is between 0 to 2 years, we undercorrect by 80%. For 2 to 8 years, 90%. And for more than 8 years, no undercorrection is done. We aim for emetropia. So counseling of patients is very, very important. The high-risk patients, that those are having short eyes, long eyes, undergone refractive surgery, or a keratoconus patient, we must be very, very careful. We should spend time in communication, discuss with them the refractive surprise that can occur, address the potential need for glasses, and show them calculation sheet. Also, explain them limitation of technology, discuss post-operative options, and consider two-step approach. So lens constant optimization is also very important. We all usually take the lens constant that is mentioned on the IOL, but we must validate it with our data, what surprises, what outcome you are getting, and you can use that A constant for them. You must stay current, read journals, attend meetings, watch webinars, join the communities. And whenever there is a post-operative surprise, review the initial calculations, biometry parameters, check for any surgical complication that had occurred. If there is significant residual error, consider for IL exchange. For IL exchange, remeasure when cornea is spoiled. Use multiple new generation formulas. Adjust power for second eye based on first eye outcome, which can improve the accuracy. And avoiding errors, you must put a checklist to confirm the patient ID, correct eye, IOL type, and power before the implantation. So you must be master of the fundamentals, understand the biometry principles and measurement techniques, use multiple formulas, no single formula work best for all eyes, recognize the special cases, continuously improve yourself, and stay current. Thank you so much.
Thank you so much, ma'am, for such a complete and detailed presentation, which will, I'm sure, help the PGs as well as all the consultants who are watching us
Oh,
today.
it is helpful to me also. It is so good. And it is so simple and so practical. It is really very nice.
Thank you so much, sir. Thank you so much.
I would now like to welcome Dr.
Actually,
Devesh.
yes, yes.
So, sir is an assistant professor in Dr. RP Center Ophthalmic Science Institute of AIMS. He has been a graduate as well as he's done his post-graduation from there, and he's an FRCS from Glasgow also. He has been assistant editor of Delhi Journal of Ophthalmology and examiner in FRCO and FACO. Now, there are many awards and recognitions due credit to him, and Dr. Bodhraj Sabharwal Gold Medal Award, Elergan Academic Achievers Award, Dr. V.K. Kalra Memorial Trophy Award, Certificate of Merit from IJO in 2021, and a Gold Award in 2023. AIOS International Heroes Award in 2023, Best Poster Award for Trauma category in AIOS APAO 2025, and Dr. Arjun Narang Award for the Best Paper Presentation in Annual DOS 2025. There are more than 85 publications to his credit, and he has been an editor of the educational book on diabetic retinopathy by ARC AIOS also. We welcome you, sir, and can you please proceed now?
Thank you for the kind introduction. Is my slide visible?
Visible, visible.
Okay, so I'll be talking about tips in the management of diabetic tractional retinal detachments. So what are the management options that we have for diabetic tractional retinal detachments in a diabetic patient? So mostly we undertake these patients for vitrectomy when the macula is involved in the tractional retinal detachment, as we see in this photograph, that there is an extensive tractional retinal detachment which is involving the posterior pole, or if the macula is threatened by the tractional retinal detachment. As we see in this image, there is a tractional component of detachment you can see along the supratemporal arcade. There is fibrovascular proliferation at the disc, nasal to the disc, and along the supratemporal arcade as well. And along the supratemporal arcade, you have a tractional retinal detachment, which is not directly involving the macula, but yes, it is threatening the macula and it is causing some striae on the macular area, and therefore the macula is threatened and you need to operate these patients so as to preserve their vision. Now, what about observation alone? So observation can also be one approach in extramacular tractional retinal detachments, because often these tractional retinal detachments which are extramacular or outside the posterior pole remain stable. And if the patient is compliant enough to follow up, then you can observe these patients. Like we see in this photograph, there is extensive fibrovascular proliferation nasal to the disc and along the infratemporal arcade, but it is not involving the foveal center. And if the patient has stable vision and is compliant to follow up, then you can observe these patients. Now, what are the pre-operative considerations that you should make before taking these patients for surgery? First and foremost is the metabolic control, wherein you need to control the blood sugars and blood pressures. There are safe glycemic targets for elective surgeries, like you have HbA1c of 7% or less, which is required for elective surgeries. But if we consider diabetic tractional retinal detachments, which are involving or threatening the macula, then that HbA1c target may not apply over here. So a recent good enough control might be good enough. So in most of the studies, there is no mention about the recent control, like how long you need to have a good control. But majority of us would consider even a couple of weeks, maybe 2 to 3 weeks of good control before taking up these patients for surgery. Now, blood pressures and renal functions should be very, very well controlled before taking these patients for surgery, because there will be profuse bleeding when you are encountering such vascular tissue or fibrovascular proliferations. If the patient is again on anticoagulants, then you need to modify them or stop them before surgery in consultation with the cardiologist. And if there are any infections, whether be it periocular infection or any systemic infection, such as a diabetic foot with an active infection, then you should avoid surgery in those patients. Now, imaging is very important when you take these patients for surgery. Like we see in this patient, we see there is a tractional detachment along the supratemporal arcade, but we cannot be sure whether that extension of the tractional detachment is happening into the macular area. So you need the macular osity, and even though there is no macular extension of the tractional retinal detachment, what we can see on the OCT is that the tractional schisis or splitting up of the retina is going right till the foveal center. So now this is going to affect the vision of the patient, and you cannot observe these patients, and you have to take up these patients for surgery. And in the bottom image, you can see there is a significant tractional component on the disc as well. And so a vitreopapillary traction is also significant in this patient. Coming to ultrasonography, so you resort to ultrasonography when you cannot evaluate the fundus because of dense hemorrhage or media opacity. So in this patient, you see an extensive fibrovascular proliferation, but you cannot make out whether there is any tractional retinal detachment underlying this proliferation. So when you do an ultrasonography, then you see that there is a tabletop tractional retinal detachment, and you have to be mentally prepared to deal with it. Now, the objectives of a surgery remain to remove the traction from the macula, that is the primary objective, remove the traction from the arcades, that is the secondary, and then remove the traction from the disc. So this is the main objective, that you remove any traction from the posterior pole. Peripheral traction need not be completely removed. That is not the main objective of the surgery. Now, you have to avoid iatrogenic breaks at all at all cost, because you don't want the rheumatogenic retinal detachment to develop in these cases. And last, you have to achieve hemostasis during the surgery and prevent any rebleeds to happen in the early post-operative as well as late post-operative period. Now, pre-operative anti-VEGF and laser play a very crucial role. And if you see this patient, you can not think of entering this eye without giving any pre-operative anti-VEGF, because it's a very vascular tissue and it is likely to going to bleed, and you're not going to find any cleavage planes easily. So if we give pre-operative anti-VEGF maybe 3 to 5 days before surgery, then it reduces the vascularization, it facilitates the dissection, and it reduces the risk of intraoperative breaks as well. And similar is the role of preoperative PRP. So if it is possible, you should do PRP away from the traction retinal detachment, because it will act in lines of anti-VEGF injection, although not very promptly, because the effect will come in a couple of weeks. But still, if you have a couple of weeks before surgery, it's always better that you do laser away from the traction retinal detachment. In addition, it also helps in peripheral hyaloid separation that eases your surgery. So if you see this patient, when we took this patient up after doing laser in the peripheral area and giving an anti-VEGF injection a couple of days before surgery, you can see how the vascularity of the tissue has reduced during surgery, and this tissue can easily be dissected and segmented without risk of intraoperative bleeding and complications. MIVS remains the key to safe surgery in diabetic vitrectomies, be it 25 gauge or 27 gauge. 23 gauge instruments are more rigid. They allow for faster vitrectomy, but 25 and 27 gauge, they have ports which go very close to the tip, and bevel tips, if they are there, then that allows dissection and segmentation and as well as delamination very close to the retinal surface. Valve cannulas, the importance cannot be highlighted enough, because intraocular pressure control is very important in these surgeries. Otherwise, with a sudden collapse, you can have profuse bleeding occurring from the fibrovascular proliferations. Now, the aim of the surgery is to remove the membranes from the posterior pole as much as possible safely. And there are different approaches that you can use, the most common being the inside out or the outside in approach to the membranes. In the inside out, you target in the peripapillary area first, and then you go out as you dissect these membranes. And in the outside in approach, you start from the periphery and then approach the center later on. And you use either segmentation or delamination. Segmentation is preferably done for denser membranes, and delamination, thin friable membranes could easily be delaminated. And all these maneuvers can either be done unimanually or bimanually using a chandelier illumination. Now, coming to a few surgeries that will highlight these tips. So it's a 25 gauge vitrectomy which is done here. And you can see that we have started with the peripheral hyaloid, which is already separated. We are removing it, separating it so that the tractional retinal detachment is separated from the vitreous base area. So we are going all around, and you have to be careful that the underlying retina, you have to be wary of the underlying retina, that you don't create any breaks in the underlying retina if it is detached. Now we are approaching the fractional retinal detachment. We are going from outside in, and carefully you lift the membranes and see the underlying retina before cutting. So this is segmentation that is happening between the different vascular epicenters. There's always a better to do it in a high magnification. And again, we are resorting from now inside out. We are going from the disc to out. Again, we are segmenting around the vascular epicenters. And the membranes could be very tightly adherent. So it's always better that you insinuate your cutter tip between the membrane and the retina, find a plane, and then segment it. So once you are done with your segmentation, you have to ensure hemostasis there and there itself. If there are any bleeders, try to pathologize them there itself, because otherwise the coagulum may form and then it might be difficult to remove it later. It's always important that you identify the posterior most hyaloid in these patients, because there often could be vitreochassis present. And like you can see over here, there's a flimsy posterior hyaloid membrane that is still left. And if you remove it, then that will ensure removal of the complete traction in your cases. So here we can see that we have removed the posterior hyaloid membrane also. Once it is done, then you can approach the proliferation at the disc. You need not peel it off from the disc because then there may be bleeders which you may not be able to diathermize. Always better to leave some stump. Now then you move to the periphery, and if there are thin friable membranes that could be easily delaminated, you can delaminate, as we can see here. But with the cutter itself, now we are delaminating it rather than segmenting it further. When you complete the vitrectomy, a peripheral shave vitrectomy is to be done because that acts as a source of VEGF and that can lead to anterior hialoidal proliferations later on. So it is very important that you remove the blood in the vitreous in the far periphery in the vitreous base area. Now, once you are done with the removal of the vitreous, then you proceed with your fluid exchange. Ensure hemostasis again at this step, and then consider laser for the areas which are away from the traction retinal detachment. Once your laser is complete, then you need to provide a tamponade that could either be gas in simple cases or it could be silicone oil in complex cases. Now, another case wherein you can see that there is a complex traction retinal detachment, and we are again segmenting it. Now, with the dominant hand, I am doing most of my maneuver, but here I'm finding it very difficult to segment it further. So you can always switch your hand. You can go to the non-dominant hand. And if you are a little ambidextrous, then your surgery becomes very easier. So here after changing your hand, you can segment it better. You can have a better approach to the dissection. Now I am resorted back again. I'm shifted back to the right hand. That can help you dissect these membranes easily without causing any iatrogenic breaks. Sometimes you are not able to find any cleavage plane, so it's a better that you choose the papillomacular bundle area and try to lift the hyaloid in that area with using a forceps, and then you get a cleavage plane because this area is it is not firmly adherent with the underlying retina, and you can lift the hyaloid in this area very easily. The conventionally what we cut is how do we approach these membranes is that we face the cutter tip toward the edge of the membrane, but then you can also have a flip or rollback cutting in which you place the cutter over the membrane and then the membrane curls into the cutter. So that way you are very away, you are far away from the retina and your iatrogenic breaks happen very less often. Coming to the bimanual surgeries, yes, bimanual surgeries make your life easier. And so with the chandelier in place, with your non-dominant hand, you can lift up the membranes and then sever the connection between this membrane and the underlying retina. And your surgery becomes quite easier with bimanual approach. Coming to the last, it's a case of rhegmatogenous retinal detachment occurring on top of tractional detachment, that it is a secondary rhegmatogenous retinal detachment. And you see a fibrous proliferation which is tightly adherent to the underlying retina. You're trying to manipulate. Now again, it's a bimanual dissection, but you're using a blunt instrument such as your endoilluminator itself to remove the fibrovascular proliferation from underlying retina, diathermize the base, and then segment it. Internal limiting membrane is not often required in majority of the diabetic retinal traction retinal detachments, but it can be considered if there is a rhegmatogenous retinal detachment and there is an obvious epiretinal membrane which is present at the starting of the surgery. So how do you achieve hemostasis in diabetic traction retinal detachments? Other than raising intraocular pressure and using endodiathermy, you can also use PFCL. PFCL acts not only as a tamponade, but it exerts pressure on the bleeders and it reduces the bleeding temporarily. You can also switch to fluid air exchange. A coagulum will form under the air quickly, and then you can resort to that managing that coagulum later on. And last, you can always wait for a couple of minutes. Most of the bleeders will stop bleeding on their own, and then you can tackle them later. So the key points that you should need to remember during dealing with any diabetic with the tractional retinal detachment, it is important that you have a very good systemic control, not only before surgery but after surgery as well. Preoperative anti-VEGF injection, and not only anti-VEGF injection, laser also helps in reducing the vascularity during vascularity of the tissues and helps in easy surgery. And proper identification of the posterior most hyaloid is important. If you leave this hyaloid behind, then and you have iatrogenic breaks, then redetachments are very likely to happen. Segmentation and delamination remain the core principles for clearing the traction, and it can be done unimanually or manually, as I've shown. And the prime objective, other than removing the traction, is to avoid any break, so that you can leave these eyes under air or even gas. And silicone oils are usually resorted to if there are breaks, or you cannot remove the traction completely, or depending on the patient and surgeon preference, it can also be chosen. Thank you.
Thank you so much, Dr. Devesh. Excellent surgical videos.
Very
And
nice.
very, very nice. I would like to invite Dr. Mitra to say a few words to sum up our sessions today. And
Why?
then
Why? Dr. Piyush Bansal? Dr. Piyush Bansal is not here.
Ma'am, two of our guest lecturers, I think, are not here today.
Okay.
So we will be concluding the session for this midterm JHOS. And Dr. Mitra, can you please say a few words to conclude? And then I would like to invite Dr. Malay to give the vote of
And
thanks.
Dr. Vibhuti Bhushan, are you here? Dr. Vibhuti Bhushan, are you here?
Yes, yes, I'm very much here.
So first,
Yeah, Dr. Vibhuti is here.
Dr. Vibhuti is here. So first, you say something because you are always off the line. So right now you are online. So first you say, and Dr. Mitra is always online. So he will say after you.
I was also always on the line. There was a period when we had a little bit of glitch.
In the meantime, we are calculating the result. The two judges did not judge. So we have two judges, and we are sending the mark sheet to the coordinator room.
It was really a fantastic Sunday that we had, full of academics. The innovators session was out of the world actually, and we are eagerly waiting for some of the innovations to come into the market so that we can use them and start using them. And the master's talk was also very, very enlightening, and there was a lot to learn for us who have been in the practice for last 20 years, almost 20 years, but still every day you learn, and you learn from the masters. There's so many good points to pick up, and very practical tips that we learned. And overall, it was a wonderful experience listening to, and especially the case presentations by the PGs were really excellent, and that shows
print करके लाइए.
That shows that how well they are being guided at their institutions by their seniors, by the faculty members. So I must thank Dr. Bharti for designing a wonderful scientific extravaganza that we had today. And that's all from my side. Excellent experience, excellent session.
So over to
Thanks.
Mitra.
Yeah. Thanks, everyone. Now, as we come to the end of today's part of JHOS Midterm Conference, I must first of all congratulate our PGs. They are exemplary. Their presentations are excellent. And as I feel proud to see that PGs are improving day by day in each coming conferences. And thanks to all their mentors, actually. Thanks all to their mentors.
Yes, is correct.
The first session, the hackathon, which was started by Dr. Bharti Kashyap herself by our
Then you were
CSC.
secretary.
Yeah, I was secretary, and kept us glued to the computer. And what a session to start with the conference today. What a session. The out of the box thinking by the innovators kept me thinking about their thinking. I was thinking about their thinking. Be it Moxie Glow, be it Blink Alarm, be it dots, be it the laser axis, every presentations were awesome.
Even the first year
we
resident
eagerly-
has in yes.
Yeah. We eagerly wait for the second part of the JHOS midterm conference. Thanks everyone, and proud to be associated with JHOS. Thank you. Thanks everyone.
And over to our treasurer, our secretary, Dr. Sujay Samanta is in USA, and he tried to join, but because of some network issue, he could not join. So he has sent a message to the group, and now vote of thanks will be given by our treasurer. But should we wait for the result, or should we do vote of thanks? Because What do you say, Dr. Malay?
I think we should wait for the result.
There are two evaluators, they did it. So I have sent the result. Dr. Rahul, you are there? Dr. Pritish?
Yes, madam, I'm here.
Okay, I'm sending the result to you. In the meantime,
Meanwhile, any other announcement you want to make? The CSC, madam.
So actually, we were doing the second part on 21st of September, but there is ISOC, they said, and we have to again reschedule it. And as you know that we started the international hero session in the midterm part 2, and this time we have invited Dr. Kamran Riaz from US. There's a half an hour session by Kamran Riaz, and he is also going to give very nice innovative talks. And his talks, he's a capillary practice surgeon, but his talks are for emulating all the general ophthalmologists also, like 5-fluorouracil neovascularization, cornea neovascularization, that a general ophthalmologist also can go for. And other thing is that I am also really surprised to see the standard of PGs. It is actually it is actually improved. Actually, our gadgets are also improved. They are showing nice pictures, nice videos. The base hospital where they are working, the hospitals have also improved technologically. Dr. Kashyap, I request you to ask the managers to give the print of the mark sheet kindly, because I am here.
I like the confident of the PGs, their body language, their body language is
body language.
Yeah,
it was
that is excellent.
They were just like consultants.
Yeah.
Just keep continuing. I am going to the coordinators hall.
Shall I announce the result, ma'am?
Yes.
Yeah, result has come.
Yes.
Surprisingly, we have 2 second winners.
Kya?
2 second winners and 2
जोर से बोलो,
third
जोर
winners.
से.
We have 1 winner, 2 second winner, and 2 third winners. Joint winners.
Joint winners.
Right. Joint winners, yeah.
The third prize goes to, one is Neha Chaudhary with 85 marks. And another is Dr. Payal Sarkar, third prize, joint winner.
Okay.
Congratulations.
And
तुमको अब 3 प्राइज के बदले you'll have to keep 5 prizes.
Now the second joint winner, one of them is Dr. Subham Singh and another is Dr. Irshad Khan.
Wow, congratulations.
One is Dr. Subham
Congrats.
Singh and another Dr. Irshad Khan.
Okay.
And the final winner of this session is Dr. Anamika Chaudhary.
Wow, congrats.
Congratulations.
Winner is Dr. Anamika Chaudhary. Joint second winner is Irshad and Subham. And third winner is Neha and Payal.
Okay. So institute this Irshad, Anamika Chaudhary is from Rio Rins. Irshad and Shubham are from Kashyap Memorial Eye Hospital, and the third winners, they are from which institute?
MGM, ma'am.
MGM.
Both
MGM. Jamshedpur.
अच्छा चलिए.
Jamshedpur, ma'am.
अच्छा कोई बात नहीं है. It's just a participation which matters. Result तो आना जाना है. Next year again they will participate.
So they are getting some memento and certificates in the annual conference?
Yes, we will. I am going to for a 1 week camp to a very remote area. After I come back, then we will prepare the certificates. And last year, Ajanta Pharma had given mementos to all the participants. So we will request them to give memento, but it will take 1 week. After 1 week, I will start the work because I am going for to Santhal Pargana, Sahibganj, Pakur, and Jamtara tomorrow itself. And my secretary is also going, my entire team is going, which is doing all these conference work. So
But I think all the PGs should get the certificate of presentations. All the PGs.
Of course, everyone will get trophy also. Last year, they said that everybody wants a small trophy. Everybody will get a trophy. First, second, third will get little bigger trophy. That's it.
Okay.
Last year we gave
Thank you.
trophy
Thank
to
you. Thank
everyone.
हेलो
Thank you.
TSC हेलो राशि
Yes.
बोल रही है, हम लोग कुछ नहीं मिलेगा, इतना मेहनत कर कुछ नहीं मिलेगा।
अरे राशि स्पॉन्सर करा देना हमको।
राशि कुछ नहीं बोल रही है।
तो इतना अच्छा होममेड फूड खिलाए, बताओ। अब ये देखो कि अब सुनील मेरे को हेल्प किया तो अजंता से हमने कराया।
Very nice, very well done, Dr. Bharti. Dr.
Nice.
Malay to kindly, please, Malay.
Yes, sir.
A vote of thanks हो जाए यार थोड़ा।
Yeah. I think that was a very fantastically arranged and fantastically run conference. Good afternoon. This brings us to the end of today's session. And I would like to thank all the innovators for sharing their fantastic ideations. And we are eagerly awaiting for them to be available in the market. And I would like to thank all the speakers for sharing their knowledge and giving us the tips. Thanks are also due to all the judges for their insightful questions and suggestions. I would like to thank all the chairpersons and session coordinators for running the show in time. And thanks are also due, as Dr. Mitra and everybody has pointed out, to the future of our societies, our PGs, who have fantastically presented the case presentations. And thanks are also due to their mentors. And thanking all the attendees for taking out time to attend the session on a Sunday. And last but not the least, I would like to thank Entod Pharmaceuticals for arranging the Zoom meet. Thank you. Thank you very much.
Thank you. Thank you very much.
Thank you. May I request all the members who are the members of the ROF, Ranchi Ophthalmic Forum, we are going to get our society registered. So I'll be sending my person for his signatures. Please keep your one passport size photograph, one copy of and one copy of Aadhaar card and one copy of PAN card. So they'll go and get it, get his signatures, and then they'll get all those photographs and Aadhaar card and PAN card. So all the members are of ROF.
Thank you. Thank you all.
There are some important announcement. The coordinators are It seems that the decision was given on the marks of one judge. The other judge's mark is getting added up. So I think there'll be some kind of a correction. चलता नहीं ये वाला सोचती है बताओ क्या बताओ देखो भाई दो दो आप देख लो कोई चश्मा नहीं
There is a little bit of correction in the result of the free papers.
Shubham Singh.
Third is Dr. Shubham Singh. Third prize goes to Shubham.
Second is Irshad.
Second is Dr. Rishad Khan.
And first is, as advised, Anamika Chaudhary.
Anamika Chaudhary remains the first. So this is a little correction. We are sorry in our part. थोड़ा जल्दीबाजी के चक्कर में थोड़ा सा we are sorry.
का दिया गया था.
हाँ. ठीक.
Dr. Bhati, do we conclude? You are muted, ma'am. I can't hear you.
Hello. Yeah.
So am I audible now?
Loud and clear, ma'am.
Yes, I am very, very thankful to Entod. They help us a lot in our online activities and especially on Sunday, because I heard that on Sunday you people were giving very tough time to some other state society, but you did not give us tough time. Thank you so much. And we took a lot of your time, late evening when your office was closed, lot of correction. So thank you. Thank you so much. Thank you.